Test. Voilà, c'est bon. Merci beaucoup. Sbahir, bonjour et good morning. Donc j'ai l'honneur aujourd'hui de présider cette séance. Elle est session en anglais, in English, et on propose qu'elle soit en anglais et en français. Puisque nous avons la séance, c'est le ventricule de droit, l'état de l'art, l'insuffisance ventriculaire droite, the right ventricle failure, the state of art. J'ai l'honneur d'avoir avec moi comme modérateur Madame Sonskrein, chef de service de cardiologie à l'hôpital Habib Femer de CHU de Tunis, et professeur Drissa Marine, agrégé, vous êtes à l'hôpital Mongislim de la Marsa, et un grand honneur d'avoir le professeur Sharfuddin حسام حسن من رئيس قسم القلب بمستشفى أسيوط, chef de service de cardiologie à l'hôpital Assiout du Caire, Qahira, Masr. Donc tout l'honneur est pour moi comme anesthésiste réanimateur, avec le professeur Skander Maza, notre expert international en anesthésie et réanimation, insuffisance cardiaque, et qui publie toujours. C'est un honneur de l'avoir comme ami depuis plus de 30 ans maintenant. Nous restons les amis des cardiologues, puisqu'on travaille ensemble sur plusieurs thèmes. Je félicite la Société de cardiologie, tous les membres du comité d'organisation, le bureau de la Société de cardiologie, pour avoir réuni un nombre important d'experts des pays africains, européens, des États-Unis, pour la qualité des thèmes, des séances, le haut niveau scientifique. Et je souhaite longue vie à la Société de cardiologie et qu'elle reste ouverte sur toutes les autres spécialités comme elle a été pendant toujours avec tous les past présidents de la Société de cardiologie. Sans trop tarder, je vais donner la parole au professeur Hussam Hassan pour présenter la première conférence. Donc notre session va durer 1 heure, 8h30, 9h30. Je vous propose qu'on passe les conférences et on laisse la discussion à la fin, puisque c'est le même thème qui se rejoint pendant les différentes conférences. Tfadhal, professeur.
Thank you very much. I'm honored to present the first presenter today, Dr. Torgen from Canada. He will speak about imaging and profiling in right ventricular failure intravenous drugs.
Okay, so good morning, everybody. I'm Pierre-Yves Turgeon, French-Canadian, and I'm now working in the Nantes for a fellowship. So it's a pleasure to be with you and opening this session this morning. I have no conflict of interest. So I will speak about imaging in RV failure. And so just a basic anatomy recall. It's a structure that is just behind the sternum, is the most anterior cardiac structure in the thorax, and is as a croissant or N triangular shape that you need to consider because it's a complex geometry. There's 3 main components of the RV: the inlet, the body, and the outlet. And we need to know that inlet and body generates the majority of RV stroke volume. There's also 2 layers of muscular fibers, the superficial ones that runs circumferential, and the subendocardial that runs longitudinal. There's also 3 distinct mechanisms of contraction. The first one is the longitudinal fibers that draws the tricuspid annulus towards the apex. The second one is the circumferential fibers that move the free wall towards the septum. And the last one, but not the least, there's also a traction of the free wall by the LV-RV continuity, and it generates a significant amount of the contraction. So in normal loading condition, with normal preload and afterload, the RV stroke volume depends mainly on longitudinal contraction. In case of abnormal condition, the RV stroke volume depends less on longitudinal, but really more on radial and circumferential contraction. So there's a lot of etiologies. You can separate it in pressure or volume overload or cardiomyopathy. But I prefer to remind it by mechanism, so you can see this great review by Arrigo that explains the place of all those mechanisms. So the first one is the abnormal preload. You need to know that RV is very tolerant to preload, so it has a greater distension capacity than LV. So at the same pressure, there's a lot more volume in the RV than in the LV. And as I said, for RV contractility, up to 40% of the contractile force of the RV depends on the LV contraction. Also, for the afterload, so in pulmonary hypertension, for example, we need to know that RV is very afterload sensitive. So just a slight increase in afterload results in a dramatic decrease of the stroke volume. There's also altered interdependence that leads to LV compression in case of RV volume overload. And you can see on the echo with the flattened septum. And also an important subject of study in the last years is the RV-PA coupling. That is a relationship between the end systolic elastance, so it's an index, almost load independent index of the RV contractility, and the total RV arterial load that is represented by two slopes. And the ratio between those two slopes determine normal versus normal coupling versus pathologic uncoupling. So the normal ratio of EES on EA is about over 1.5, and in uncoupling you move the slope to the right, and it results in it represents diminished RV contractility, and it leads to a diminished ratio. So imaging the right ventricle, I will focus on the transthoracic echo, but I cannot not talk about cardiac magnetic resonance because it's still the gold standard for non-invasive assessment of anatomy, function, and tissue characterization. You can also use cardiac CT, but it's a lot of radiation, and it compared to the CMR, it overestimates the volume and RVEF. You can also use nuclear imaging. It has a good diagnostic accuracy for global and regional RV function. But always remember that for right ventricle particularly, you need to repeat those exams. So TTE is the more important because all those imaging, even if advanced, are load dependent. So let's go back to basic TTE. So it's still the imaging modality of choice. There's limitation to know, but you can always use multiple acquisition views. Don't hesitate to be atypical towards the axilla or sternum, and always use multiparametric evaluation. You need to have a good apical four-chamber to start with the full RV opening, so in the green line. And after that, you can move towards the axilla to have the RV focus apical four-chamber, or you can move toward the septum to have a modified one. Those are very useful. And in case of pulmonary pathologies, for example, the subcostal view is a very go-to also. You need to be sure that the axis is okay, not too posterior or too anterior. But so if you see coronary sinus, you're too posterior. So we can do all types of measures. I will skip rapidly on that, but you can do linear dimensions, areas, and full RV volumes. The normal values, you can find them in the guidelines. So for the morphology, we can quantify the D shape by the eccentricity index, and we can quantify the dilatation with the RV-LV ratio. So how to evaluate? As I said, it's a multiparametric evaluation. Even if the ESC guidelines recommend CMR as the preferred method, we should start always with the TTE. And we can do a lot of parameters. It takes times, precision, and passion. So the limitation to know is that the substernal position in this is very superficial, so it has a bad resolution. There's a lot of trabeculation. It's easier to evaluate the longitudinal function, but in case of abnormal preload, as I said, you need to evaluate radial and circumferential function, so it's more difficult. And you need to always remember what is the loading condition of your patient. Does he have pulmonary hypertension or TR? So you all know all those parameters, but some evaluate longitudinal and others global function. So I will pass pretty rapidly on this. Just very important, eyeballing is not a good method of evaluation, because in this patient, for example, you can say that it's normal, but if I show this, there's a torrential TR that leads to abnormal afterload condition. So you can use the TAPC, as you all know. I just wanted to stress the proper alignment is very important. So the MO need to pass by the apex towards the tricuspid lateral annulus. It's reproducible if you do it like this. It's easy to use, but it's angle and load dependent and only evaluate longitudinal function. You can do the S-wave also. It's the same pros and cons as the TAPC. And you can also do a more global evaluation by the fractional area change, and it integrates the radial function in the equation. But it's pretty difficult because all of the trabeculation, and there's a higher inter-reader variability. So I just wanted to stress that it's important to do a RV focus view for the fact, because when you do it like this, there's a very good correlation with the CMR for RVEF and volumes. You can also use the TIE index. It's a global evaluation that integrates the systolic and diastolic function. To understand this formula, you have to say that the performant RV has a longer ejection time relative to the old systole. So there's a lot of formula. I prefer the one on the left with the TDI, so the tissue Doppler imaging. It's the best and easiest method because you can do this on a single beat. And on the pulse wave at the right, you need RR interval matching, so it's unreliable in the irregular heartbeat, as I said. So for the RV strain, sorry, so you need to integrate it in clinical practice now, because it has a very good values. So you need to do this on RV focus apical views, and the normal are minus 23 to 20%. So it's pretty easy nowadays. I just want to stress that it's vendor independent, so there are normal values that are published, but you need to know with which machine they work. And lastly, I just want to show you some 3D images. The great advantage is that it includes an outflow track, and there's a good correlation with CMR, but it's time consuming despite the artificial intelligence. Maybe it's going to be better in the next years. And you have the abnormality. I will not talk about this because I don't do it in clinical practice. And I think someone will talk about this, but it's very important to evaluate the preload with the inferior vena cava, the hepatic veins. The afterload with pulmonary pressure is very important. With the Vmax, it's not perfect, but you can trace the mean gradient, for example, and even calculate the resistance. So I will skip this part. So in the future, what we have non-invasive pressure loops evaluation, or the myocardial work. We can quantify 3-axis quantification of 3D shortening, and maybe AI-based or machine learning 3D echo software will increase in quality and save us time and do a more complete evaluation. So in conclusion, sorry for the time, you need to be systematic, it's complex, you need to know the strengths and weaknesses of every parameter. Always integrate the preload and afterload condition in your analysis. At least include 2 quantitative parameters and be careful about the visual evaluation. Strain for all, in my opinion, it's not hard to do, and it's even easier in the recent years with the automated calculation. We need to integrate RVPA coupling. And are we ready for 3D RVEF? I don't think so, but let's practice. And if it's going to be easier in the future, we're going to be ready. So thanks for your attention.
Thank you very much for this good presentation. I'm very happy to moderate this session about right ventricle. And I want to call Monsieur Abdelhamid from Magdi Abdelhamid from Egypt to talk about chronic right ventricle failure management.
Good morning, everybody.
10 minutes.
Okay, thank you so much, Mr. Chairman, for the kind invitation. Good morning, everybody. First of all, I'd like to congratulate the board members of the Tunisian Cardiac Society for a successful meeting, and thanks for the kind invitation. In a couple of minutes, I'm going to talk about chronic right ventricular failure management, which is a challenging topic. This is my disclosure. And this slide shows the 3D reconstruction image of the challenging chamber of the heart, the right ventricle. On the left, the normal, and after RV pressure or volume overload and RV remodeling, structural and remodeling changes will lead to the abnormal shape of RV and develop right side heart failure. This slide summarizes the different causes and the pathophysiology of RV failure. We know that the most common cause of right ventricular failure is secondary to left side heart failure. So if you look for that, the main determinants of the RV function, preload, afterload, contractility, and relaxation. So an excess preload due to left side heart failure, tricuspid regurgitation, different causes, and the same for increased afterload due to pulmonary embolism and other causes which was mentioned in the first presentation, and decreased RV contractility due to myocardial infarction, RV infarction, for example, myocarditis in patients with LVAD, post-cappage, and patients with who develop decreased or impaired relaxation due to infiltrative disease, myocardial fibrosis, and different causes. So all these abnormalities will lead to increased preload, systemic congestion, increased afterload, decrease the stroke volume and the cardiac output, the phenomena and the mechanism of impaired LV function due to the ventricular interdependence and shift of the septum left side with decreased LV preload, decreased cardiac output. So these cascades will end in development of this picture of the systemic venous congestion. Patients coming with systemic venous congestion and clinical evaluation, you can see lower limb edema, high venous pressure, hepatomegaly, ascites, in addition to symptoms of fatigue and other symptoms suggestive of right side failure. And you have to evaluate for left side heart disease, commonly seen patients with valvular heart disease, coronary artery disease, and other causes. So patients maybe in history have history suggestive of arrhythmogenic right ventricular cardiomyopathy with history of sudden cardiac death. The diagnostic findings was mentioned in the previous presentation, specifically echo, but we have to do an electrocardiogram, we have to do chest x-ray, we have to do CMR is a gold standard as mentioned. So we have different investigations which should be done to assess for RV failure. And right side heart cath sometimes needed, especially in patients who have pulmonary hypertension, you need to know whether this is pre-capillary or post-capillary pulmonary hypertension. And some measurements are important not only for diagnosis, but also for prognosis. CT pulmonary angio, if you need to rule out pulmonary embolism, laboratory biomarkers, PNB will be high, of course, and abnormal liver function, abnormal renal function, and the high level of D-dimer in pulmonary embolism. This slide is very interesting in a study which involved 1,300 patients correlating different stages of right heart failure with the prognosis. So if you look for stage 1 patients at risk of right heart failure, still RV function is normal, the prognosis is good. However, if you look for stage 4 patients with RV dysfunction, refractory signs, symptoms of heart failure, look to the right, you can see that the cumulative survival is much lower in patients who have stage 3 and 4 compared with stage 1. So how to manage those patients? In the absence of acute RV failure, which will be mentioned by Professor Mubaza in the next presentation, look for the right. Patients, you need to optimize the fluid status, and in the presence of congestion, of course, the standard treatment is diuretics to relieve systemic venous congestion. So diuretics have a limited efficacy with time due to the development of diuretic resistance. And if we go to the guideline-directed medical therapy for left side heart failure, you can see that neurohormonal antagonists are not tolerated in those patients due to hypotension, due to renal failure, and due to malabsorption. So we don't have an evidence for drugs which are effective in treatment of right side heart failure, except treatment for congestion by the use of diuretics. And this slide summarizes the treatment of right ventricular failure. Look for how to decrease preload with the use of loop diuretics, and sometimes with the development of diuretic resistance, you need to give a diuretics to induce a sequential nephron blockade with the use of thiazide diuretics. And in resistant cases, you might need ultrafiltration to remove some fluids. And the atrial septostomy is sometimes needed as a palliation for severe pulmonary hypertension. If you look for afterload reduction, which is seen in patients with pulmonary hypertension, so pulmonary arterial hypertension should be subjected for vasoreactivity tests to rule out patients who are not will be treated well with the CCB, calcium channel blockers. So the presence of positive vasoreactivity tests is an indication for CCP. Inhaled vasodilators like nitric oxide and prostacyclin analogs in patients for acute right ventricular failure or cardiogenic shock due to right ventricular failure. And we have endothelin receptor antagonists like bosentan, ambrisentan, prostacyclin analogs, epoprostenol, treprostinil, and the phosphodiesterase 5 inhibitors, sildenafil, tadalafil, soluble guanylate cyclase, a stimulator like riociguat. So those are treatment for pulmonary arterial hypertension. And in patients who have right ventricular failure, complicated by cardiogenic shock, malperfusion, hypotension, you need to give a beta agonist, beta-1 agonist like dobutamine, dopamine, and milrinone, which is a phosphodiesterase 3 inhibitor. You might need vasopressors like epinephrine or epinephrine. Digoxin may reduce symptoms in patients with chronic right ventricular failure. So treatment of RV failure in patients with pulmonary hypertension, you need to decrease preload, you need to improve RV contractility, you need to prevent RV ischemia, and decrease afterload in the pulmonary vasculature. So tricuspid regurgitation is commonly seen in patients with right heart failure due to dilatation of the annulus, due to tethering of the leaflets. So in the presence of left side heart disease, so in the presence of severe tricuspid regurgitation, those patients should be subjected for tricuspid valvular repair or replacement during left side valvular surgery. In patients who have mild to moderate tricuspid regurgitation, if the tricuspid annulus is dilated, also same, those patients should be subjected to tricuspid valve repair or replacement. If there is left side heart disease and severe primary tricuspid regurgitation symptomatic, those patients also should be subjected to tricuspid valve repair or replacement. So a heart team approach is important to identify patients who are at high risk for tricuspid valve surgery, and those patients can be referred to do a transcatheter tricuspid valve repair or replacement. In advanced cases of RV-LV dysfunction with pulmonary hypertension, of course, the mortality will be high, so medical treatment only is indicated. So this slide summarizes the different the landscape for surgical as well as transcatheter tricuspid valve management, suture annuloplasty, ring annuloplasty, coaptation enhancement, replacement, and nowadays we have the approach of doing transcatheter tricuspid valve repair using MitraClip, for example, and we have different designs for tricuspid valve implantation, replacement, as you can see here in this slide. And you can assess the risk of those patients using this TRI-score, a very nice score which differentiates patients according to the risk. If they are subjected to isolated tricuspid valve surgery, a risk than 3 carry a low surgical risk, above 6 indicate high surgical risk. So using an age, NIHA function class, right side heart failure signs, doses of diuretics, GFR, bilirubin, ejection fraction, and RV dysfunction can identify the prognosis of those patients. And you can appreciate here in a study which involved 2,400 patients comparing conservative treatment with tricuspid valve catheter treatment, and you can appreciate that the outcome of patients who had a lower score was better compared with patients who have a high score. Again, transcatheter approach is better than conservative management. However, the predictors of poor outcome in transcatheter tricuspid valve implantation, according to this interesting paper, the precapillary pulmonary hypertension, a discordance between right side cath measurements and echo, massive and torrential tricuspid regurgitation, severe RV dysfunction, and organ damage. So the prognosis in patients who were subjected to transcatheter approach was better than conservative approach. Finally, patients who have atrial fibrillation, if we did a reversion to venous rhythm, this can lead to decrease in tricuspid and mitral regurgitation, and you can appreciate here in this paper that active restoration of sinus rhythm will lead to reverse remodeling, and this will lead to decreased tricuspid regurgitation and prevention of atrial and ventricular cardiomyopathy. So, ladies and gentlemen, the take-home message: the presence of RV dysfunction, independent of the etiology, is associated with increased mortality. Achieving evolemia and treating the underlying disorder are key to the management of right side heart failure. Medical therapy of right side heart failure is based on diuretics drugs. But in the presence of tricuspid regurgitation, there is an increased risk of residual congestion and diuretic resistance. Transcatheter tricuspid valve approach for repair or replacement are new tools for treating patients with right side heart failure and isolated secondary TR. Earlier recognition and the intervention for management of right side heart failure before point of no return is highly recommended. Thank you for your attention.
Thank you, Professor Magdi, for this excellent presentation. Then we move to the next presentation. With pleasure, I call Professor Mbaza. He will talk about
acute right ventricular failure.
Acute right ventricular failure management.
Bon, since our Minister and General Fergeni asked me to do the lecture in French, I will do it in French, and the slides will be in English. Then I guess it will be very easy to follow. Here are the main messages, and in the next slides, I'm going just to confirm what I've said here. Right ventricular failure is really frequent, rarely isolated, and there are often biventricular dysfunction. And maybe the next part of the slide is so important. The only thing to remember as a cardiologist and as intensivist is we should avoid any excess fluid in right ventricular failure. This is a major problem because in many textbooks until today, it's written acute myocardial infarction, you should to give volume loading. This is a big mistake, and you kill your patient by giving excess fluids, and I will show you data in a minute. What is the role of the right ventricle? We heard already many things, but the right ventricle function is to keep right atrial pressure as low as possible to optimize the venous return. J'avais dit que je ferais en français, là je suis en anglais en fait. Le ventricule gauche, en revanche, il est là pour générer de la pression. Donc vous voyez que le ventricule droit, lui, c'est le débit, il va aspirer le sang de la périphérie, alors que le ventricule gauche, il va générer de la pression. Donc le ventricule droit, il va générer du débit. Et comment il va générer du débit? Parce qu'on a une chance extraordinaire, c'est que les résistances pulmonaires sont très 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 faibles, quasiment de zéro. Donc tout ce que le ventricule droit va générer comme débit va traverser le poumon sans aucune difficulté. Et ça va être génial. Cette diapo est un peu compliquée, mais elle est vraiment très très importante. En haut, on a le volume du ventricule. Le ventricule gauche, le sang va vers l'aorte uniquement en systole. Hein, c'est tout ce qu'on a appris. Le ventricule droit, c'est différent. Le sang coule du ventricule droit vers l'artère pulmonaire quasiment pendant tout le cycle cardiaque. Et peu de gens savent que pendant la diastole, il y a encore du sang qui coule du ventricule droit vers l'artère pulmonaire. Et ça, c'est très important à retenir. L'autre chose à retenir pour tous les jeunes, le ventricule gauche, sa perfusion coronaire, comme vous pouvez le voir sur la droite, c'est uniquement la diastole, alors que le ventricule droit, c'est pendant la systole et la diastole. En revanche, chez les malades qui ont une hypertension artérielle pulmonaire en haut, vous voyez que le ventricule droit n'est perfusé que pendant la diastole. Donc si vous ne maintenez pas une pression artérielle diastonique, ce ventricule droit ne va pas fonctionner correctement. C'est ce qu'on a expliqué ici dans cet article, c'est que vous voyez que sur la gauche, le ventricule droit normal, vous voyez que la veine cave bouge, vous voyez que la pression auriculaire droite, elle est de 0 à 5, vous voyez qu'il y a une contractilité qui marche bien. Maintenant, allons complètement à droite, le C. Regardez le C, vous avez la veine cave inférieure qui est dilatée, la pression auriculaire droite qui augmente et le TAPSI qui est diminué. Et surtout, je vais vous parler de quelque chose qui s'appelle TR, tricuspid regurgitation, l'insuffisance tricuspide, auquel on ne fait pas assez attention, et je vais vous montrer dans un instant comme cette insuffisance tricuspide, elle peut être très délétère. Tout à l'heure, on va parler de l'insuffisance rénale qui suit l'insuffisance ventriculaire droite et qui est beaucoup liée à l'augmentation de pression. Juste mentionner cet article-là, on va regarder en bas à droite, vous voyez right atrial pressure, pression auriculaire droite sur créatinine. Vous voyez qu'il y a une relation directe entre la pression auriculaire droite, entre la congestion et l'altération de la fonction rénale, mais on va en entendre parler beaucoup plus. Le foie, je voudrais m'arrêter 2 secondes sur le foie, parce qu'on ne fait pas assez attention. C'est une des raisons de la mort des malades qui ont une insuffisance cardiaque. Cet exemple-là, c'est une personne qui arrive avec une grosse insuffisance tricuspide. Regardez ici, le sang, quand vous regardez les veines sus-hépatiques, la veine cave inférieure, le sang normalement coule du foie vers la veine cave inférieure, vers l'oreillette droite. Et regardez ici la surprise, regardez ce malade-là, à cause de l'insuffisance tricuspide, à chaque systole, le sang remonte dans le foie et en fait, il bloque la circulation. Donc à chaque fois que vous avez un malade qui a une insuffisance tricuspide qui est très très importante, le sang ne circule pas dans le foie pendant toute la systole et ça donne des grosses catastrophes. Comment on va gérer ces malades? Pour les jeunes résidents, les fellows, je vous conseille d'aller sur cet article parce qu'on a mis 12 cas cliniques d'insuffisance cardiaque droite et on a montré les échos. Donc vous allez avoir des échos, des vidéos, même 3D, des insuffisances ventriculaires droites. Et comme ça, vous pourrez vous entraîner. Alors, l'insuffisance ventriculaire droite, parfois elle arrive sans que vous l'attendiez. Ça, c'est un sujet de 30 ans qui a eu un accident. Au 5e jour, il est allé au bloc opératoire pour que le chirurgien orthopédiste traite ce patient-là. Et tout d'un coup, à peine début de l'anesthésie, tout d'un coup, ce malade fait une hypotension artérielle. Et ce qui est intéressant, c'est que quand vous avez un malade qui, aux soins intensifs de cardio, en cardiologie, fait de l'hypotension artérielle, qu'est-ce que vous allez faire? Vous allez faire un tout petit peu de volume loading. Vous allez donner 250 millilitres en 5 minutes tout doucement. Et là, surprise, et c'est là où il ne faut pas tomber dans le piège, la pression artérielle ne s'améliore pas. Et là, il faut se dire, c'est pas normal. Moi, Alexandre Mebaza, vous mettez 250 millilitres en 5 minutes, ma pression artérielle bouge et mon débit cardiaque bouge. On met de la noradrénaline et surtout, là, très vite, on fait une échocardiographie. Et qu'est-ce qu'on va voir? Pourquoi ce malade fait de l'hypotension artérielle? En fait, il avait déjà Alors j'espère que mes échos vont marcher. Regardez, et ça c'est vraiment des choses qu'il faut montrer à vos étudiants en médecine. C'est très très simple. Regardez en haut à gauche, vous voyez que le ventricule droit est beaucoup plus large que le ventricule gauche. Ça y est, il n'y a rien besoin de faire de plus. Là, en urgence, on voit qu'il y a un problème. Et regardez, c'est ce que je vous montrais au milieu. En plus, il y a l'apparition d'une insuffisance tricuspide qui, comme j'espère vous avoir convaincu tout à l'heure, est très délétère pour le foie et pour le rein. On emmène vite le malade au CT scan. Évidemment, il avait plein d'embolies pulmonaires qu'il avait développées au cours des 5 derniers jours. Et je voudrais vous signaler que ça, c'est vraiment quelque chose qu'il faut beaucoup utiliser. C'est qu'aujourd'hui, le scanner thoracique permet déjà de voir, regardez le ventricule droit, qui est beaucoup plus large que le ventricule gauche. Donc vous voyez, le malade arrive, il va au scan. N'hésitez pas à regarder ces images-là. Et du coup, ça va vous pousser à faire une échocardiographie. Alors après, ça devient beaucoup plus simple. On a cherché la cause. Regardez, on appuie. Vous voyez que là, à gauche, la veine fémorale, elle est compressible. Donc pas de problème. En revanche, regardez de l'autre côté, regardez au milieu, ben, la veine n'est pas compressible. Vous voyez qu'elle reste toujours la même taille. Donc il y a bien, effectivement, un thrombus. Donc le message très important, et vraiment, je vous invite à lire cette revue générale qui est vraiment exceptionnelle parce qu'elle vous dit aujourd'hui ce qu'il faut faire quand vous avez un malade avec une insuffisance ventriculaire droite aiguë. Step 1, step 2, c'est je regarde la sévérité de l'insuffisance cardiaque droite et je détecte quelle est la cause. Hein, c'est ce qu'on a fait chez le jeune homme de 30 ans. C'est qu'est-ce qui s'est passé et pourquoi ça s'est passé. L'autre point très important, regardez ici, step 3, 4 et 5, pour la première fois au monde, on a dit l'insuffisance cardiaque droite aiguë. Il faut, faire très attention au volume. Regardez, c'est marqué noir sur blanc. Faire très, très attention à ne pas donner de volume, à minimiser les volumes et surtout pas remplir ce malade-là. Et pour la première fois, step 4, on a dit, quand vous avez un malade où vous suspectez l'insuffisance cardiaque droite, ne pas mettre de volume, mais mettre immédiatement de la noradrénaline. Et en fait, les malades ont très peu besoin d'inotropes, ils ont beaucoup besoin de noradrénaline. Pourquoi? Ici, vous avez en haut un foie, par exemple, la boîte grise, qui est perfusée, c'est le gradient entre l'artère et la veine. Quand un malade a une embolie pulmonaire, la pression veineuse augmente et donc, du coup, le gradient est diminué. Et le seul moyen d'y arriver pour maintenir la pression, c'est de monter très, très vite la noradré pour récupérer une pression artérielle et reperfuser ce malheureux foie. Alors, les insuffisances cardiaque droite, il y en a beaucoup. Ça, c'est un malade qui est venu avec une grosse hypotension artérielle, un camionneur qui arrive aux urgences. On nous appelle, on met l'appareil à écho et là, le diagnostic est clair. Regardez ces veines sus-hépatiques, comme elles sont hyper dilatées. En fait, c'était une péricardite constrictive. Vous voyez ce ventricule droit et surtout ce septum qui ne bouge quasiment plus. Donc là aussi, il ne faut pas remplir ce malade-là, il ne faut pas lui donner du volume. Et en cas d'hypotension artérielle, il faut donner de la noradrénaline. Donc vraiment, c'est un message à retenir, c'est il ne faut pas donner d'excès de fluide, même pas donner de fluide du tout. Quand nos infarctus du myocarde droit prédominants viennent dans nos soins intensifs de cardio, on arrête toutes les perfusions et il n'y a quasiment plus que des seringues électriques, un peu de noradré s'il faut pour maintenir la pression artérielle le temps que tout passe. Donc voilà les messages principaux. L'insuffisance ventriculaire droite est rarement isolée, c'est du biventriculaire. Je vous en supplie, retenez ce message. Quand vous avez un infarctus du ventricule droit, ne pas donner de fluide, au contraire, juste des seringues électriques, pas de perfusion et donner de la noradrénaline le plus tôt possible si le malade en a besoin. Voilà, merci beaucoup.
On va finir avec le professeur Esnold de France qui va nous présenter la conférence Cardio-Renal Syndrome de Key Messages.
Bonjour à tous. Alors, on m'a demandé de faire ce topo en français. Voilà mes liens d'intérêt en fait avec tous les médicaments de l'assistance cardiaque, comme tous les experts. Alors, je vais me concentrer sur 2 points, la physiologie et la prévention du syndrome cardio-rénal de type 1. je crois que tout est dit sur cette diapositive. Quand on recherche les déterminants du syndrome cardio-rénal, vous prenez une population de patients qui a une insuffisance cardiaque à fraction d'éjection réduite aux soins intensifs, et vous regardez qui va faire une insuffisance rénale aiguë de stade 1, c'est-à-dire une augmentation de la créatinine d'au moins 0,3 mg par décilitre de créatinine. Et vous voyez cette très belle relation avec la pression veineuse centrale. Plus la pression veineuse centrale est élevée, plus vous augmentez votre risque de faire une insuffisance rénale aiguë. Alors qu'il n'y a aucune relation avec le débit cardiaque, la pression artérielle systolique et les pressions capillaires pulmonaires. Alors si on revient à la physiologie vraiment de base, voilà, qu'est-ce qu'il a fait M. Starling? Vous prenez un sarcomère, vous tirez dessus, ça augmente sa force de contraction jusqu'à un certain seuil, et après, la contraction commence à s'effondrer. Et si on traduit ça en physiologie cardiaque, vous optimisez le remplissage télédiastolique de votre ventricule gauche et vous augmentez bien sûr votre volume d'éjection systolique jusqu'à un certain seuil, et après, l'éjection s'effondre. Et donc, le cœur a besoin de fonctionner dans une fourchette extrêmement étroite de volume optimal, parce que l'hypervolémie va très rapidement aboutir à des catastrophes. Alors maintenant, si on parle de pression de perfusion rénale, de façon très schématique, vous voyez que la pression de perfusion rénale part de la pression artérielle, dans l'artère rénale. Cette pression baisse dans l'artériole afférente, le glomérule, l'artériole efférente, les capillaires péritubulaires, jusque dans la veine rénale. Et donc, cette différence de pression entre l'artère et la veine rénale, c'est la pression de perfusion efficace, et c'est ce qui fait le flux sanguin rénal. Alors maintenant, si votre patient est congestif, il y a une petite diminution de pression artérielle, mais surtout une très importante augmentation de la pression veineuse rénale, c'est la pression en fait veineuse centrale, et maintenant la différence de pression entre l'artère et la veine est beaucoup plus faible, et ça explique une diminution du flux sanguin rénal. Et donc, qu'est-ce qui se passe en réponse à cette diminution du flux sanguin rénal? Vous savez tous que vous allez stimuler la rénine, le système rénine-angiotensine-aldostérone, donc vous stimulez l'aldostérone et vous favorisez la rétention de sodium au niveau du tubule distal. Ce que vous savez moins, c'est qu'il y a aussi une réaction aiguë, ce qu'on appelle le réflexe glomérulotubulaire, qui favorise une réabsorption sodée proximale. Et donc, vous n'êtes pas surpris que tous vos médicaments favoris d'insuffisance cardiaque agissent, tous ces sont des diurétiques qui agissent soit sur la réabsorption proximale, soit sur la réabsorption distale. Vous savez que les inhibiteurs du SGLT2 agissent sur la réabsorption proximale, les anti-aldostérones sur la réabsorption distale, mais vous savez aussi que le sacubitril, par l'augmentation du taux de BNP, aura un effet natriurétique essentiellement proximal, mais aussi un petit peu distal. Et donc, on comprend mieux maintenant pourquoi les inhibiteurs du SGLT2 sont si efficaces pour prévenir les poussées de congestion. Vous voyez que dans ces deux études d'insuffisance cardiaque à fraction d'éjection réduite, quand vous avez en haut et à droite un odds ratio à 0,7, ça veut dire que vous avez 30% de réduction du risque de poussée de congestion, ici avec la DAPA, et vous voyez exactement le même 30% de réduction de risque avec l'AMPAD en pro-reduced. Alors comme à chaque fois dans la préservée, le bénéfice est un petit peu plus faible, mais tout de même, vous voyez, une diminution de l'ordre d'environ 20% du risque d'hospitalisation pour congestion ou de mort cardiovasculaire. Pour le sacubitril, c'est pareil, vous avez donc un bénéfice qui est d'ailleurs essentiellement sur la congestion, parce que quand vous voyez le critère principal combiné mort cardiovasculaire et hospitalisation pour poussée de congestion, vous réalisez qu'en fait, pour la mort cardiovasculaire, le bénéfice est un petit peu plus faible, et donc bon, c'est porté beaucoup par les poussées de congestion. Dans la préservée, comme d'habitude, le bénéfice est un petit peu plus faible et il est au seuil de la signification statistique, mais donc on considère quand même, toutes les recommandations considèrent que one size fits all, de toute façon les 4 fantastiques, dont 3 diurétiques, sont utiles, quelle que soit la fraction d'éjection. Alors tout de même, il faut réaliser que dans toutes ces études dont je viens de parler avec le sacubitril valsartan, il y avait très très peu de patients qui recevaient des inhibiteurs de SGLT2. Et donc, on peut se dire, bah, écoutez, est-ce que c'est si vrai que ça qu'il faut utiliser deux diurétiques qui agissent à peu près au même endroit, au niveau du tubule proximal? Est-ce que ce n'est pas un petit peu trop de diurétiques? Alors, la réponse est non, puisque vous avez ici, dans ces études de sous-groupe, tiré des études dans l'insuffisance cardiaque à fraction d'éjection réduite, vous avez ici exactement le même odd ratio, que vous ayez ou pas des harnais, hein, du sacubitril/valsartan, aussi bien ici dans l'étude, le pointeur ne marche pas très bien, mais aussi bien en haut avec l'ADAPA qu'en bas avec l'empagliflozin. Donc le bénéfice des inhibiteurs du HLT2 et des ARNI, du sacubitril/valsartan, ces bénéfices sont indépendants et s'ajoutent, s'additionnent, donc il faut bien sûr prescrire les deux. Alors ça fait quand même beaucoup de diurétiques, tout ça, puisque les antagonistes des récepteurs des minéralocorticoïdes, les MRI, les anti-aldostérone, c'est aussi des diurétiques. Donc est-ce que c'est si prudent que ça de donner un inhibiteur du HLT2 qui agit en proximal et un anti-aldostérone qui agit en distal? Eh bien à nouveau, la réponse est oui, puisque dans les études de sous-groupe, vous voyez à nouveau que le bénéfice est exactement le même que les patients prennent ou pas un anti-aldostérone. L'effet se surajoute, hein, avec les inhibiteurs du HLT2. Alors, je voudrais juste vous expliquer pourquoi c'est si important d'avoir un anti-aldostérone, un inhibiteur des récepteurs des minéralocorticoïdes, et vous introduire avec ce concept d'aldostérone breakthrough, l'échappement d'aldostérone. Alors ça, c'est un de nos vieux papiers qui date déjà depuis plus de 10 ans. Alors c'est une grande étude internationale où on a randomisé des diabétiques de type 2 pour recevoir du losartan ou du telmisartan pendant 1 an. Et au bout d'1 an, 28%, plus d'un quart de ces patients présentent cet échappement de l'aldostérone. Alors c'est quoi l'échappement de l'aldostérone? C'est le fait que vous débutez ici un ARA2, mais c'est pareil avec les IEC, hein, les inhibiteurs d'enzymes de conversion. Vous débutez un monoblocage du système rénine-angiotensine-aldostérone par un IEC ou un ARA2, et 1 an plus tard, le taux d'aldostérone est revenu plus élevé qu'avant de débuter le blocage. C'est un truc de dingue. Vous bloquez le système rénine-angiotensine-aldostérone pour bloquer l'aldostérone, et 1 an plus tard, vous avez un placebo, puisque l'aldostérone est revenu au-dessus de la valeur avant de débuter le blocage. Votre système a totalement échappé. Et ça, il faut le savoir. Les EEC et les ARA2 sont des placebos au bout de 2-3 ans. Ce sont des placebos au bout de 2-3 ans. Et c'est pour ça que vous êtes obligé de rajouter un anti-aldostérone. Alors c'est quoi finalement les déterminants de cet échappement à l'aldostérone? Ben, c'est cette étude qui le montre. C'est de la physiologie de 2e année de médecine. Plus vous faites votre boulot, mieux vous travaillez, plus vous allez favoriser l'échappement de l'aldostérone. Regardez, voilà ceux qui ont la pression artérielle systolique la mieux contrôlée. Hein, vous baissez mieux la pression artérielle systolique. Vous diminuez mieux la consommation sodée. Vous augmentez la kaliémie parce que vous faites un blocage du SRA, donc vous montez la kaliémie. Un étudiant de 2e année de médecine vous dit que ça stimule l'aldostérone, tout ça. Bah oui. Et donc ça favorise l'échappement de l'aldostérone. Alors plus intéressant, vous faites une diminution aiguë du débit de filtration glomérulaire, vous savez, pour diminuer la pression dans le glomérule, pour protéger le rein. Hein, toutes ces courbes où vous avez une perte de DFG initiale et après les courbes de débit de filtration sont toutes plates et vous protégez votre rein. Eh bien, mieux vous protégez votre rein, plus vous avez une baisse de DFG initiale, plus vous favorisez l'échappement de l'aldostérone. Il n'y a pas de moyen pour éviter ça que de donner un anti-aldostérone. Alors, c'est ma conclusion. Comment prévenir finalement ce syndrome cardio-rénal de type 1? Eh bien, associer 3 diurétiques. Sur vos 4 fantastiques, il y a 3 diurétiques. Ça prouve l'importance de l'association de ces différents diurétiques pour éviter un échappement. Inhibiteur du HLT2, ARNI, anti-aldostérone pour éviter cet échappement. Deuxièmement, les diurétiques de lance ne sont là que pour rattraper la congestion résiduelle. Alors, vous pouvez commencer un peu IV, mais après, il faut switcher en perfusion continue parce que c'est plus efficace. Alors, il ne faut pas oublier que les thiazides peuvent rattraper, dans certains cas, des échappements aux diurétiques de lance. Alors, je vous le schématise ici. Si votre malade prend depuis un certain temps des diurétiques de lance, eh bien, en fait, il y a un peu plus de sodium délivré ici au niveau du début du tubule distal, hein, segment cortical de dilution. Et ça favorise une hypertrophie de ce segment avec une multiplication des cotransporteurs sodium-chlore qui sont le site d'action des thiazides. Et c'est pour ça que les thiazides peuvent rattraper de l'échappement aux diurétiques de l'anse. Et donc enfin, si vous utilisez de façon satisfaisante tous ces diurétiques, vous aurez de moins en moins besoin de faire de l'ultrafiltration. Je vous remercie.
Merci beaucoup à tous les 4 conférenciers pour ces excellentes présentations. Nous avons 10 minutes. J'invite les conférenciers de se joindre à nous pour commencer la discussion. Et vous avez le choix de poser les questions en anglais, en français. Vous pouvez monter, vous pouvez venir à côté de moi, si vous voulez. Alexandre aussi. Oui, c'est bon. Il vaut mieux être en face des auditeurs. Est-ce qu'il y a des questions dans la salle? Tfadal, Dr. Chabra.
My question for Dr. Magdi Abdelhamid for right ventricular heart failure, is there a place for SGLT2 inhibitor or ARNI?
Very interesting question. Yesterday, during the session on SGLT2 inhibitor with Professor Stephen Anker, I asked him the same question. Do we have data as sub-analysis impact of SGLT2 inhibitors on RV function, hemodynamics, pulmonary artery pressure, etc.? But unfortunately, we didn't have yet any data about the effect of SGLT2 inhibitors on RV function. But we have data for reverse remodeling for patients with left side heart failure. So maybe we need studies to see if there is an
in your
effect.
practice, do you prescribe? In your practice, do you prescribe the SGLT2 inhibitor in
most patients with right side heart failure are due to left side heart failure, which is one of the 4 pillars of the foundation therapy or guideline direct medical therapy. So those patients are already on SGLT2 inhibitors due to left side heart failure, if they have a very low GFR below 20.
OK.
Thank you. It would be for the echocardiographists. What about strain for right ventricle? Really, we know it's not so easy with the echogenicity we have of the right ventricle, especially with our patients. So do you really use it every day? Is it an everyday thing that you use? Thank you.
Yes, so in the past years, I had a lot of TR patients to evaluate. So with the volume overload, it tends to be easier, but I will admit that it's not feasible for all patients. But if we don't try, we'll never do strain. So that's I think we should think about the steps to moving towards the future. So increase our ability to do RV strain, and eventually we're going to be better on 3D imaging, and that's the progression. So it's not easy, but it's feasible, but we need practice and interest.
Alors, pour vous, je vous avais montré une très belle image de cœur droit aigu. Je ne sais pas si on m'entend. Alors, vous avez montré une très belle image de cœur droit aigu et vous avez parlé d'embolie pulmonaire multiple, mais déjà à l'échographie, il y avait, on voyait très bien le thrombus dans le VD. Et là, j'ai eu exactement un jour le même cas. Moi, ma question ici, est-ce qu'on est vraiment obligé d'aller au scanner ou s'arrêter là? Parce que le diagnostic, il est très évident. Si on a une image comme ça, moi, je n'irai pas au scanner. Et puis, j'aurais une deuxième question pour le syndrome cardio-rénal. Vous avez très bien dit qu'il fallait démarrer les 3 médicaments en bloc. Alors moi, j'ai une petite question. Quand vous commencez à avoir une clairance qui baisse, quels sont les produits que vous préconisez en premier lieu et est-ce qu'il y a des molécules que vous éliminez provisoirement et lesquelles?
Alors, la précaution la plus importante, c'est de faire la place pour ces diurétiques. Et parfois, les patients, malheureusement, sont lyophilisés par des diurétiques de lance à la phase aiguë, avant même d'avoir débuté les traitements réellement cardio- et néphroprotecteurs. Et si ce malade a été lyophilisé, surdosé en diurétique de lance, on ne peut plus rien introduire, ça c'est sûr. Plus rien du tout. Donc, en aigu, c'est très compliqué, surtout s'il a été beaucoup déplété. En chronique, il faut aussi savoir diminuer les diurétiques de lance pour faire de la place. Sans doute commencer assez tôt avec le 5-méthylvalsartan. La bonne nouvelle avec les anti-aldostérone, c'est que ce n'est pas efficace avant 2 ou 3 jours. Parce que du fait du mode d'action, c'est des facteurs de transcription qui agissent sur l'expression à la membrane du canal sodé, ça prend 3 à 4 jours pour qu'un anti-aldostérone soit efficace. Donc il n'y a aucun risque à débuter un anti-aldostérone, par contre, puisque ça sera diurétique au bout de 3 ou 4 jours. Et puis l'upture du GLT2 le plus vite possible. Donc en fait, il faut commencer tout le plus vite possible, mais faire de la place en diminuant les traitements inutiles, les diurétiques de lance.
Donc effectivement, pas besoin de scanner. Le vrai message de mon cas clinique, c'est que quand vous avez un malade qui a une hypotension artérielle, 99,9% des cardiologues intensivistes mettre du volume loading, et je vous en supplie, faites une écho, vous voyez le VD, et là vous arrêtez, vous mettez pas une goutte, et la restauration de la pression artérielle, il faut mettre un tout petit peu de noradrénaline, même en voie veineuse périphérique, mais là vous rajoutez du volume à quelqu'un qui a un volume droit comme ça, c'est une seule issue, c'est de tuer le malade. Donc je vous en supplie, si ça peut rester le message, ce serait génial.
Moi, j'ai une question un peu futuriste pour l'imagerie. Est-ce que vous croyez que l'IRM, l'imagerie moderne, l'IRM cardiaque, cœur droit, gauche, ou l'IRM combiné à l'échocardiographie, va supplémenter l'échocardiographie pour les malades chroniques? En urgence, c'est l'échographie qui reste mobile, rapide, etc. Mais pour le diagnostic étiologique, pour l'évaluation fine des cavités cardiaques droite et gauche, avec l'intelligence artificielle maintenant et l'imagerie IRM, est-ce que vous voyez que dans le futur proche, ça va remplacer l'échocardiographie, tout en sachant qu'on ne se passe jamais de nos éminents échocardiographistes présents dans la salle, puisqu'ils vont certainement interpréter également les images, comme lorsqu'on a débuté avec le coroscan, il y avait toujours cardiologue avec les radiologues.
À mon avis, en fait, les deux vont progresser en même temps. Le but, c'est vraiment d'approcher l'échographie le plus près possible de l'IRM pour certaines choses, dont les volumes, dont la fraction d'éjection. Par contre, l'IRM va toujours rester le gold standard vraiment pour l'analyse de diagnostic initial, la caractérisation des tissus et tout ça. Après, je pense que ça va toujours rester une modalité qui va être plus dispendieuse, plus difficile d'accès. Peu importe comment on va améliorer la technologie, ça va être toujours relativement long et prendre beaucoup de ressources. Donc, moi, je ne vois pas un avenir très important dans l'IRM, bien qu'elle va toujours garder sa place, mais je vois surtout une progression de la place de l'évaluation avancée en échocardiographie. Puis on le voit, les progrès sont exponentiels dans les dernières années. Justement, moi, il y a quelques années, j'essayais de faire du strain ventriculaire droit avec un résultat vraiment sous-optimal. Et maintenant, avec les volumes 3D qu'on est capable de faire, je ne vous ai pas présenté beaucoup de cas, mais c'est assez impressionnant la corrélation IRM et échographie qu'on est capable d'atteindre maintenant. Donc, je crois que j'ai encore un avenir en échographie.
Alors, est-ce que vous avez noté des limites au TAPS dans l'évaluation de la fonction ventriculaire droite?
S'il y a des limites au TAPS?
Oui.
Oui, beaucoup. En fait, faut savoir que le TAPS a surtout été validé initialement pour sa corrélation avec la fraction d'éjection chez des patients sains. Et donc, il y a une très bonne corrélation chez les patients sains. Mais comme je disais tout à l'heure, en fonction des différentes conditions de charge, la fonction longitudinale prend beaucoup moins de place dans la contraction. Et donc, c'est les autres paramètres qu'on doit évaluer. il y a différents cut-offs dans la littérature qui a été publiée en fonction des pathologies. Donc, je pense que c'est quelque chose de simple. C'est quelque chose que si on utilise bien, justement, en respectant l'angle et tout, qui est très utile parce que ça a été, malgré toutes ces limitations, ça a été bien démontré comme étant, comme ayant une valeur pronostique dans différents diagnostics, dont l'hypertension pulmonaire, par exemple.
I have a short question for Professor Mbaza. Professor Mbaza, impaired RV function after successful treatment of acute pulmonary embolism and no RV failure. How to?
Is it possible?
Sometimes, very rare, but can be seen. Impaired RV function after treatment of.
I think that there are two questions. One, and I'm sorry, I repeat it again, in our, in fact, European survey, the main reason of death after acute myocardial infarction is really volume overload, and in fact the patients are dying from the liver, not from the heart, from the liver and the kidney. Two, you're totally right. I would say if you wait, this patients with a right ventricular myocardial infarction, which they are rare, usually after 8 to 10 days, the right ventricle recover. We have now a large series of MRI after acute myocardial infarction, and surprisingly, compared to the left, you see more recovery than the left ventricular myocardial infarction. There is less wound and things like this that what you may see on the left.
Dernière question, Alexandre, concernant l'intubation et la ventilation invasive dans le cœur droit aigu. On fait tout pour ne pas les intuber parce que ça vraiment ça désamorce.
Yeah, Professor Fergeni is asking about intubation and mechanical ventilation when there is a right ventricular dysfunction. Alors c'est vrai que effectivement ça décompense et là aussi il faut être très précautionneux et là aussi il faut pas rajouter un malheur au malheur. Une fois encore, il faut être la seringue de noradrénaline et être très 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 précautionneux parce que l'hypotension, alors là, va entraîner de l'ischémie du ventricule droit et va aggraver les choses. Donc c'est des malades qui sont très fragiles, mais I come back to what you mentioned, recovery of the right ventricle is really very good.
Merci beaucoup. Merci pour l'excellente présentation de nos experts. On peut les applaudir. Merci pour la Société de Cardio de nous avoir donné cette occasion de discuter le cœur droit. On laisse la place à la séance suivante.
Enchaîner avec le symposium de Novo Nordisk qui va être animé par professeur Valenci, un éminent diabétologiste et qui a, je pense, une expérience très large dans la prise en charge des patients diabétiques, notamment la prescription des analogues de GLP-1. Et donc, professeur Valenci va nous parler des nouveautés. Je pense que cette année, nous avons beaucoup de nouveautés, en particulier chez les patients obèses, et la place de ces molécules dans l'amélioration du pronostic de nos patients diabétiques. À vous la parole, professeur Valencia.
Vous m'entendez? C'est bon. Merci beaucoup pour l'introduction. Bonjour à toutes et à tous. Merci à la STCCCV, à l'AMCV, aux organisateurs de m'avoir invité. Je reviens toujours avec grand plaisir en Tunisie, mes racines, et à Djerba notamment. Et merci à Novo Nordisk, bien sûr, pour le soutien. Alors, nous avons un sujet d'actualité, et en tout cas assez nouveau, au moins dans le Maghreb. Cette famille thérapeutique des agonistes du récepteur du GLP-1, nous en avons en France depuis une dizaine d'années. Et il vous arrive ici un premier, le liraglutide, qui est disponible en Tunisie, et d'autres, j'espère, qui viendront prochainement. Alors, le thème touche autour d'une cible cardio-métabolique et un peu rénale. Bien sûr, je vais faire moins bien que notre éminent néphrologue, mais dire quand même quelques mots sur GLP-1 et rein. Alors, comme il se doit, déclaration. Voilà. Pardon, j'ai été trop vite peut-être. Hein. Voilà. Au moins 2 secondes. Donc, nous commençons par les effets métaboliques et sur le poids, qui sont très consistants quantitativement et comparativement aux classes classiques, des effets absolument majeurs. Alors, vous avez notamment ici la comparaison de ce qu'on appelle la grande famille des incrétines. Ça a commencé par inhibiteur de DPP4, qui évite la dégradation du GLP-1 endogène. Et puis, secondairement, donc, ces agonistes récepteurs du GLP-1, on va dire des analogues de GLP-1, qui agissent comme le GLP-1, mais de façon durable, parce qu'ils ont été modifiés. Alors ici, on a la baisse d'hémoglobine glyquée, vous voyez, qui est très importante en quantité comparativement aux inhibiteurs de DPP4. La baisse de pression systolique de l'ordre de 3-4 mm de mercure, qu'il n'y a pas avec inhibiteur DPP4. La baisse des triglycérides. Sur le HDL, pas d'écart notable. Sur le poids, un écart important. Et on va beaucoup en dire là-dessus, de l'ordre de 3 kg, qu'il n'y a pas avec DPP4, une légère accélération cardiaque de 2-3 battements par minute qui n'entrave pas le pronostic cardiovasculaire, autant que l'on sache, et une petite baisse du LDL cholestérol. Alors, concernant l'amplitude de la réduction du taux d'hémoglobine glyquée, je commence par ces données de vie réelle. Bien entendu, les grandes études contrôlées ont largement démontré l'effet versus placebo ou versus des comparateurs actifs, et je vous ai à l'instant comparé aux inhibiteurs DPP4. Ici, dans la vraie vie, eh bien, on arrive assez facilement au-dessus de 1% de baisse d'hémoglobine glyquée, voire 1,6%. Concernant le poids, voilà toute une série d'études contrôlées, et effectivement, il y a des baisses entre 2 et 3 kg de valeur moyenne de poids, en sachant qu'il y a de très bons répondeurs. J'ai quelques patients qui peuvent perdre 7 kg, ici avec le liraglutide, à la dose que l'on donne dans le diabète de type 2, ça veut dire que l'on titre jusqu'à 1,8 mg par jour. Alors, maintenant, dans la vraie vie, l'effet du liraglutide, ce sont des données d'observation ou sur registre. On atteint également des baisses de l'ordre de 3 kg. Ça veut dire sans avoir mis forcément le prix en termes de conseils hygiéno-diététiques et d'accompagnement du patient. Dans la vraie vie, on a des baisses comparables à ce que l'on voit dans les études contrôlées. On peut retenir cette moyenne de baisse de 3 kg. Qu'en est-il vis-à-vis du challenger, je vais dire, inhibiteur du SGLT2? Et on n'est pas là pour dire inhibiteur SGLT2, c'est pas intéressant. Bien sûr que c'est très intéressant, mais il y a des places probablement pour les 2 classes thérapeutiques modernes. Et ici, en fait, on s'interroge dans cette méta-analyse en réseau. Alors, ce ne sont pas des études face-face, mais un collectif d'études où on a testé l'un, liraglutide, et on a testé l'autre, inhibiteur DPP4. Et vous voyez à droite l'amplitude de baisse d'hémoglobine glyquée. Il n'y a pas photo. La baisse d'hémoglobine glyquée, elle est beaucoup plus consistante, de l'ordre de 1,2 à 1,4%, alors qu'on est plutôt à 0,6-0,7% de baisse avec inhibiteur du SGLT2. Alors, si on revient sur le poids, on sait, avec tous les médicaments de l'obésité, que plus on est gros au départ, plus on perd de poids. Et c'est vrai, on retrouve cette tendance ici dans une population de diabétiques de type 2. Quand l'IMC est inférieur à 35, on a des baisses jusqu'à 2,7 pour kilogramme sous la dose maximale de liraglutide, 1,8 mg. On perd 2,7 kg, tandis que quand l'IMC de départ est supérieur à 35, on perd 4,4 kg. Et ça, c'est vrai dans tous les essais de médicaments de l'obésité. Alors, un médicament qui est à notre disposition en France dans le diabète et que l'on peut utiliser dans certaines conditions dans l'obésité en France, mais non remboursé pour l'obésité. Et je souhaite que ce médicament arrive en Tunisie et en Afrique du Nord parce que les résultats sont majeurs. Hein. Ici, il ne faut pas confondre. Ce sont des obèses, ce ne sont pas des diabétiques. Et dans l'obésité, avec la même restriction énergétique, on perd plus de poids que quand on est obèse diabétique. Pour différentes raisons, on en parlera si vous voulez. Et vous voyez notamment pour chaque pavé, par exemple sur la pression systolique, les répartitions de patients selon qu'ils ont perdu moins de 5%, 5 à 10%, 10 à 15%, plus de 15%. Plus de 15%, la moitié de la population de cette étude a perdu plus de 15%. Ça veut dire 15 kilos. C'est impressionnant. Eh bien, vous voyez aussi que plus on a perdu de poids, plus la pression systolique s'est abaissée, la pression diastolique s'est abaissée. Le non-HDL cholestérol s'est abaissé, les triglycérides sont abaissés. C'est très lié à la perte de poids. Donc, ces médicaments de l'obésité sont une vraie classe thérapeutique qui est utile dans le diabète type 2 et qui est utile dans l'obésité par elle-même. En parallèle, petite baisse de pression systolique qu'on met sur le compte de la perte de poids, mais également d'effets rénaux liés à cette classe thérapeutique. On a de l'ordre de 2 à 3 mm de mercure de baisse de pression systolique, mais dans l'ensemble des études, si on va voir des bénéfices effectivement, ce n'est pas à mettre sur le compte de cette petite baisse de pression systolique. Alors maintenant, on en arrive aux effets cardiovasculaires spécifiques. Y a-t-il des données spécifiques qui vont permettre de nous dire que ce sont des effets propres, indépendants de la perte de poids, voire indépendants du métabolisme? Il y a quelques données. On va dire qu'on est dans le pléiotropisme, comme avec les statines, comme avec les bloqueurs du système réninien-angiotensine. Eh bien, du côté droit, vous avez les effets globaux de ces analogues du GLP-1 et un point fondamental, l'effet sur le cerveau. On réduit l'appétit, on renforce la satiété, on mange moins, et on mange moins aussi parce qu'il y a un ralentissement de la vidange gastrique avec cette classe thérapeutique. Donc, on perd du poids. On a des effets sur le pancréas, réduction du glucagon, augmentation de l'insulinosécrétion. C'est comme ça que ça agit et ça va largement améliorer la glycémie. Et puis d'autres effets, et notamment, on se reporte sur le côté gauche, où on voit la cible cardiaque et la cible vasculaire. Sur la cible cardiaque, bon, tout a été montré de façon plus ou moins stricte, mais dans l'ensemble, ce sont les messages qui sont retenus. Vous voyez cette grande revue Drucker et qui a renouvelé récemment la revue qui s'enrichit. On a des effets favorables sur le cœur, on va en dire un mot. On a des effets favorables sur le vaisseau et globalement, on va dire, on renforce le potentiel de vasodilatation, on stabilise la plaque, on réduit l'inflammation, on améliore la fonction endothéliale et aussi un effet anti-agrégant plaquettaire qui a été rapporté. Alors, voyons donc quelques études basic research, recherche expérimentale. Ici, la souris déficiente en ApoE, un modèle d'athérosclérose expérimentale. Et on a des souris qui mangent CHO, leur alimentation normale. Vous voyez légère progression du poids quand elles prennent de l'âge. Vous avez en noir la courbe la plus haute qui est les souris auxquelles on donne à manger une diète occidentale, et elles adorent le lard notamment, et elles prennent beaucoup de poids. Les souris qui mangent cette diète occidentale et à qui on donne du liraglutide ne prennent pas de poids, elles sont dans le pavé du bas, comme si elles avaient mangé une diète normale, donc liraglutide est très efficace sur le poids. Et on va voir qu'est-ce que ça donne sur le développement des plaques. Il y a un petit peu de plaques chez ces souris qui ont leur alimentation normale. Il y a beaucoup de surface de plaques sans traitement, vehicle, quand on leur donne la diète occidentale. Elles développent beaucoup de plaques. Et ces souris qui mangent la diète occidentale et à qui on a donné du liraglutide, eh bien, elles ont moins de plaques. Elles sont entre les deux. Donc, on a réduit le développement des plaques. Et le dernier groupe, c'est un groupe de souris qui a mangé la diète occidentale, mais qui n'a pas grossi. Donc, elle a le même poids que si elle avait été traitée par liraglutide. Elle a développé des plaques. Comment on interprète ça? En disant qu'on a un effet anti-athérosclérotique. Est-ce qu'il est spécifique? Probablement oui, parce qu'il est indépendant du poids. Et probablement oui, parce qu'il n'y a pas eu de baisse du cholestérol, il n'y a pas eu de modification des lipides, on n'a pas d'autres stigmates sur le plan métabolique. Par contre, si dans ce même modèle, on étudie l'inflammation, ce sont des données là in vivo sur du sang prélevé, on voit que le TNF-alpha a baissé, l'interféron gamma a baissé, l'ostéopontine a baissé, on a des marqueurs d'inflammation qui sont réduits, et donc l'hypothèse est effectivement qu'on limite le développement des plaques grâce à un effet favorable sur l'inflammation et aussi des effets antioxydants notamment. Alors, sur l'infarctus expérimental, on a ces données chez la souris. L'infarctus est moins étendu dans le groupe traité par liraglutide, moins de rupture cardiaque dans ce modèle. Et puis, on revient sur le vaisseau, l'endothélium, ici le vaisseau périphérique, mais chez des diabétiques de type 2 coronarien stable. Alors, on a fait une manip un peu compliquée là. On a le sérum salé et on a sous-clan. Clan, ça veut dire qu'on perfuse de l'insuline. Et delta FMD, forearm mediated dilation, c'est la réponse vasodilatatrice post-ischémique qui permet d'interroger l'endothélium. On passe de 2 à 3,1. L'insuline induit cet effet favorable sur l'endothélium. Mais à droite, avec le même clan, quand on a injecté du GLP-1, on voit que la réponse endothéliale s'est terriblement majorée. Donc on améliore la fonction endothéliale. Et en bas, le contrôle, c'est la nitroglycérine. On n'a pas d'effet sur la musculature lisse. Donc bénéfice sur la fonction endothéliale, et ça a été montré par plein d'autres études. Maintenant, le patient qui a fait un infarctus, un groupe traité par placebo, un groupe traité par liraglutide. Après 3 mois de traitement, on observe une amélioration de la fraction d'éjection ventriculaire gauche. Donc des données ici favorables sur le vaisseau, sur le cœur. Alors bien sûr, on est en droit d'attendre du bénéfice et les essais de sécurité cardiovasculaire, vous savez, ont été développés pour démontrer la sécurité, mais finalement, au-delà, on attend un effet bénéfique et c'est ce qui a été largement montré, notamment avec l'étude LEADER, près de 10 000 patients avec 2 contingents, un de prévention primaire, un de prévention secondaire, et on compare donc liraglutide versus placebo. Et le résultat est éblouissant, avec sur le MACE, 3 points à gauche, une réduction de 13% des événements, à droite, et pour la première fois en diabétologie, avec un médicament du diabète, réduction de 22% de la mortalité cardiovasculaire. Autre point à noter, c'est le moment de divergence des courbes. On est vers 6 mois. Ça veut dire quoi? Ça veut dire probablement que les effets anti-athérosclérotiques rendent compte, pour l'essentiel, de ce bénéfice. Alors qu'avec un inhibiteur de GLT2, vous verrez des choses arriver plus tôt, par baisse de la volémie, je pense surtout. Donc ici, c'est très cohérent avec les effets anti-athérosclérotiques. Qu'en est-il sur le microvasculaire? Sur un critère composite dans LEADER, il y a effectivement une réduction de 16% des événements microvasculaires. Sur la rétinopathie, pas grand-chose. Sur la néphropathie, évaluée sur le critère d'évolution vers la macroprotéinurie, il y a une réduction significative de 26%. Par contre, il n'y a pas d'effet bénéfique sur les critères durs d'insuffisance rénale terminale, de traitement de substitution, etc. Donc, c'est efficace sur le passage à la macroprotéinurie, mais moins puissant sur le critère rénal que l'on voit avec les inhibiteurs de SGLT2. Alors, si on revient maintenant sur les cibles cardiovasculaires, ici, ce sont des méta-analyses qui ont comparé les deux classes. Avec agonisme du GLP1, analogue du GLP1, vous voyez qu'on remplit toutes les cases, tout est significatif, infarctus, AVC, mortalité cardiovasculaire, mortalité totale. À droite, on manque une case, on manque les AVC. Voilà, il n'y a absolument pas de tendance favorable vis-à-vis des AVC, pour des raisons peu claires d'ailleurs, mais enfin c'est ainsi et c'est très cohérent dans les méta-analyses. Après, il faut avoir une lecture de ces données a posteriori, post-hoc, qui ont été bien sûr préspécifiées, d'une lecture des deux contingents. Je vous ai dit de prévention primaire, prévention secondaire. Oui, mais attention, qui est en prévention secondaire? Quelqu'un qui a fait un infarctus ou un AVC, ok. Mais quelqu'un qui a une maladie athérosclérotique démontrée, de l'athérome carotidien significatif, une artérite, mais asymptomatique, qui n'a pas fait les événements durs, est aussi athérosclérotique. Et à ce moment-là, regardez par exemple le pavé en haut à gauche, c'est le MACE, avec ces 3 sous-populations. Quand il y a les facteurs de risque, c'est la prévention primaire, ce sont les 2 courbes en bas grises, pas d'effet du liraglutide sur les événements à ce moment-là. Ça va dans le bon sens, mais pas d'effet significatif. Maintenant, dans le bleu, c'est en haut, ce sont les patients qui ont fait déjà un infarctus ou un AVC. L'écart est très significatif, réduction de 15%. Et à droite, si on regarde la mortalité, ça marche très bien aussi, réduction de 20%. Et puis entre les deux, il y a la population qui a la maladie athéromateuse asymptomatique, eh bien ça marche aussi, quel que soit le critère de jugement cardiovasculaire. Donc j'attire l'attention là sur le fait qu'il y a la maladie que les cardiologues connaissent bien, le patient a parlé, la maladie a parlé, mais quand elle n'a pas parlé, elle est subclinique, on est quand même dans la maladie athéromateuse. Et une lecture complémentaire de ça, c'est de se dire, il n'y a pas d'atteinte vasculaire, ce sont les courbes en bleu clair, pas d'effet vraiment du liraglutide. Par contre, les 2 parties supérieures, c'est il y a un vaisseau atteint ou il y a plusieurs vaisseaux atteints, et là, ça marche très bien. Même avec un vaisseau atteint, ça marche très bien. Voilà un message fort que je voudrais passer. Quand il y a la maladie athérosclérotique, quel qu'en soit le stade, il faut y aller. Alors, les méta-analyses disent la même chose. On rassemble les études avec agonistes du GLP-1, et vous voyez en bas, quand il y a antécédent cardiovasculaire, on est à gauche du 1, réduction de 14% du MACE. Sans antécédent cardiovasculaire, on est plutôt du bon côté, mais ce n'est pas significatif. Alors ça veut dire quoi? Ça veut dire que pour prévenir un événement, il va falloir peu de patients quand on est dans la maladie athérosclérotique, énormément de patients quand on est au stade des facteurs de risque, sans démonstration de la maladie athéromateuse. Alors, il y a aussi l'hospitalisation pour insuffisance cardiaque, et ça a été regardé dans ces études, et ça va dans le bon sens, réduction de 9% du risque globalement, et notamment leader, vous voyez, ça, on est vraiment du bon côté. Donc, d'après ces données, ça va aussi dans le bon sens sur hospitalisation pour insuffisance cardiaque. Alors, maintenant, dans ce nouveau monde où vous avez à votre disposition, ici par exemple, liraglutide et d'autre part les inhibiteurs du SGLT2, est-ce qu'on doit réfléchir en termes d'alternatives thérapeutiques l'un ou l'autre, ou est-ce qu'on doit réfléchir en termes de complémentarité? Ici, c'est pour dire, si on fait un peu la synthèse des cibles de ces 2 classes thérapeutiques, vous voyez qu'il y a du rouge à gauche avec GLP-1, ça veut dire grosse efficacité sur la glycémie, sur l'endothélium, sur l'obésité, sur l'inflammation. À droite, avec l'inhibiteur GLT2, il y a du rouge surtout sur la volémie, sur le métabolisme myocardique et peut-être un peu plus sur la pression artérielle. Et puis une autre lecture, c'est aussi ça, qu'il y a le cœur dont je viens de parler, le cœur et les vaisseaux dont je viens de parler, puis il y a le métabolisme. En fait, l'inhibiteur du SGLT2, ça stimule l'appétit, alors qu'agoniste GLP1, ça réduit l'appétit. Cette perte de poids est beaucoup plus importante avec agoniste du GLP1. Dans SGLT2, c'est dû surtout à la glycosurie, donc perte d'énergie, et aussi un petit peu de diurèse, du moins au début. Je ne vais pas trop m'aventurer, j'ai quelqu'un qui me regarde là-bas. Maintenant, sur insuline, en fait, c'est un sens opposé. On réduit l'insuline parce que, avec l'inhibiteur GLT2, parce qu'on baisse la glycémie, on réduit l'insuline. De l'autre côté, on stimule l'insulinosécrétion. On augmente le glucagon avec SGLT2 inhibiteur, alors qu'on réduit le glucagon, ça va dans le meilleur sens sur ce plan-là avec agoniste du GLP. Alors, mettons-nous dans cette situation d'association. Prenons des patients qui sont sous inhibiteur du SGLT2 et on va ajouter GLP1. Vous avez à gauche, par exemple, on a ajouté du laglutide. Et vous voyez les rouges, le rouge foncé, le carmin, on a réduit bien plus l'hémoglobine glyquée comparativement au placebo. Avec liraglutide, de même, on réduit l'hémoglobine glyquée comparativement au placebo. Et puis en bas, le poids, avec les médicaments actifs, on réduit le poids. Donc, le fait, chez un patient qui est sous inhibiteur de GLT2, d'ajouter GLP1, conserve l'effet bénéfique sur l'hémoglobine glyquée, conserve l'effet bénéfique sur le poids. On est dans le même type d'étude et on regarde la pression systolique, elle s'abaisse quand on ajoute le GLP1. Elle s'abaisse pratiquement de la même ampleur que ce que l'on voyait quand il n'y avait pas de SGLT2 inhibiteur au départ. Donc on conserve aussi l'effet de baisse de tension qui éventuellement vient s'ajouter déjà à la baisse de tension qui avait été induite par inhibiteur du SGLT2. Et maintenant, donc ici, c'est un peu la synthèse de tout ça, mais on a un schéma, un design différent. On a mis ensemble et au même moment agoniste du GLP1 et inhibiteur du SGLT2. Il n'y a aucune recommandation qui dit vraiment de faire ça. Mais si on le fait, c'est intéressant. Vous voyez par exemple l'étude à gauche, canagliflozine, inhibiteur SGLT2 plus liraglutide, perte de 20%, baisse de 20 microgrammes, enfin une baisse significative de l'hémoglobine glyquée, bien plus ample que sous ISGLT2 seul ou liraglutide seul. Et on a les mêmes tendances dans les autres études. Donc simultanément aussi, et sur l'hémoglobine glyquée et sur le poids, on voit s'exprimer les effets des deux classes thérapeutiques. Et maintenant, sur la pression systolique, de la même façon, la combinaison des deux réduit plus la pression systolique que si on donnait un seul des deux. Alors, inhibiteur GLT2, bien sûr, il y a des effets majeurs sur les cibles cardiovasculaires, et cette méta-analyse, la plus importante avec toutes les études rassemblées ici, vont dans le bon sens sur le MACE 3 points, mais vous remarquez la même chose qu'avec agoniste du GLP1. Sur le MACE, ça marche significativement chez les patients qui ont la maladie athéromateuse. S'ils n'ont pas, ils ont donc recruté parce qu'ils ont des facteurs de risque, mais ils n'ont pas, l'effet n'est pas significatif. Donc, même profil qu'on a vu avec agoniste du GLP1. Du côté droit, sur hospitalisation pour insuffisance cardiaque, pour le coup, ça marche toujours, qui est ou pas antécédent cardiovasculaire. Alors, ici, et c'est la seule étude vraiment sur les événements que l'on va retenir, c'est un registre, ce sont des registres nord-américains, les patients mis d'abord à agoniste du GLP1 et on ajoute inhibiteur GLT2 ou un sulfamide, et je dois aller vite, on observe qu'il y a un effet favorable sur le critère composite cardiovasculaire, sur hospitalisation pour insuffisance cardiaque. Donc, sur une base de GLP1, le fait d'ajouter inhibiteur GLT2 semble marcher, mais ce sont des données observationnelles, on n'a pas les études randomisées. Alors, je dois terminer rapidement. Vous avez déjà vu ça dans différentes réunions ou symposia ici même. Vous avez ce schéma ADA 2023, où on dit, en premier lieu, vous avez un diabétique type 2, regardez son statut cardiovasculaire. Si c'est oui, on va voir. Si c'est non, du côté droit, eh bien, si c'est oui, bien sûr, quand on est dans la maladie athérosclérotique ou quand il y a des indicateurs de haut risque, vous voyez très largement la place des agonistes du GLP1 ou éventuellement inhibiteurs du SGLT2. Quand il y a insuffisance cardiaque, c'est inhibiteur du SGLT2. Quand il y a maladie rénale, c'est surtout inhibiteur du GLT2, en sachant que GLP1 est en réserve en cas d'intolérance notamment ou de contre-indication aux inhibiteurs du SGLT2. Alors, de l'autre côté, il n'y a pas de maladie athérosclérotique ni rénale. Eh bien, on se concentre sur la glycémie, et là, on voit quoi? Les médicaments très efficaces sur la glycémie, ce sont les agonistes du SGLP1. C'est ça que l'on met en premier lieu. Du côté droit, sur le poids, qu'est-ce qui est très efficace? Ce sont les agonistes du GLP1. C'est ça qu'on met en premier lieu. Et dernière recommandation ESC 2023, très cohérente avec cette attitude. On est dans la maladie athérosclérotique et il y a de façon privilégiée place pour ces deux nouvelles classes thérapeutiques. Ou bien on est dans le haut risque ou le très haut risque parce que le score est élevé ou bien il y a une atteinte d'organes cibles. On a metformine là, mais ces nouvelles classes ont tout à fait leur place. Et dans la recommandation française que j'ai coordonnée, où on évalue le risque coronarien des diabétiques de type 2, on a d'emblée des patients du très haut risque parce qu'il y a la macroprotéinurie, l'insuffisance rénale sévère, ou bien du haut risque. Quand ils sont dans le très haut risque, ils doivent avoir ces traitements. Quand ils sont finalement, secondairement, dans le très haut risque, parce qu'on a fait le score de classification coronaire qui met en évidence l'athérome coronaire, à ce moment-là, il y a aussi place pour ces traitements. Donc c'est ce que l'on a exprimé ici, très haut risque, il faut ces traitements. Et donc j'arrive juste, comme il faut, à la dernière idée, mais que je ne vais pas développer. Bien entendu, on a ça en tête, il n'y a plus qu'à implémenter, mettre en place ces choses-là, et donc c'est dans un discours, un échange entre diabétologues, cardiologues, néphrologues nouvellement, pour effectivement dire ce patient est dans cette classe de risque, il a la maladie, oui ou non, et de partager ça pour attribuer la bonne classe thérapeutique. Voilà, merci pour votre attention.
Monsieur Valency, on ne peut pas avoir mieux que vous pour faire un speech pareil parce que vous avez la double casquette du cardiologue et de l'endocrinologue, ce qui est exceptionnel et rare. Donc on vous remercie pour ce topo exceptionnel. Il y a certainement beaucoup de questions. Est-ce qu'il y a des questions de l'audience? Sinon, je vais commencer par la première. Alors les cardiologues, ils savent que les inhibiteurs SGLT2 marchent sur les REF et les PEF. Les insuffisances cardiaques à fraction d'éjection, qu'elles soient conservées ou réduites. Est-ce que c'est la même chose pour les analogues GLP-1?
Ah, merci pour cette magnifique question. Et donc, je suis sauvé par le gong, puisque vous avez vu passer il y a 15 jours l'étude dans HF-PEF chez des obèses. Et on a donné le sémaglutide à dose anti-obésité. Ce n'est pas pareil, c'est plus fort que la dose anti-hyperglycémie. Et donc, on n'a pas évalué le pronostic, ce n'était pas le but des choses, mais ces patients donc obèses ont une insuffisance cardiaque à fraction d'éjection préservée et ils améliorent le score Kansas de fonctionnalité, on va dire, et ils améliorent leur capacité physique sur le test de 6 minutes de marche, etc. Donc ça va dans le très bon sens. Et au passage, ils ont perdu dans l'étude de l'ordre de 13% du poids corporel, alors qu'il n'y avait que 3% de perte sous placebo. Donc, c'est très nouveau comme concept, que finalement, si on perd beaucoup de poids, on améliore le cœur. En fait, on était un peu sur sa faim, parce qu'on n'avait pas de grands médicaments de l'obésité. Et on tendait à dire, oui, on va perdre du poids, mais on ne va pas beaucoup améliorer le cœur. Pour la première fois, on démontre qu'on améliore le cœur dans la fraction d'éjection préservée.
Alors, s'il n'y a pas d'autres questions dans la salle, j'enchaîne avec la deuxième question. Beaucoup de nos patients obèses, moi je suis actuellement dans le privé, ils se mettent à prendre justement les médicaments analogues de GLP-1 de façon spontanée alors qu'ils ne sont pas diabétiques ni prédiabétiques pour perdre du poids. 1. Quelle dose prendre? 2. Pourrons-nous espacer les fréquences d'injection sous-cutanée? Et troisième question, beaucoup quand ils arrêtent, ils regagnent en fait en poids. Et peut-être que la chirurgie serait une meilleure solution.
Oui, très bonne question également. Alors, bon, le sujet c'était diabète type 2 et le laboratoire m'a dit vous ne parlez pas d'autre chose. Mais j'ai le droit quand même, hein, je prends ce droit puisque vous m'y invitez. Donc, l'iraglutide, dans le diabète, on va jusqu'à 1,8 mg tous les jours. Ça s'appelle Victoza. Et les doses plus fortes, on peut aller jusqu'à 3 mg, ça s'appelle Saxenda. Et donc, nous disposons de cela en France, c'est une injection par jour. Sémaglutide, dans le diabète, qui va vous arriver, on va jusqu'à 1 mg en injection une fois par semaine. Et ce même sémaglutide en injectable à forte dose, jusqu'à 2,4 mg, ça s'appelle Wegovy, donne des résultats faramineux sur le poids, mais impressionnants. Il y a pratiquement un tiers des patients qui perdent 20% du poids. Bien sûr, avec chirurgie bariatrique, on a des résultats de cet ordre, voire meilleurs. Mais bien souvent, avec chirurgie bariatrique, il y a une remontée de poids. Après 5-6 ans, on est obligé de faire une réintervention. Ou alors, on mettra ces médicaments à des gens qui ont eu la chirurgie bariatrique. Donc, une notion importante que je voudrais dire, je n'ai pas montré les cinétiques de perte de poids, mais sous agonisme du GLP-1, on ne reprend pas de poids. Et même dans les traitements de l'obésité, ça n'arrête de... On se demande jusqu'où. C'est vraiment phénoménal, effet très consistant.
Docteur Hachet, tfadal.
concerne la disponibilité du produit, parce que comme il a été détourné pour le traitement de l'obésité, justement, il est très peu disponible, ça c'est un. Et deux, pour les patients qui en ont reçu, on observe une baisse initiale du poids, puis ça stagne. Est-ce qu'il y a une explication à ça?
Oui, alors vous avez raison de préciser ça. Donc, on est avec Victoza, n'est-ce pas? Je ne connais pas la situation du marché ici. Victoza, en France, est toujours disponible. Il n'y a pas de problème d'approvisionnement. C'est Ozempic qui pose le problème d'approvisionnement. Parce que, effectivement, les obèses ont remarqué que ça leur rend service, donc ils essayent de tirer un peu la prescription du médecin traitant. Maintenant, sur la perte de poids, ça rejoint le point que j'évoquais. On baisse, mais ça plafonne, effectivement, avec Victoza dans le diabète. Parce que le diabétique, il perd moins facilement que l'obèse sans diabète. Vous voulez savoir pourquoi? C'est l'épargne énergétique. Quand vous pissez du sucre, vous pissez plein de calories. Vous améliorez le diabète, vous pissez plus du sucre. Donc, on retient cette énergie. Dans l'obésité, il n'y a pas ce problème.
Monsieur Valency, est-ce qu'on a une idée sur l'association des agonistes GLP-1 avec les inhibiteurs SGLT2? Est-ce qu'il est additif?
Oui, alors, donc, montrer quelques études, effectivement, contrôlées, etc. On va plutôt dans le bon sens et c'est presque additif. On a du mal à vraiment démontrer complètement parce que ça n'a pas été conçu de cette façon-là. Il faudrait faire des essais spécifiques. Mais en tout cas, quand on donne l'un, quand on donne l'autre et quand on donne l'association des deux fait nettement mieux qu'un seul, mais pas strictement additif. Sur la pression artérielle, on a l'impression, en tout cas, quelqu'un à qui on fait séquentiellement, il y a eu déjà sa baisse de pression sous inhibiteur GLT2, par exemple, on a joué le GLP1, on voit une baisse supplémentaire, et inversement. Donc, on a plutôt l'impression que c'est du genre additif. Et donc, on aimerait avoir effectivement des essais maintenant dits de sécurité et d'efficacité cardiovasculaire pour voir la combinaison des deux si elle améliore le corps.
Oui, alors juste une dernière question, et je pense qu'on pourra clôturer après. Je sais que nos diabétologues s'attachent beaucoup à la metformine. Donc, j'ai vu les recommandations 2023. Est-ce que les analogues GLP-1 passeraient dans certaines catégories de patients diabétiques avant la metformine?
Oui. Alors, donc, je faisais partie de cette vague des recommandations ES et ESD en 2019, et on a été traité de hérétique par les diabétologues. Et en fait, on voulait faire bouger les lignes. Et on a réussi à faire bouger, puisque finalement, ESC 2023 dit ça. Si effectivement le patient est dans la maladie athéromateuse, c'est la priorité de mettre ces classes thérapeutiques. Alors maintenant, on peut, vous êtes pour certains cardiologues d'urgence, d'USIC, etc. On est en train avec Patrick Henry de rédiger une reco sur quoi commencer à l'USIC. Eh bien, probablement que l'agoniste du GLP-1 peut être commencé à l'USIC, éventuellement avec conseil du diabétologue, mais il n'y a pas de temps à perdre.
Merci. Alors, merci beaucoup au laboratoire. Donc, au laboratoire. Oui, une dernière. Oui, docteur Chabra.
L'effet sur la fonction rénale. Est-ce qu'il y a déjà une amélioration, comme c'est le cas des inhibiteurs de SGLT2?
Oui.
La deuxième, est-ce qu'il y a un obstacle à prescrire en cas d'insuffisance rénale?
Ah oui. Alors, donc, j'ai bien dit sur la protéinurie que c'est efficace, sur la microalbuminurie, c'est efficace, sur la créatinine, ça baisse dans le suivi, dans l'IDER, ça baisse moins que sous placebo. La créatinine, enfin la fonction rénale se dégrade moins que sous placebo. Ok, c'est significatif, mais ce n'est pas l'effet majeur comme il est constaté avec inhibiteur du SGLT2. Maintenant, jusqu'à quand l'utiliser? En fait, bon, on continue, même lorsque le DFG passe au-dessous de 30, voire de 20, on continue, alors qu'on est limité avec inhibiteur GLT2.
Alors, merci beaucoup,
Merci
professeur
beaucoup.
Valency, pour cette excellente conférence. Donc, nous remercions les laboratoires Novo Nordisk pour ce sympo toujours incroyable avec le professeur Valency. Et nous enchaînons directement sur le symposium Medtronic.
who's Dr. Dagmara from Poland. We will speak about renal denervation therapy, the back to the renal denervation, or back to the future, because the stop after Simplicity HTN3 is not only stop, it's stop and go, I think. And Dr. Dagmara will speak about this subject.
Good morning. Thank you very much, distinguished chairman, dear colleagues, ladies and gentlemen. I would like to thank the organizing committee and Medtronic for inviting me to this session and provide you with the update with the current position of renal denervation in the landscape of hypertension treatment. It's very important to stress that hypertension is a global pandemic currently affecting 30% of global world population. Hypertension is a treatable and modifiable risk factor. And if left untreated, uncontrolled hypertension initiates the domino effect and dramatically increases the risk of stroke, myocardial infarction, and over the longer term, development and progression of chronic kidney disease and heart failure. And moreover, the midlife hypertension is a strong risk factor for dementia and Alzheimer's disease. Blood pressure is poorly controlled all over the world, in both men and women. And if you take the entire global hypertensive population, between 50 and 60% of the hypertensive patients are diagnosed. From those who are diagnosed, less than 50% are treated. And very importantly, less than 25% who are actually treated achieve their blood pressure controlled. What are the reasons for poorly controlled blood pressure? An awareness of hypertension. Hypertension is a silent killer. 30% of patients do not have any symptoms, and they don't connect that perhaps headache could be the symptoms of blood pressure elevation. Patient non-adherence. Hypertension needs lifelong therapy, and 50% of patients stop antihypertensive medication within 1 year since drug initiation. Another important aspect is our doctors' roles, clinical therapeutic inertia. Only 1x6 doctors actually intensified hypertension treatment over the visit. Most patients just continue prescribing the same drugs without the blood pressure assessment. Unhealthy lifestyle, it's not only obesity, but from my experience, always is a salt intake and preserved food. And you can't imagine how often when patients cut down on salt intake and preserved food, the blood pressure is reduced and they don't need additional antihypertensive drugs. So in other words, it's responsible for so-called pseudo-resistance. And of course, disparity in healthcare. 2/3 of the global pandemic of hypertension is in low middle income countries. When, of course, the issue of drugs unavailability and drug affordability play a major role in blood pressure uncontrol, and also access to the medical insurance and healthcare system. So just simple blood pressure measurements can prevent this domino effect. And of course, when it's blood pressure control, it translates to the reduction of major cardiovascular events, stroke, heart failure, ischemic heart disease, and cardiovascular death. Excuse me. Oh, sorry. Something went wrong. Can I get to the slides? It's something wrong with the pointer. Is the slides number 6 or 7? I apologize for this.
Here we go. It's very important. So the blood pressure reduction is strongly related to the proportionally to the blood pressure decrease. Something wrong. Whether it's related to 5 millimeter of mercury reduction or 10 millimeter mercury reduction. So the current antihypertensive guidelines, they provide the evidence that the primary goal is to lower blood pressure in the vast majority of patients below 130/80. And when you see in this green zone, that I will not use the pointer because it's some issue when moving towards this with the slides. So the vast majority of patients, when you see in this red box, we aim to reduce the blood pressure below 130/80. This is particular to the age until 65. And in those who are older, the age of 75, this is the green zone for systolic blood pressure. If well tolerated, we also aim for this blood pressure goal. With the diastolic, it's very easy, between 70 and 80% for the vast millimeter of mercury for the vast majority of patients. However, we don't do attempt to lower blood pressure lower than 120/70 millimeter of mercury. The current hypertensive guidelines recommend the use of well-known antihypertensive drugs. However, these drugs do not suppress all mechanisms underlying hypertension or completely suppress a single pathway, leaving contrarregulatory escape mechanisms that also impact over the longer term for blood pressure control. Renal denervation has generated great interest over the last decade among all device-based therapy. And what is the advantage of the renal denervation? In addition to efferent sympathetic nerve inhibition, which most of the antihypertensive drugs works, renal denervation also targets the efferent renal nerves, which coming from the kidney to the brain and influence the central sympathetic blood pressure control in the brain, which of impact on the target hypertension-mediated organ damage. And our experience is with the patient treated with renal denervation in resistant hypertension, there is sympathetic inhibition after the renal denervation, and this effect is sustained out to 12 months post-procedure. This initial excitement with the renal denervation was cooled down after the publication of the Simplicity Hypertension 3 trial, which fails to meet the primary efficacy endpoint. And what we see on the slide, there was no changes in 24-hour systolic blood pressure measurements between sham-controlled and renal denervation group at 6 months after the intervention. However, we need to point limitation of the Simplicity Hypertension 3 trial. It's very important when we assess the true effect on new device treatment that we don't play with the drugs changes. As what you see, 40% of patients in the Simplicity Hypertension 3 trial have changed this medication before the 6 months, before the primary efficacy endpoint was assessed. The second important issue with this trial was there was 70% did not have proper complete renal denervation. In other words, their kidney were not denervated. Only 19 patients had 2 complete nerve ablation in both renal arteries. Further limitation is that we have over 100 operators in more than 80 centers in the United States. Some of the doctors just performed their first procedure in their life. And in Australia, we didn't have any method to verify the completeness of renal denervation, as you remember from my previous start with the microangiography assessment and sympathetic inhibition. And what we learned from the Simplicity Hypertension trial to account for this limitation when design next generation trial, also the importance is to perform circumferential nerve ablation and focal nerve ablation, not only in the main renal arteries, but also provide radiofrequency ablation close to the ileum and treat the branches of the renal artery. And we now have robust evidence that renal denervation is effective according to the clinical trials, the second generation sham control trials, who were blinded not only to the patient but also to investigators. This trial as an efficacy primary endpoint used 24-hour ABPM. These trials were performed in the presence or absence of antihypertensive medication in patients with uncontrolled hypertension and resistant hypertension. However, in 2018, the European Society Hypertensive Guidelines did not recommend renal denervation until further evidence regarding the safety and efficacy become available. And this document were mainly based on the Simplicity Hypertension 3 trial. Although at the time of publication, these guidelines were already out of date because, as you remember from previous slide, this high second generation trial were published between 2017 and 2022. Therefore, there have been multiple consensus statements on requiring the update on the guidance for hypertension treatment, which included the second generation trial. Therefore, the recent 2023 European Society Hypertension Guidelines, based on this robust second generation trial, recommend renal denervation as a safe and effective adjunctive, meaning complementary treatment option for the treatment of uncontrolled hypertension. This trial and the evidence, the guidelines use class recommendation B, which we have surrogate measure, we have randomized controlled trials, but B because there are not outcome study. So now we have turning point to hypertension management. Renal denervation is considered as the third pillar in hypertension treatment following lifestyle modification, physical activity, reduction in body weight, reduction and cut on alcohol intake and salt, in addition to medication. But if still patient is difficult to control hypertension, we have option to perform renal denervation. And the current statement recommendation of hypertensive 2023 guidelines is that renal denervation can be considered in patients with uncontrolled hypertension, with GFR above 40, when treatment drug elicits side effect or poor quality of life. The second recommendation for renal denervation is in patients with treatment-resistant hypertension with GFR above 40. But very important class 1 recommendation is that renal denervation should be offered following shared decision-making process, which is key, discussion between patient and doctors, and also should be performed in experienced specialized centers. Most importantly, not only to guarantee the proper patient selection and structure pathway for hypertension assessment, but also experience in the procedure interventional doctors. When you think about the first uncontrolled hypertension, we have, in addition to this second generation trial, pooled analysis show that renal denervation reduced 24-hour blood pressure and also office at 6 months follow-up. Very important aspect, antihypertensive drugs do not cover 24-hour period for blood pressure assessment. Therefore, when patient needs to take another tablets on the next day. With renal denervation, we have 24-hour always-on effect in patient in the absence of medication. This is particularly important in the morning hours, where is the morning set, where is the time when more stroke and myocardial infarction occurred. The same effect, what you can see in the renal denervation demonstrate always-on effect on 24-hour blood pressure reduction in patient in the presence of medication. Very important, From the global registry, we know that more than 30% over the 3-year duration achieve the reduction in blood pressure, and they are in the target zone, meaning the blood pressure is controlled, which impact cardiovascular outcome. We have also long-term experience from Australian and German patients, up to 10 years, that renal denervation reduced the blood pressure 24 hours over the longer term and out to 10 years without adding medication. And actually medication better, what you can see on the bottom, is reduced. What about patients with resistant hypertension? It's very surprising, and it's very nice that when we confirm true resistant hypertension, which actually affect less than 10, around 5% of the entire hypertensive population, as a first-line therapy, what we heard yesterday from Professor Neil Poulter is ACE, ARB inhibitor, calcium channel blocker, and diuretic, because this is the definition if patient is not controlled with antihypertensive drugs, including diuretic, and confirmed by 24-hour blood pressure measurements. As a fourth-line therapy, we can add spironolactone or beta blocker or alpha blocker or centrally acting drugs or renal denervation. What you can see, it's class 2 recommendation. So we have option, renal denervation also as a fourth-line therapy if patients do not tolerate drugs like spironolactone or beta blockers is contraindicated or alpha blocker. Most important aspect is the safety of renal denervation, and we know evidence that there is preserved renal function. From my experience in the renal denervation chronic kidney disease, we know there is slow the progression, but also we know there is some improvements in GFR. So in terms of the renal function, the procedure is safe, and also in terms of the renal artery. Very important aspect, that renal denervation should be done in a shared decision-making process after objective and complete patient information. This is very important, and is highlighted in multiple expert consensus statements that patient perspective and preference is very important when we make decision whether to treat with pharmacotherapy or whether to add renal denervation. And when it's factors which may influence patient decision, and preference, it could be drugs intolerance. Maybe they can perceive that the high blood pressure is a significant risk factor, or maybe they have some experience to the emergency admission because of the high blood pressure. From the doctor's perspective, could be elevated blood pressure, patient at high cardiovascular risk, and multiple drug regimen. And when patients in Germany or Japan were asking, what would you prefer, rather go for renal denervation add-on therapy, 30% of patients expressed the interest in renal denervation. When you look at the slides, doctors are likely to recommend renal denervation, and you see this green zone, that when it's higher blood pressure level, and also the higher number of medication. This is completely in contrast to the patient preference that the bottom, you can see that they consider renal denervation irrespective of number of drugs and irrespective of elevation of blood pressure, even they are more prone to go for the renal denervation in the absence of medication. Very important aspect when we talk patient about the risk and benefits, and they were asking multiple questions about the vascular injury, side effect, pain, intervention, duration of defects, that blood pressure reduction was the strongest influence on the treatment choice for patient. And they would accept even small reduction in blood pressure by 2.5 millimeter of mercury in the maximal acceptable risk of 20% of potential vascular injury or side effects. Very important, which was also the limitation of the Simplicity trial, renal denervation should be performed in experienced specialized centers. Why is important? We required a multidisciplinary team which should include experts in hypertension and the vascular intervention. The multidisciplinary team should be helpful to implement renal denervation in the structured pathway hospital following guideline-based intervention, including proper blood pressure assessment using 24-hour blood pressure measurements, arterial imaging, and also follow-up visit. Data should be provided to the registry and is clear signals to the payers for the reimbursement of the renal denervation. Shared decision-making is crucial before we decide and discuss with the patient what are benefits or risks related to the procedure. And this requires really clear discussion with patient, and we need to incorporate patient preference. In conclusion, as officially recommended in 2023, renal denervation is recommended as a complementary approach in patients with resistant hypertension and uncontrolled hypertension who cannot tolerate blood pressure-lowering drugs with eGFR above 40. Renal denervation is safe at the time of the procedure and in the longer term, what we learned from the Global Simplicity Registry, but also from Australian and German experience. In contrast to blood pressure-lowering drugs, renal denervation ablates both efferent and afferent renal nerves, which are not targeted with the drugs. And we know also from other trials which are currently ongoing that renal denervation provides cardioprotective and nephroprotective effects in addition to blood pressure reduction by targeting sympathetic nervous system. Thank you very much for your attention. This is my contact details. If someone can you reach? My name is Dagmara, is Adebrand in Europe, and my surname is Herring. Thank you very much.
Thank you, Dr. Dagmara, for this very interesting lecture and for the renal denervation therapy. Are there any questions in the audience? Dr. Selma Abdeslam.
Some patients won't get medication for essential hypertension when it is discovered. Do you think that renal ablation may be an alternative to patients who don't want to take medication as a first line?
Observational studies demonstrate that renal denervation is effective in drug-naive patients. But we have to follow the guidelines, what is available. At this stage, if patients experience side effects of the drugs, do not tolerate, it's not written drug-naive, that clear, but if for any reason doesn't want to take the drugs because of pure quality of life or is intolerant to drugs, and even taking one drug, this is how I read the guidelines, the renal denervation is considered as an alternative option. What I would like to point that patient, this is why shared decision-making process. Renal denervation, it needs to be as an add-on therapy to lifestyle modification. Many patients who are referring to me for the renal denervation, I diagnose pseudo-resistance, meaning they have white coat effect, that's why we need 24-hour blood pressure measurements to confirm resistant and perhaps confirm pill taking, observed pill while performing ABPM. And the salt intake play a crucial role in pseudo-resistant. So in other words, if we treat patients with renal denervation, the expectation may be wrong and misleading due to unhealthy lifestyle. So that's why it's class 1 recommendation of the guidelines, clear discussion with the patient. And if patient is compliant, then that makes sense. Otherwise, we may get wrong data, collect. If we think about the reimbursement in the country and starting to perform the procedure, the renal denervation is not effective. So this is very clear class 1 recommendation. In addition to lifestyle and consideration of medication, proper documentation and discussion with the patient.
Thank you very much. Very excellent presentation. It looks like you are in charge of the blood pressure. I mean, if you have a patient with hypotension and heart failure, HFrEF or MREF or PF, which one is more will cause and create hypotension when the patient is treated? Which type of the heart failure?
Heart failure is a consequences, or mostly with HFpEF with uncontrolled hypertension over the longer term. We have evidence not from the second generation trial, but also one first generation trial, also our own experience in Australia to perform renal denervation in heart failure patient. But we didn't observe hypotension. We observed increase in 6-minute walk test, the reduce of the symptoms. Ejection fraction remain stable. But there are patients with heart failure. High blood pressure is not the problem. We just give the drugs to prevent the exacerbation of heart failure and actually maintain the ejection fraction or even increase. And now we have recommendation of drugs. From my experience, like SGLT2, it's a breakthrough in the management of patients with heart failure. I see dramatic increase in ejection fraction within the months. Why? 1 month, 2 months. Why? Because we straight away, patient increases the maximum dose, 10 milligram, empagliflozin or dapagliflozin. The other drugs like beta blockers, ACE inhibitors, spironolactone, we need to uptitrate because only the high dose of drugs were proven to reduce mortality. But we are almost not able to increase the drugs because of the low blood pressure. So in heart failure patient, the management is it's very complex. And due to water retention, the sympathetic nervous system plays role, and the sympathetic nervous system predict mortality in this patient. At this stage, we have currently ongoing second generation trial with sham control in patients with heart failure, and maybe we will learn soon about the management. But currently, we have proper European Society Cardiology guidelines for heart failure management.
Thank you. Thank you.
I have one question, please. It was demonstrated some effect in heart rhythm disturbance, in particularly atrial fibrillation. So what is the explanation? And is it an addition factor to indicate renal denervation in patients who had hypertension and atrial fibrillation?
It's a very good point. Thank you for this question. Currently, atrial fibrillation not yet in the guidelines is very similar to chronic kidney disease patient, heart failure, obstructive sleep apnea, atrial fibrillation. We have currently ongoing second generation trial. From the current experience, including my patient treated with renal denervation, atrial fibrillation is, I would say, is a potential and electric storm potential for renal denervation. We know, and with the longer term, 12 months, that patient who has add-on therapy to pulmonary vein isolation and renal denervation, there is reduction in AF recurrence up to 12 months post-procedure. But we also know that in AF patient, what may trigger, and we need to rule out, is obstructive sleep apnea. As you know, obstructive sleep apnea is associated with tachycardia, bradycardia syndrome, and atrial fibrillation over the night. So if we perform renal denervation and pulmonary veins isolation, if we didn't diagnose early the obstructive sleep apnea, the effect, even pulmonary vein isolation, could be less effective. So we need to also treat with CPAP therapy if required. So it's very important to rule out this before we consider. But the evidence is strong. If I could, we have pre-European Society Hypertension meeting in Athens in April, and I was giving a talk of the indication for renal denervation beyond hypertension. And I was asked by the chairman if I could choose 2 conditions for renal denervation, which I would choose. And I will always go with atrial fibrillation And my second is related to the chronic kidney disease patient with my own experience working in Australia with chronic kidney disease patient. Because we saw that renal denervation, since you perform, it's halt the progression. GFR is stable, it's not further progression. And this is very important if we can delay the progression of the disease. In atrial fibrillation patient, it's very important to look for the left atrium. It's hypertension-mediated organ damage. Not all patients can go under pulmonary vein isolation. So it's really, we need to do a similar structure for the assessment of the patient. I'm assuming will be similar structure pathway for patient evaluation like in hypertension. Rule out pseudo-resistant, check on healthy lifestyle, and EAF patient will be very similar structure pathway before we consider. But I fully agree, it's also reduction in sympathetic nerve activity. And I don't observe any hypotension in this group of patients following renal denervation. And it's add-on 24-hour effect.
Very much for this interesting presentation. Maybe I have a basic question. How to explain the difference in outcomes between old studies and current studies?
Which studies?
By how to explain the difference in outcomes between old studies and current study.
The studies in renal denervation.
Yes.
As an outcome, you mean blood pressure?
Yes.
Reduction. So it's a very simple question to some extent, because we learned from the Simplicity Hypertension trial, free trial, that we need to perform circumferential coverage in the renal nerves, that the nerves are towards the aorta. There are different distribution of the nerves and towards the hilum of the kidney. And we also learn that multiple renal arteries, if they are not denervated, they may impact on blood pressure response. So the second generation trial were very rigorously designed, meaning there were proper arterial imaging. And I was also involved in the second generation trial. So the patient who has renal anatomy were ineligible. They were excluded from the trial. They was confirmed with 24-hour blood pressure measurements. There were medication adherence confirmed for the drugs assessment or observed pill. So this trial were very different from the first generation, and also in the first generation trial, we did not perform, like with the spiral, catheter, the fourth ablation. We ablate separately. So the ablation was different in the first generation trial compared to the second generation trial.
So isn't the same device?
It's the same radiofrequency method, but it's different device. Because the second generation, the spiral catheter do multiple, as you remember on my side, focal. And we perform one ablation, which covers circumferential coverage. In the first generation trial, we need to ablate each point. I was standing behind 300 renal denervation procedure behind the interventional doctor, so I exactly know where we need to put. Each ablation point was 5 millimeter difference. So we try to ablate superior, anterior, inferior path of the artery, sometimes performing multiple ablation as we can. In the second generation, the procedure is shorter because at the same time we ablate circumferential renal artery, and if there are additional renal arteries like branches and the diameter is between 3 and 8 millimeters and allow us to position and accommodate the catheter, we also ablate.
Thank you, Dr. Dagmara. You restored the hope to find the third pillar for the treatment of the resistant hypertension. Thank you, Medtronic. It was a very nice session. Thank you.
Thank you very much.
speak, I know just what you're saying. So please stop explaining. Don't tell me 'cause it hurts. Don't speak, I know just what you're thinking. And I don't need your reasons. Don't tell me 'cause it hurts. Our memories, they can be inviting, but tomorrow to get mine, frightening. And as we die, both you and I, with my head in my hands and sit and cry. Don't speak, I know just what you're saying. So please stop explaining. Don't tell me 'cause it hurts. Don't speak, I know just what you're thinking. And I don't need your reasons. Don't tell me 'cause it hurts. It's all ending. I gotta stop pretending who we are, who we You and me, I can see you sighing. Are we? Don't speak, I know just what you're saying. So please stop explaining. Don't tell me 'cause it hurts. Don't speak, I know just what you're thinking. And I don't need your reasons. Don't tell me 'cause it hurts. Don't speak. Like the legend of the phoenix, all ends were beginnings. What keeps a planet spinning? The force from the beginning. We've come too far to give up who we are. So let's raise our bar and our cards to the stars. She's up all night to the sun. I'm up all night to get some. She's up all night for good fun. I'm up all night to get lucky. We're up all night to the sun. We're up all night to get some. We're up all night for good fun. We're up all night to get lucky. We're up all night to get lucky. The present has no rhythm. Your gift keeps on There's a bar and a cups to the stars. She's up all night to the sun. I'm up all night to get some. She's up all night for good fun. I'm up all night to get lucky. We're up all night to the sun. We're up all night to get some. We're up all night for good fun. We're up all night to get
Allô, allô, allô. Allô, allô. Vous m'entendez? Vous m'entendez? Oui.
friend, Dr. Dania Moti from KSC, to talk about amyloid cardiomyopathy, the red flags. It's up to you, Dr. Dania.
Et ça, c'est pour... OK. Salam alaikum. Bonjour. Good morning, everybody. I am very happy to be with you today, and I would like to thank the organizing committee for this kind invitation. I hope you are hearing me. Is it clear? Okay. So we'll talk about a disease that is gaining a lot of interest. I'm not sure if this slide, I should start them with this one. Yeah. So I work nowadays in Riyadh, King Faisal Hospital in Saudi Arabia, and I have no conflict of interest regarding this presentation. As you know, I cannot in 10 minutes cover all the aspects of amyloidosis. I have 669 slides, but I will try to focus on the main point. So amyloidosis is a group of disease that is due to extracellular deposition of insoluble amyloid fibrils. Amyloid heart disease is often underdiagnosed or misdiagnosed everywhere in the world, not only in Riyadh, not only in France, everywhere, because it can simulate many other diseases, and clinical manifestations actually are misleading and depends on the state of amyloid deposit. Its diagnosis implies integrative approach using clinical clues, EKG, echo, and sometimes MRI, and multimodality imaging, and sometimes tissue biopsy is mandatory to reach the diagnosis. However, please remember, a high index of suspicion is the key to find this patient. You know, there's more than 20 precursors of amyloidosis that can create the disease. I want you to remember only 2. At the left side, the blue, the transthyretin amyloidosis, which can be either hereditary one or the acquired one with the elderly. We used to call it senile amyloidosis in the past, which gives the position of wild-type transthyretin. And the hereditary one, it's due to autosomal dominant disease in chromosome 18 and due to deposition of mutant transthyretin. Both this one are due to liver abnormalities. It's a liver disease. On the right side, you have the light chain amyloidosis. It's a toxic disease. It's a hematological disease, and due to deposition of light chain due to plasma cell dyscrasia. Basically, you have a plasmocyte monoclonal things in the bone marrow that gives toxic component M monoclonal component that takes light chain. Light chain are very toxic for the heart and for the organism, and they misfold and they give amyloid fibrils in many organs. Just again, I'm telling you this is very important. Please remember, light chain amyloidosis is an acute disease. It kills people. It has to be treated and it needs to be urgently diagnosed because the survival is 4 to 6 months if the patient presents already with heart failure. On the right side, ATTR is more kind of chronic disease. It's less urgent to diagnose, and the median survival is 4 to 6 years if untreated. So please remember, I want you to really recognize the light chain amyloidosis. We can save lives. However, the diagnosis of amyloidosis is not straightforward. I mean, it's not like a COVID, you do PCR, you have the disease. Here, you need to put things together. I call it like a puzzle. You need echo, EKG, PYP, MRI, clinical assessment, lab test, biomarkers, sometimes tissue biopsy. Okay, this is a slide. It comes from the JAC 2003, and you can see that the clinical manifestations are very diverse with ATTR cardiomyopathy. It can be a cardiac manifestation, musculoskeletal, polyneuropathy, autonomic dysfunction, and that's why it leads to errands of the patient. It goes from doctor to doctor, they travel everywhere, and they see basically almost in 50% of the case 5 doctors before they reach the diagnosis. I give you more images here because extra cardiac signs are very important. We know we're all cardiologists here, and we don't have the time to examine the patient. But remember that extra cardiac signs have a very good positive predictive value in the setting of unexplained dyspnea and suspicious echo. On the left side again, I put you the signs that are more likely associated with light chain amyloidosis, the ecchymosis, the soft tissue manifestation, the nephrotic syndrome, the lung edema, all the things, and the macroglossia that are more likely to be with light chain, and the other things with ATTR, the musculoskeletal manifestation, the spontaneous rupture of the tendon. You will be very proud in front of your resident if you do this and you will make the diagnosis, because not many diseases give you this rupture spontaneous tendon. The carpal tunnel syndrome, ask the patient if he has surgery before. And in the middle, you have the common one, the orthostatic hypotension or the peripheral neuropathy. So I know there is a lot of information, but remember 3 things. If you have cardiomyopathy, neuropathy, and nephrotic syndrome, both together, remember it's light chain until otherwise proven. You have to demonstrate that it's here or to rule it out. On the other side, if you have a heart failure unexplained, neuropathy, carpal tunnel syndrome, and hypotension, remember, it could be ATTR and do PYP scan to rule out this disease. Really, really, it's important. Now, this is just to give you an idea because I'm passionate about echo and I love echo. Look, this is ATTR damage and this is light chain damage. This occurs over years and this is occur over months. You can see that the thickness of the heart is much less in the light chain because the patient does not have the time to live enough to be thick at up to 18. So basically around 12 to 30 millimeter. But the damage are almost the same, but it's a kind of time. Okay, now the key electrical findings is the relative low voltage, which means relative low voltage is discordance between LV wall thickness and the QRS voltage. You have to put always the echo and the EKG together, and you read that one together. And there is, the QRS voltage is lower than expected for the LV wall thickness. I put you here, this is, we call it again, I will give you another. This is other sign. The most frequent sign in ATTR is the pseudo-infarct pattern in V1, V2, V3. It looks like somebody who has myocardial infarction, but actually is a chronic over time, and the troponin, you don't have the same kinetic over time. Now, many people, and we learn this in medical school, you have the absolute low QRS voltage. It's not very common, actually. It's more common in the light chain, and actually it's more a sign that late stage of the disease. In other words, we wait too long to diagnose the patient, and they may have the absolute QRS low voltage. Now you have, of course, unexpected conduction disturbance, arrhythmia, atrial fibrillation in 50% of the case, LBB, left bundle branch block, AV block. LV hypertrophy is rare. However, you can have an EKG like 10 to 20% of the patient. So remember, pseudo-infarct pattern, atrial fibrillation, and relative low voltage. Now, I cannot talk about echo. I can talk for 2 hours. I will summarize on one slide all the signs that you need to know in cardiac amyloidosis. It's severe heart failure, contracting with apparently normal ventricles, blindly diffuse deposit of the amyloid fibril everywhere, LV, RV, IVS, valves. Impairment of the LV long axis. Remember, this is very important. When you have small S wave, small MAPC, and you have low GLS, all the sign, they have a good sensitivity and specificity for differentiating cardiac amyloidosis from other type of disease of hypertrophic state. And you have to calculate sometimes the apical to base ratio. You have also small pericardial effusion in 50% of the case, and you have pulmonary hypertension, and it depends actually on the stage when you discover the disease. You can have high RA field pressure, high LA field pressure, high PA pressure, and low stroke volume. This is alteration are almost here when we discover this patient. Now, what about aortic stenosis and ATTR? I cannot talk about all the study. I summarize for you everything. Basically, associate aortic stenosis with ATTR is present in 8 to 15% on those undergoing TAVI population. The mean age are higher than the AOS alone, 80 years. 70% of them are male, and most of the time they present with low flow, low gradient aortic stenosis. So it's a very common condition now, and we are counting between, and our experience is around 10% of the population. Now, when we are talking this morning with Dr. Hussam about this diagnostic value of CMR, it's a good, I call it, it's a super powerful echo. It has a good resolution, and it gives you the same morphological information as echo in terms when patient is very acoustic, have acoustic window, and also it gives you tissue characterization, of course, which echo cannot give. All pattern of late enhancement are possible in this disease. You can have the patchy, you can have the transmural, you can have the subendocardial. The thing that's very important is the short inversion time, suboptimal nulling. This is very common in this disease, and the radiologist is not able to try to find this time. The most common and the most, modern things is to look at the T1 mapping and the extracellular expansion. And when you have a T1 mapping more than 1164, it's really diagnosis at 92% of the case of the disease. So look at this sign if the other sign is not good. Now, when you should use hematological test and biomarker, they should be done actually for every patient with suspected cardiac amyloidosis. The free light chain, the serum and immunofixation, the abnormal kappa over lambda, and of course the troponin and BNP can give you a prognostic staging of the disease, especially in light chain amyloidosis. Finally, the bone scintigraphy of the heart is a cornerstone in ATTR. It has a very good sensitivity and specificity, more than 92% for detecting ATTR, and it does not diagnose light chain. Remember, they don't bone for the calcium. It helps distinguish between ATTR and light chain and other disease, and grade 2 and 3 uptake confirmed by SPECT imaging. And if you are able to rule out plasma cell dyscrasia, is diagnostic of ATTR, and we don't need to do any cardiac biopsy for this patient. In other words, it has a 100% positive predictive value. But I want you to remember, you have to have the planar imaging. This was the mistake many years. If you have a planar showing uptake, you have absolutely to do a SPECT imaging to cut the heart in transversal and to see that the uptake is in the myocardium, not in the cavity block. So the ratio is, sorry. Okay, I'm done, actually. When should you perform tissue biopsy in cardiac amyloidosis? You have to do biopsy to prove the presence of light chain amyloidosis only in light chain. You don't have to do it for TTR because you cannot give chemotherapy for this patient. You don't have to do cardiac or renal. You can do subcutaneous, fat, rectal, accessory, salivary, whatever your center is good on it. And you have to type the original protein should be performed as mass spectrometry because you cannot treat ATTR as light chain and vice versa. Actually, when you should perform genetic testing, and this is my almost final slide, differentiate between wild type and hereditary ATTR, differentiate between light chain and other amyloidosis subtype, phenotype and genotype correlation, and family screening. So as you can see that the timeline, the best time to diagnose patient, and when you look at the orthopedic manifestation, and that time the prognosis is much better than when you look at the clinical dyspnea, heart failure, or something which is goes at the up. Echo and EKG are unfortunately late on the line of the diagnosis. Remember, the earlier the better. If we are able to see patient at the stage of carpal tunnel syndrome or orthopedic manifestation, you have better treatment and you can, rather than stage C. In summary, my friends, please have a high index of suspicion. Look at the clinical clues, cardiac and extracardiac sign. Suspicion phase involve echocardiography, EKG, sometimes MRI. The homological workup is mandatory for everybody, and the confirmatory phase implies bone scintigraphy of the heart, tissue or heart biopsy, and please treat as soon as possible. You have for the first time guidelines, typical guidelines in European Heart Journal to tell you the role of each parameter and each testing and according to the guide. I don't have the time to go through it, but really it's what I told you. And actually you have also the consensus European from Pablo Garcia, and you have even the American now. Everybody is running after amyloidosis now. So it's really gaining a lot of interest because of the new treatment we have. So the journey of cardiac amyloidosis is very long, and you need to work with your colleague. You cannot work on yourself. You have to work with the hematologist. You have to work with nephrologist. You have to work with all the other people, and you have to create in your center a cardiac amyloid team, as we did in Riyadh. And because if you want to go fast, you have to go far, you have to go with other people. So please create your own team. Not everybody is involved in amyloidosis. Not everybody like this disease. So you have to choose your own people whom you want to work. And take-home message, work as a team, look for clinical clues, look for echo, EKG, sometimes MRI, order bone scintigraphy, protein immunofixation, and discuss supportive and disease-modifying treatment according to the country. And please, please have a high index of suspicion. If you don't think about it, you will never diagnose it. Thank you so much.
Thank you so much, Professor Dania, for this wonderful presentation. We will allow for some time for discussion at the end of the session. So you can join. Professor Stephen Anker is online.
Hello, everybody.
Professor Stephen, how are you? Yeah, sorry, it's recorded. Okay. So I have the pleasure to introduce Professor Stephen Anker. He's a well-known expert in the field of heart failure from Charité University, Berlin. And he's going to talk about HFpEF obesity therapy. Okay.
Really to speak to you about obesity therapy in HFpEF, where of course you know there is quite some interesting advances. Of course, when you talk about obesity in HFpEF, I should say the very obvious thing to begin with: take the guidelines and treat your HFpEF patients, and that also means you treat the obese HFpEF patients. And the most important part is give them diuretics when they have congestion. And of course, now give them SGLT2 inhibitors. EMPA and DAPA have a 1A recommendation for obesity. And you can see basically that even in the patient profile type approach to treating patients with HFpEF that we recently published about in the European Journal of Heart Failure, the center, the core of the therapy is SGLT2 inhibition with diuretics, but then you have all the different phenotypes around it. But one of them is obesity, and we already mentioned semaglutide and tirzepatide possibly there, and I would like to share with you some of the data why we are doing it. Of course, you're knowing that our most interesting new therapies for HFpEF come out of the diabetes world. We have the SGLT2 inhibitors. They are basically reducing blood glucose by inhibiting renal reabsorption of sugar. We have also the GLP-1 agonists. The two trials in HFpEF that really are key are the DELIVER and the EMPEROR-Preserve trial that showed overall that HFpEF patients get a benefit, and importantly, they also get this benefit in the obese subgroup. Now, some of you might argue, well, maybe we should use SGLT2 inhibitors specifically to treat patients with obesity. On the one hand, that is true because you get a good quality of life benefit. Here on the left, you can see that the benefit is highest in terms of change in quality of life measures. The benefit is highest in the most obese patients, but they also have the worst quality of life to begin with. So maybe there is some degree of a regression to the mean problem here. Some others of you might say, well, what about the weight change? And on the right, you can see with dapagliflozin, very similar with empagliflozin, we have a modest at best change in body weight, about 2.5 kilograms for patients with BMI above 40. This is not a specific obesity therapy. It's a general therapy of HFpEF that also works in obese patients. Still, we need to take care of obesity. Obesity is very frequent in HFpEF patients. So what do we do about it? And now we are coming to the GLP-1 receptor agonists. Let's start with semaglutide, where we really have most of the data. And this is just a small review of the different trials done with 2.4 milligram of semaglutide, a subcutaneous once weekly injection, and showing that in all sorts of trials, in all sorts of conditions, you get a strong weight loss. And this was the reason why then also trials in heart failure patients with a preserved ejection fraction were started. One trial is still ongoing with semaglutide, and that is the trial in diabetic patients with HFpEF. BMI above 30, ejection fraction above 45, randomized 1-to-1. Okay, we will see how this trial is going, and it looks for multiple endpoints, but body weight and quality of life are the key. With the same endpoints and a total of 529 patients, recently the STEP HFpEF without diabetes trial reported. This was shown at the ESC. It's now published this week in the New England Journal, also in print. And this is how the trial looked like: 1-to-1 randomization and 1 year of follow-up. Kansas City Cardiomyopathy Questionnaire, 8 points improvement on average. This is approximately the highest amount of improvement we see with any treatment in heart failure. Of course, it's for the subgroup of obese patients where you have really a poor quality of life to start with. If you look into the body weight, of course, this is important in obesity. The change between the groups was 10.7%. The change in the placebo group, 2.5%. The change in the treatment group, 13.3%. So this is a massive reduction in body weight. And this is also related to a 20-meter improvement in 6-minute walk test. All of this just published. Now, you might say mechanistically, what is really this treatment doing to the metabolism, to the inflammation, to the heart function? Well, for CRP, we can tell a 39% reduction of CRP. We know that inflammation plays a role in HFpEF, so maybe that's also a good thing to see in these patients. We do have a reduction that is substantial for CRP. We do also have a reduction that is substantial with anti-BNP. Now, this 16% reduction might seem to many of you not very impressive, but don't forget, the patients are losing fat tissue. Fat tissue is known to bind natriuretic peptides. So the patients with the weight loss have a more amount of fat tissue loss, so they should have less binding of anti-BNP, and so the BNP should be more in the circulation, and still we see a reduction. So this reduction is likely an underestimate of the true change in natriuretic peptides. There is also some cardiac benefits. What about safety? Well, in general, the number of serious adverse events was less in the semaglutide versus the placebo group. If you, for instance, look here at cardiac disorder side effects, a strong reduction. Cardiac events really were reduced in the patients, and you can see all sorts of other things. There is relatively little that is basically related to the problems. The only thing we see is gastrointestinal adverse events. Of course, that is part of the effect. You have a premature filling feeling, you have constipation, and this is something you might argue is actually due to the having less food intake due to the body weight reduction. Now, these metabolic effects that I describe you now from the STEP HFpEF trial are also seen in general with semaglutide in different populations of diabetic and obese patients. Reductions in hemoglobin A1C, reduction in blood pressure, reduction in CRP, and all of this associated also with reductions in lipids. And you might ask yourself, well, what about changes in cardiovascular outcomes? Well, and for this, there was a big trial where recently a press release gave us some hints. So this is all really creating a lot of optimism. 17,000 patients randomized, non-diabetic patients, BMI of 27 or higher, at least 45 years. And in this trial, for instance, and this will be very interesting, also more than 4,000 heart failure patients. I would assume mostly HFpEF patients, but we don't know that yet. We don't know. Only thing we know is there's overall a 20% reduction in MACE events. This was reported as a press release. The patients treated with semaglutide had less death, stroke, and MI in this trial. I would assume that later this year we will see all the details. Now, ultimately, is there more to come? Definitely yes. Tirzepatide is a dual receptor agonist for GIP and GLP, and you might even have a little bit more weight loss with this therapy. You can see you might even have on average 15-20% in diabetic populations with tirzepatide, as shown before. Is there a heart failure trial ongoing? Yes, there is. It's actually of a longer duration. It tries to do like a 2-year follow-up. It tries to analyze with a win ratio, death, hospitalization events, and then also quality of life changes and exercise capacity changes. And this is planned as a registration trial. We will see whether this works, but quite a number of people are optimistic. So we can basically say today that obesity therapy is possible. We have many opportunities for phenotypic approaches to the patients. The core number one is SGLT2 inhibition, but very soon, I believe, we will also have a specific anti-obesity therapies as part of it. The future is very bright. Thank you so much for your interest. Okay.
Professor Stephen, do you hear us? Hi, Professor Stephen Anger. Hi. Hi, this is Magdi. How are you? Yeah, do you hear us? Dr. Stephen? If there is a problem, we can go to the next speaker and come back to Professor Stephen. Okay?
So I think we pass to the next speaker, and Professor.
Thank you very much. Now, our friend, Dr. Walid Amara, will speak about ECG and arrhythmia ablation, diabetes, heart failure, HFpEF. Voilà. heart failure à fraction d'éjection préservée.
Merci beaucoup. Thank you very much for the invitation. It's a great pleasure to do this topic for you today. And you asked me about to speak about ICD and atrial fibrillation ablation in the case of
Please, the presentation. Excuse me.
Maybe we have Professor Hanker.
Yes, I'm here.
Do you hear us?
Yes, I do hear you perfectly well. Thank you.
Good.
Hi, Professor Stephen. How are you?
Very well, thank you. Good day. Hi.
We are delighted that we are having you for the next second day of the meeting, and we enjoyed your presentation. I have a question regarding the results of STEP-HFpEF. Is there an impact for the comorbidities which are common in patients with HFpEF regarding the endpoints of the study?
Well, the biggest impact is of course on obesity itself. We don't know yet whether there is other impact on atrial fibrillation, for instance, on the presence maybe of diabetes in the future. The patients included in the trial were non-diabetic patients, so it's possible that over longer follow-up we will see differences there. But on the other hand, of course, the study is relatively small with 529 patients and only 1 year of follow-up. So maybe we get more ideas about the impact, long-term impact on other comorbidities by, for instance, in the near future, seeing the results of the SELECT trial, where we have 17,000 patients with much longer follow-up. In STEP-HFpEF, we don't know that information yet.
Do you think that involving the hard endpoints like all-cause mortality, heart failure hospitalization, so we have seen only quality of life, Kansas City cardiomyopathy questionnaire, body weight reduction, so the hard endpoints which are very important in the measure.
Yes, of course, they are in the long term really important, but we should distinguish. Is this a useful therapy for patients with obesity and heart failure with preserved ejection fraction? I think it is, because making them lose more than 10% body weight and improving their quality of life and exercise capacity is useful. Is this the best possible result already? No. As you say, we need hard endpoints as well. In this study, we saw from a safety standpoint, there were, in terms of the summary of all cardiac disorders with heart failure, atrial fibrillation, and flutter, or presence really of congestive heart failure, we saw that there was a total of 43 events in the control group and 8 events only in the intervention group, which is like a difference of more than a factor of 4 to 5, highly significant result. This is of course not the same as having a trial that is big enough to be powered for such endpoints, but it's really valuable that at least things go in the right direction. And I could imagine really a reduction of heart failure hospitalization in such patients, but you're right, we need bigger trial data for this. One interesting point, I mentioned it on the side, is that there's 4,000 patients with heart failure in the SELECT study, and we shall see very soon subgroup results for events for these 4,000 patients.
Okay. There is any question in the... Yes, Dr. Shabrak. From the audience.
Yeah.
Are there benefic effects in patients who had normal body mass index, who are not obese?
Well, good question. Not studied yet. This is a weight loss therapy. And so at this moment, nobody has done that kind of treatment because, of course, in those patients, a weight loss is not really indicated. SELECT was body mass index 27 and higher. STEPS trials were body mass index 30 and higher. Below 27, no trials have taken place. in below 27, of course, you have the previous trials with GLP-1 agonists, but at the lower dose, of course, with 0.5 and 1 milligram per week. And there you have a modest reduction of future heart failure development in SUSTAIN 6. But I cannot tell you at this moment whether this was also seen in the subgroup of patients without obesity. This I don't know, but in terms of heart failure and normal body weight, absolutely nobody has done any data, any research yet.
After these favorable results of STEP-HFpEF, should we consider that compared with bariatric surgery, GLP-1 receptor agonist in patients with HFpEF is a good option before considering bariatric surgery?
Well, quick answer, absolutely yes. Bariatric surgery, the evidence at this moment is limited in terms of randomized studies, but it's suggestive, but mostly really restricted to very severe obesity, body mass index above 40. Some advocated also for body mass index up to 30, from 35 and above. But let's say 40 and above, it's a different story than what you see here, where the body mass index is 30 and above. So between 30 and 35, I don't think bariatric surgery should even be considered. It's too much of an invasive procedure. 35 and 40, it has limited consideration. And so in both cases, I would say this is the better option here. And clearly it has the much better data. So I would totally support, before you even consider bariatric surgery, you should think about this treatment.
I have just a simple question, if you accept. I mean, for heart failure, do you prefer to start usually with ARNI, sacubitril, valsartan, or SGLT2 inhibitor without diabetes?
Well, don't forget, this is heart failure with a preserved ejection fraction. So these patients basically did not technically, in many cases, have a strong indication or any indication for getting the treatment with the full complement of the foundational therapies. You are also right, if this is what you imply, that essentially almost no patient in this trial had an SGLT2 inhibitor. So focusing here on HFpEF, where we now have a class 1A recommendation, it still is the thing also to do in the obese HFpEF patients. Absolutely first, give an SGLT2 inhibitor and of course manage the congestion with diuretics. Many of these patients have also RAS inhibitors and beta blockers because of the hypertension. So many of these patients are treated with these drugs anyway. Do we have evidence for, let's say, 55 and above ejection fraction, sacubitril, valsartan? Not really. And so I would say at some stage very soon, we will have to consider these anti-obesity therapies. But please also remember, at the moment, they are not regulatorily approved. The paper was actually physically only published in New England Journal 1 week ago. We know it since the ESC Congress. So we still have to learn a lot about these medicines. We still have to wait for the results of the diabetes STEP trials, also of the tirzepatide trial, and we still have to see the SELECT trial results, and particularly the subgroup there, about the long-term effects on hard outcomes in the 4,000 patients with heart failure. Still a lot to learn to make final conclusions about which things to do, but SGLT2 inhibitors are definitely first, and so no question about that.
Thank you.
Okay, thank you. Thank you, Professor Anker, a high-cited researcher. And I think there is no question in the audience. Thank you very much. And we will pass to the next presentation.
Thank you. Bye-bye.
Goodbye. So, Dr. Walid
Thank you very much.
Amara,
Thank you.
Bienvenue parmi nous. Welcome.
Thank you. So it's a great pleasure now to speak about arrhythmias management in case of HFpEF. And the question was ICD or atrial fibrillation ablation in case of HFpEF. So the question will be very fast regarding ICD, because there is no indication for ICD in case of FPEF. So, as you will see in my slides, I will not really address this question. There will be some cases for pacing, and we will address that. So the first question that you may ask me is how does IF affect prognosis in case of FPEF? Of course, as you see on the left from the European Society of Cardiology guidelines, atrial fibrillation guidelines, that of course AF affect prognosis, increase mortality, which is a odds ratio around 2 for death, increase the risk of stroke, and increase, of course, the risk of left ventricular dysfunction. And as you see on the right figure, each of these factors, AF and HFpEF, increase the risk for the other pathology. The second question that you may ask me, that maybe HFpEF is not always FPEF, and in some case, it's patient that has been improved after medical therapy. They had tachycardiomyopathy. Maybe they had in the past decreased ejection fraction, and now with therapy they are better, but they have atrial fibrillation and tachycardiomyopathy. And in this case, atrial fibrillation is in the guidelines regarding if you have left ventricular dysfunction with patient with atrial fibrillation, and you have arguments in favor of tachycardia-induced cardiomyopathy. Indication for atrial fibrillation ablation is a class 1 indication. The third question that you may ask me is that, and we addressed that in previous session with Professor Anker, is that we have now benefit of SGLT2 inhibitors in HFpEF, and how about benefit in case of patients that have HFpEF and atrial fibrillation? And if you look to the subgroup analysis of the two main trials, DELIVER and EMPEROR PRESERVE, you will see that the benefit of, there is no impact of atrial fibrillation or no anterior fibrillation of the benefit of SGLT2 inhibitors. You may say even that the benefit is higher in this patient with atrial fibrillation. So of course, these patients should receive today an SGLT2 inhibitors. And then you may ask me about, do we have arguments to go to a rhythm control therapy for all our patients with atrial fibrillation with FPEF? And in this case, of course, you can look to this trial, which is the AIST-FNET4 that has been published in the New England Journal of Medicine. Of course, this is not a trial about atrial fibrillation. It is not a trial about HFpEF. This is a trial about yearly rhythm control strategy. But there are some patients, maybe between 10 to 20% of the patients that had atrial fibrillation ablation. And these patients, as you remember, were randomized between an yearly rhythm control strategy, including mainly medical therapy, but in some cases atrial fibrillation, but in the other group, usual care group. And as you see, there was a significant benefit in terms of the primary criteria, and you reduce significantly cardiovascular death, you reduce significantly stroke, and so the primary criteria was significant. So my idea is that in case of atrial fibrillation and HFpEF is to think about an early rhythm control strategy. And then you may ask me if in my practice I would choose drugs or catheter ablation for rhythm and rate control in atrial fibrillation with HFpEF. So I will not have randomized trial like you have in HFrEF. In HFrEF you have CASTLE-IF, and even recently you have CASTLE-HTX in very severe patients, which are who are patients that you are actually discussing about cardiac transplantation. So if you look specifically to HFpEF, here is an abstract coming from the recently ESC Congress, and you see here in a randomized trial they evaluate patient with HFpEF and with atrial fibrillation, and you evaluate the impact of atrial fibrillation, and you see that when you ablate this patient, you improve their hemodynamics, you reduce their BNP, you improve their quality of life, you improve your VO2 peak. So you have really some arguments regarding impact of atrial fibrillation. But it is not a mortality trial, of course. But remember that your benefit in case of HFpEF with ablation is lower than in patients without heart failure. Here is a small trial that has been recently published. It's almost 100 patients, and they compare patients without HFpEF and patients with HFpEF, and you see that, of course, recurrence of atrial fibrillation, hospitalization, cardioversion are more frequent in patients with HFpEF than in patients without HFpEF. So, of course, if we compare patients with HFpEF with patients with HFrEF, you will see that atrial fibrillation ablation has almost a similar efficacy with a significant result even in terms of mortality. Probably that means that your patient with HFpEF should be proposed atrial fibrillation almost at minimum as atrial fibrillation with reduced ejection fraction and probably more. And if I focus on the guidelines and to give you some simple message for your practice, if you look to this recently published update of the ESC guidelines on heart failure, you see that for HFpEF, of course, diuretics, dapagliflozin, and something very important is treatment of etiology and treatment of comorbidities, screening for etiologies, even if the level of evidence is C. So that means that if you have atrial fibrillation, you have arguments to go towards, propose the different therapies for your patient with HFpEF. And even if I go to the guidelines of atrial fibrillation, which are now 3 years ago, we are expecting a new update next year at ESC, you see in the center, in case of HFpEF, you have the choice of giving an antiarrhythmic drugs, but antiarrhythmic drugs in this case is mainly amiodarone. I don't have dronedarone, I have it, but it's not reimbursed in my country. Probably you don't use it, and I'm not using it. So we have the choice between amiodarone with its very high risk at the long term for your patient and catheter ablation. So in this case, you know that in case of recurrence without HFpEF, without HFrEF, you can discuss and you have a class 1 indication to perform atrial fibrillation for patient after failure of drug therapy. And I think that in this case, it's still the guideline. And of course, there you have still indication for, even if it should be very limited, first-line therapy, because what you don't see in the guidelines, what you don't see in these guidelines, that we always have to discuss the benefit-risk ratio with the patient, and even from a medical-legal perspective, as an expert, you have always to propose to the patient the different options and to write it in your report that you already discussed with the patient the different option and not only think about first-line therapy. And of course, why first-line therapy may be useful, because you have some kind of trials like this one. Early AF is not an HFpEF trial, it's an atrial fibrillation trial. It's a first-line atrial fibrillation ablation versus antiarrhythmic drugs. It has been done by cryo, which simplifies the procedure, of course, and you see that your percentage of patients in sinus rhythm at 1 year was significantly higher. So, and to finish, of course, always think about maybe our preferred option is to propose rhythm control, but there are some patients that may be candidate for weight control. And this is the patients on the right of the figure. You see that in some patients, even with HFpEF, you can discuss to pace and ablate. And in this case, maybe physiological stimulation, left bundle branch pacing, or CRT, even if it is a class 2B indication, can be discussed associated with an heavy junction ablation. I would not recommend it as a first-line therapy, but I may recommend it for older patients. Of course, remember, in case of weight control, you have the different option with mainly beta blockers. So here you can have my take-home messages here that in case, of course, of permanent AF, you have to think about weight control, and then about eventually AV junction and CRT. And in case of non-permanent AF, your preferred option is rhythm control strategy. And in this case, you have the choice, but with the high risk at the long term, if you have a lung patient, regarding amiodarone, and then discuss atrial fibrillation ablation. And thank you very much.
So thank you very much, Dr. Amara. I think it was so clear for us. If we can be simple, it's just for HFpEF, we must treat the HFpEF with GLT2 inhibitors, risk factor controls, and class 1 it's simple. And then for atrial fibrillation is the medical therapy to control rate.
Yeah, you have, of course, SGLT2 inhibitors is in the guidelines, diuretics. And I think that regarding when to propose ablation, you have to remember that your patient with HFpEF usually is an older patient, usually has comorbidity, have obesity. So in this case, probably is not the best candidate, especially for first-line atrial fibrillation ablation. So, and even from a medical legal consequence is always to discuss with the patient, always to discuss the different options and propose cardioversion for some cases, and then follow the patient. In case of recurrence, you have to discuss, in this case, if they are old, maybe, or very obese, so you have to propose all the medical therapy you can have, and in some selected patient, you have to discuss atrial fibrillation ablations.
Thank you. So discussion is open.
Yeah, Professor Dania, thank you so much for your elegant presentation. I have 3 questions only. The first question, the role of multidisciplinary management in diagnosis and management of patients with cardiac amyloidosis. This is the first question.
I answer or I...
Okay.
Thank you, Dr. Abdelhamid, for this question. Actually, the diagnosis should be multidisciplinary. However, now, today, in 2023, and the latest experience, all patients present in the cardiologist room. So in the clinic of the cardiologist. Unfortunately, I did not receive, and I don't wonder why, in Saudi Arabia, no nephrologist has diagnosed amyloidosis. No neurologist has diagnosed amyloidosis. So we call them once we have, but unfortunately, patients are coming at that stage of heart failure. So therefore, we do the diagnosis, we try, and if we have problems, we have to call, actually to rule out hematology, we should be able to prescribe the free light chain and the immunofixation. However, we need him also to give us his opinion and to give us his input about the other manifestation and whatever needs when you have doubt about. But the neurologist has to be involved, the nephrologist has to be involved, and also, of course, the pathologist. So it has to be multidisciplinary. For the treatment, for the light chain, is exclusively almost the hematologist. However, the cardiologist has to be aware because there is cardiotoxicity of this medication, and he has to have every 3 months follow-up. And for the ATTR is almost exclusively the cardiologist.
Great. The second question, should we screen every patient going to be subjected to TAVI in elderly patients to rule out amyloidosis before sending the patients to TAVI?
This is a great question and always open for a lot of discussion. And I always think that try to answer that in the literature there has been 2 ways, 2 strategies. Either you are rich and you have the time and you have the possibility to screen every single patient coming to TAVI, and that's great, and you will be very, very specific and you will be very exhaustive, and you will have, like the English team has been done, and the Vienna people, they have found over 200 patients going to TAVI, they have found maybe 15 patients per 15%. Now, if you don't have the time and you don't have the possibility to do PYP for every single TAVI patient, then use the echo and use the red flags. I did not have the time to explore what are the red flags in patients presenting with aortic stenosis, but there's some 5 red flags, if you may allow me. For the aortic stenosis patient, not everybody, not the HFpEF. If you have somebody who is present with low flow, low gradient, disproportionate advanced diastolic dysfunction, disproportionate elevated NT-proBNP more than lone AS, elderly patient, more male, electrical problems, AFib, QRS, large QRS, which are not necessarily found in the lone AS. If you have RV dysfunction, severe pulmonary hypertension, these findings are not common in only lone AS. Pericardial effusion. So if you have these red flags, yes, you have to screen them. So to respond to your question, yes, you could screen everybody. However, I think if we don't have unlimited structural things and money, then focus on the red flag that you find on the EKG and the echo and the clinical findings.
Finally, when to say, stop, I'm confused, I need a biopsy.
Okay. The problem of the biopsy, again, it depends on the expertise of the center. When I was working in France for 10 years in the referral center, the biopsy we almost need it maybe for maybe 5% of the case, when all other extra cardiac biopsy were not contributive, and we needed absolutely to know if the patient has light chain and he needs treatment. And you know that treatment for light chain is very important, it's very expensive and toxic. So that for the ATTR, the biopsy is needed when you have like everything is like the MR is not contributive, echo is not contributive, nothing is contributive, and you really yourself as an expert, you think that you need a diagnosis for this patient. And the second case when it's maybe 10% of the case, and the second one when you have AMGUS or you have abnormal fetal light chain and immunofixation, and you have also grade 2, 3 uptake, and some people that has been described in the literature, they have both disease. I will not confuse you if you find only one, but some patients, very rarely, they have both disease because it's elderly disease. So patient may have also dyscrasia and they have also ATTR.
And from the floor, yes.
My question is for Walid Amara, notre ami, toujours. You said that in case of atrial fibrillation, chronic atrial fibrillation with preserved HFpEF patients, you said you proposed the option of ablation, of junctional ablation, then CRT. Why CRT with a preserved ejection fraction? Why not single chamber pacemaker?
I think actually that, of course, I think probably it will depend from one case to another. And I think actually, as you see in the guidelines, it has been proposed as a class 2B indication. But I think that this was actually with the possibility of doing left bundle branch stimulation, no one will do as a first-line therapy a CRT. So I would think that maybe I would propose it actually for mid-range with maybe, so I think if I have an ejection fraction below 50%, I would think if it is easy, I use by BV, ventricular stimulation. But actually with his bundle branch stimulation and left bundle branch stimulation, that would be my preferred option.
And I have a question about amyloidosis. We have many patients with hypertension and carpal syndrome and spinal stenosis. Do you advise to indicate bone scintigraphy for these patients?
Very good question, doctor. Thank you very much for the question. Actually, you know, this elderly patient, and if you look at all the data, almost 80% they have hypertension. So this is the common population that you are facing. So yes. Now, carpal tunnel syndrome is one of the red flags. According to the guidelines, if you have unilateral or even bilateral, it's one of the red flags. So if you have LV thickness more than 12, usually they said 12, you can depends on you, maybe 13, maybe, or if you know, the echo is not really precise. I'm not gonna be as strict as the guidelines, but if you have a thick heart, even only mild, is not all the concentric. If you have mild and you have one red flags, and the patient is old and he has heart failure, yes, I think it's a good idea not to miss this patient to do PYP. And the second red flag you said is the carpal and the spinal stenosis. The spinal stenosis in the literature, actually, it has been described. Unfortunately, when they screened this population, they found maybe 5 to 10% of the population because you know, it's not very specific, and we need really a good examination to know this is canal lombaire étroit, what you call canal lombaire étroit, the spinal stenosis. So it's not as common as the carpal tunnel syndrome. But yes, I would advise you to screen this patient.
Okay, thank you.
So no other question. I thank all the audience, the speaker, and chairman and women. I invite you to keep here for the Feu Mohamed Gedish Award by Adwia. Madame la Présidente, ici.
Alors, Alina Slametkoum el-Kul, aujourd'hui c'est la cérémonie de clôture. Cette cérémonie de clôture est honorée par la présence de Monsieur le ministre conseiller auprès du président de la République, notre maître, le professeur Mustafa Ferjani. Si Mustafa annasna ou sharraftna ou barakallahu fik d'être ici. Alors, ce prix qui porte le nom de Mohamed Gedish, on a voulu immortaliser ce monsieur qui a beaucoup donné pour la cardiologie et qui a été toujours un moteur vers l'action, vers la recherche et vers le nationalisme. C'est pour ça qu'on a voulu que son nom soit commémoré toujours avec l'innovation et la recherche en Tunisie. Alors ce prix a été instauré par un partenariat entre la Société tunisienne de cardiologie et les laboratoires Adouia. C'est la 3e édition et nous remercions ces laboratoires de perpétuer justement ce prix. Et puis c'était une initiative, et je dois rendre hommage à mon ami le professeur Leila Abid, parce que c'était lors de son mandat que ce prix a été créé. Donc c'était une initiative pas du past bureau, mais du bureau précédent, et donc c'est important de rendre hommage aux gens qui ont pensé justement à instaurer ce prix au moment où si Mohamed était décédé. Alors, je vais demander à Madame Maalla de présenter les laboratoires Adouia, et je vais passer juste le micro après, sans reprendre le micro, au professeur Ferjani, au professeur Wafé Fehri, et puis au président de jury de cette année, le professeur Habib Adrissa.
Merci beaucoup. Alors bonjour à toutes, bonjour à tous, mesdames et messieurs. En tant que laboratoire Adouia, nous tenons à exprimer notre profonde gratitude envers Monsieur Mustafa Ferjani, ministre conseiller auprès du président de la République, professeur Selam Abdeslem, président de la Société tunisienne de cardiologie et de chirurgie cardiovasculaire, professeur Leila Abid, président de l'amicale des cardiologues, des chirurgiens cardiovasculaires et des angiologues de SFAX, ainsi que tous nos invités distingués. Alors, aujourd'hui, c'est avec une immense joie et une grande fierté que nous célébrons la 3e édition du prix Mohamed Gedish d'innovation en cardiologie et chirurgie cardiovasculaire. En fait, c'est un prix qui remémore, comme il a bien si dit professeur Abdeslem, donc une figure éminente de la médecine tunisienne, Feu Mohamed Gedish. C'est le père de la cardiologie tunisienne moderne. Mais c'est un prix également qui incarne pour nous, en tant que laboratoire Adouia, notre volonté de soutenir la recherche scientifique, l'excellence médicale et à faire progresser la cardiologie tunisienne. Bien évidemment, nous tenons à remercier professeur Habib Adrissa, notre président du jury, ainsi que les membres du jury pour leur contribution précieuse, ainsi que leur disponibilité dans le processus de sélection des lauréats. Bien sûr, aux candidats qui ont participé à ce prix, nous vous adressons nos meilleurs vœux de succès. Bon courage, votre dévouement il est essentiel pour améliorer la santé cardiaque en Tunisie. À la fin, je souhaite longue vie au prix Mohamed Gadish d'innovation en cardiologie et en chirurgie cardiovasculaire, et vive la cardiologie tunisienne. Merci à tous.
Monsieur le ministre, chers invités, chers collègues, chers maîtres, pour moi, je tiens tout d'abord à remercier les laboratoires Aduia de nous avoir offert ce moment exceptionnel, hein, ce moment où on encourage d'une part les chercheurs et la recherche tunisienne, et d'autre part, c'est un moment très émouvant pour nous, parce que ça nous permet de rendre hommage à feu Si Mohamed Gadish, notre père, notre maître. C'est toujours émouvant quand je parle de Si Mohamed. C'est un être exceptionnel qui a énormément fait pour la cardiologie tunisienne, qui a énormément fait pour la médecine tunisienne. Donc, c'est quelqu'un d'inoubliable. Et j'espère que ces moments-là resteront toujours dans nos cœurs. Et voilà, merci.
C'est un moment où il y a beaucoup d'émotions lorsqu'on évoque feu professeur Mohamed Gadish, médecin général, qui a tout donné à la santé militaire, à l'hôpital militaire qui continue à rayonner, qui a beaucoup donné à la cardiologie tunisienne également. Et c'est l'occasion de remercier le bureau de la Société tunisienne de cardiologie et l'AMCV. Berah, vous avez honoré et les past présidents, les invités également, Lioum Si Mohamed Gadish, l'ouverture Si Ali Bousnina également. Et de nos jours, on manque de, peut-être, voilà, on commence ça diminue la reconnaissance envers nos maîtres, envers les médecins bâtisseurs de la médecine tunisienne. Si la médecine tunisienne a encore, et Inch'Allah pour toujours, un rayonnement au niveau du Maghreb, c'est grâce aux bâtisseurs de la médecine tunisienne dans tous les domaines, les anciens doyens des facultés de médecine. Je peux citer Sahsouna Ben Ayed en médecine interne, Zahir Sefi en chirurgie, Sam Rchedli, pasteur et en tant que fondateur de la faculté de médecine de Tunisie, tous les pionniers qui ont laissé leur poste de chef de clinique en France, qui ont regagné la Tunisie au moment juste après l'indépendance pour fonder les facultés, les écoles et former des générations, et que les jeunes présidents et membres du bureau des sociétés savantes continuent à montrer cette reconnaissance à nos aînés, aux fondateurs. J'espère que cette tradition sera transmise également et pour les autres sociétés savantes. Donc, c'est Mohamed Gadish Allah yarhamou. Merci aux laboratoires également qui ont eu cette initiative, la société de cardiologie. C'est un moment pour et évoquer tout ce qu'il a fait pour l'évolution de la cardiologie au niveau national, mais également au niveau de l'hôpital militaire de Tunis. Je n'oublierai jamais, lorsque j'ai envoyé ma demande de stage à l'étranger dans les années 90 pour se former à l'échocardiographie. Était réticent, mais l'autre n'a pas voulu. Serchid Meshmesh Kif Melou, ils étaient la faculté pour faire le CEC, des mots dynamiques par les ultrasons pour les non-cardiologues. C'était tout le début. Mais après, le premier échographe utilisé dans le service de réanimation, en 1998, était acheté par le service de cardio. Et depuis, il y a une coopération entre les deux services au niveau de la faculté pour la formation des non-cardiologues à l'utilisation de l'échocardiographie comme moyen diagnostique et d'évaluation hémodynamique chez les patients dans les urgences ou qui ont une instabilité hémodynamique. J'espère que cette coopération et collaboration entre les différentes spécialités continue dans l'intérêt du patient et dans l'intérêt de la qualité de la formation des médecins tunisiens qui est reconnue pas uniquement en Afrique. Et on continue à avoir beaucoup de médecins dans différentes spécialités qui se forment en Tunisie, les portes restent ouvertes, mais également beaucoup de médecins continuent à partir en France et en Allemagne et qui sont qui représentent de façon parfaite les compétences de l'école de médecine tunisienne. Donc, encore une fois, c'est Mohamed Allah yarhamou et tous nos aînés, les seniors qui ont passé leur vie dans les hôpitaux à former les médecins tunisiens. Et la formation ne se fait et ne se fera que dans les hôpitaux publics et dans les CHU. Merci pour l'invitation également. Et longue vie et bonne continuation pour la Société de cardiologie. Merci.
Donc c'est pour moi un grand honneur, un grand plaisir que de présider le prix des laboratoires adjoints du feu notre cher maître, le professeur Mohamed Gueddiche. Mohamed Gueddiche est resté gravé dans nos cœurs, dans nos mémoires, dans nos esprits. Il a marqué les jeunes, les moins jeunes, de génération en génération. Il a tout fait pour que notre société aille de l'avant. Il a fait de notre société une dimension internationale, qu'il repose en paix. Et voilà. Donc, je remercie bien sûr Monsieur le Président de la Société tunisienne de cardiologie, la vice-présidente qui m'a téléphoné pour m'inviter à présider ce jury, Madame. Donc, la présidence de la MCV qui a eu l'idée de donner le nom de notre cher maître à ce prix. Et bien sûr, je suis très ravie d'avoir aujourd'hui parmi nous notre très grand ami, très proche des cardiologues que nous aimons tous, Monsieur le ministre, conseiller auprès de Monsieur le Président de la République et chef de service d'anesthésie, le professeur Mostafa Ferjeni. J'ai une affection particulière parce qu'il a soigné donc, avec toutes ses forces ma mère. Voilà. Donc, je vais aussi, bien sûr, donc remercier les laboratoires ADUA, leur directeur général qui n'est pas ici présent, Al-Khamemi, et le docteur Sene Malla, qui est responsable de la gamme cardio dans les laboratoires ADUA. Donc, les membres du jury de ce prix se composent des professeurs suivants. Le professeur Youssef Ben Amr, chef du service de cardiologie de l'hôpital Montgislim. Le professeur Khaldoun Ben Hamda, chef de service de cardiologie de l'hôpital Fatouma Bourguiba. Et docteur Dora Abid, qui travaille dans le secteur public ASFAX. Ce prix, il est particulier. Ce n'est pas des articles qu'on avait à commenter, mais c'est un prix d'innovation et de la recherche. C'est un prix sous forme de projet de recherche. Nous avons essayé pour trancher, choisi le projet le plus innovant, le projet qui traite d'un thème d'actualité, d'un thème pertinent d'un sujet qui va apporter un plus pour nos patients, qu'il soit réalisable en Tunisie et qu'on peut-être un jour on l'exportera à l'étranger. Donc voici, donc, en fin de compte, après une discussion qui n'a pas été très facile, nous avons d'abord reçu 5 projets et on doit choisir uniquement 2. Peut-être que je demanderai au laboratoire de nous ajouter un 3e prix pour l'année prochaine, pour encourager la recherche comme ils l'ont toujours fait. Le premier prix revient à Dr Basma Hashqasem des laboratoires de biotechnologie de Sfax. Le titre du travail, du projet, c'est la sélection et caractérisation de molécules prothrombotiques ou antithrombotiques à vocation thérapeutique. Est-ce qu'elle est là? Oui. Le 2e prix, donc, il est attribué au docteur Hassan Ibn Haj Amr. Donc, il est, je crois, chef de service de cardiologie au service de cardiologie Al-Mahdiya. Ah oui. Ce sujet est intitulé « Effet de la pollution atmosphérique sur la fonction endothéliale et la variabilité instantanée de la pression artérielle chez le sujet apparemment sain ». Sujet d'actualité. Pas mal de papiers en 2023 traitent de ce sujet. Donc, qu'ils soient vivement remerciés. Et mabrouk. Félicitations pour les lauréats.
Anna Sibennader, il va prendre le premier prix, ou Madame Imen Mtiri. Ils sont là ou là? Allez-y, vous allez prendre les prix, vous allez prendre les photos. C'est Mohamed Abdelnader, est-ce qu'il est là? Il n'est pas là, faute de quoi on va le remplacer par Selma Sharafeddine, elle est là. Voilà.
Bonne continuation.
L'effet de la pollution atmosphérique sur la fonction endothéliale et sur la
variabilité
instantanée. La fonction endothéliale, c'est par l'appareil thermo.
L'année prochaine, vous allez présenter des résultats, madame. Voilà. Promis. Sur la fonction endothéliale et la pollution atmosphérique, c'est ça? Merci beaucoup.
Le premier prix.
En fait, c'est pas l'équipe de cardiologie, c'est une équipe de chercheurs qui va développer un nouveau prototype pour un anticoagulant. Et on espère réellement que ça sera fabriqué ici en Tunisie.
Merci beaucoup. Nous remercions encore une fois, oui, une photo d'ensemble. Nous remercions encore une fois Monsieur le ministre conseiller auprès de Monsieur le Président de la République et Monsieur le gouverneur de Medellín qui nous a beaucoup aidés. Et on va passer tout à l'heure à la lecture Introduction of New Kinds of Cardio-Oncology, Focus on Heart Failure and Arrhythmia in Advanced Cancer. Alors, et j'invite les modérateurs là.
Donc,
Justement. كارديو اونكولوجي وقتاش c'est bon. Donc, good morning, everybody. We'll move to an interesting lecture that Professor Anker will give it online, and it's about cardio-oncology. He will tell us about the introduction to a new kind of cardio-oncology by focusing on heart failure and arrhythmia in advanced cancer. So as I said, Professor Anker will give his presentation online. Is he connected? He will be connected. Okay. Je vais l'enregistrement.
Where basically we are going much beyond chemotoxicity. Chemotherapy toxicity is long known to exist. There are guidelines about this, but what I'm telling you about now today is going beyond this. Where is our thinking over the last 15 or 20 years coming from? Well, it comes from the patients. So on the left, you can see key symptoms of patients with advanced cancer. And you see here, besides pain, they have easily fatigue, they have weakness, they have dyspnea, they have weight loss, they have edema. Sounds a little bit like heart failure, possibly. And then on the right, you can see, and there's very limited data on this, but there was an editorial about solid cancers and what these patients die from. And it's estimated that about 1/4 of these patients, and possibly it's many more, die from cardiovascular causes. So maybe that gave us some thinking. And then we started to do some research and investigated, first of all, patients with colorectal cancer, CRC, and compared them to heart failure patients. On the left, you can see the ejection fraction. Heart failure patients, ejection fraction 30. Patients with colorectal cancer, like 55 to 60. And you would probably say they didn't have heart failure, and everybody was above 45% ejection fraction in this study. On the right-hand side, you see the exercise capacity of these patients, and you say, okay, maybe these patients already are halfway between healthy controls and heart failure patients with a poor exercise capacity. But then we actually investigated in these patients, focusing on those patients who were chemotherapy naive. So no toxicity possible because simply they didn't have chemotherapy, and still they had reduced exercise capacity, impaired heart rate variability, and they had neurohormonal activity. And we published this almost 10 years ago in JACC. So this was the first hint that maybe there is something like a heart failure syndrome in these patients. And conceptually speaking, we developed the following idea. On the left, you can see all the things that basically can attack the heart in a cancer patient. And it could be neurohormones, it could be chemical stress from the therapy, it could be oxidative stress, it could be really cytokines, anything can attack the heart in some way or other. And on the right, you can see what in the heart this can result in. And you might have apoptosis, so basically losing cells. You might have fibrosis, but in the end, you may have cardiac wasting and you may have arrhythmias. And the question is there evidence for this? Is this really important? Well, the most simple form of what you might call an arrhythmia is tachycardia, is high heart rate. And of course, you know that in cancer, patients often have a high heart rate. If you talk to your oncology colleagues, they will say this is a demand tachycardia. They might be right about this, but the problem is that this is indicating already a poor prognosis. Patients with a high heart rate in cancer have a much worse outcome. Now, the second thing is then, well, what about non-sustained VT? What about real arrhythmias? Well, first of all, in a prospective study of 120 patients, we found about 8% of patients having a non-sustained VT in a 24-hour ECG. Well, that's 8% is more than many people would expect, but it's not everybody. Now, many people believe atrial fibrillation should be much more frequent, but that's actually not correct. Atrial fibrillation is only in 1 to 2% of cancer patients, and this is advanced cancer, stage 3 and 4 cancer patients. So this is not early. This is later stages. In this particular study, colorectal cancer, pancreatic cancer, and lung cancer. And these patients are sick. They have non-sustained VT 8%, but atrial fibrillation relatively few. And when they have non-sustained VT, you can see here the graph on the right. Within 3 years, all these patients were dead. So patients with non-sustained VT have a poor outcome. Patients with more than one non-sustained VT do have actually a very poor outcome in this setting of advanced cancer. Now, you might say, I go back to my hospital records and do this retrospectively. On the one hand, you can do this, of course, and we actually did this to try out what happens. On the other hand, you will get really biased results. Because if you look at retrospective data, when are you actually collecting a 24-hour ECG? You collect it in patients where there is a reason, where the cancer doctors called the cardiologist for some kind of support. And it may have happened because of a syncope, some abnormal ECG, maybe suspected atrial fibrillation. And when you then do a 24-hour ECG, 17% of patients had a non-sustained VT, and 8 to 10% of patients had an atrial fibrillation in this kind of biased retrospective setting. Nevertheless, non-sustained VT also in a retrospective setting is prognostic for these patients with cancer. So maybe there is something about arrhythmias. Maybe we should actually consider this as a therapeutic target. And of course, we can discuss this later on. The obvious therapeutic implication is to try out defibrillators in these patients. You may or may not argue there is some ethical limits to this, but many of these patients have above 1 year life expectancy. So technically, we would be allowed to do this. And of course, you need to disclose to the patient that you are doing this, and they need to have the option to turn off the device if they do not want to live longer anymore at some stage later in their cancer history. But at least in principle, it should be possible to prolong life this way. We haven't done it yet, but we are trying. Now comes the second part, the cardiac wasting. And cardiac wasting, I would like to explain to you, is de facto the heart failure syndrome of advanced cancer patients. So if you look back in basic science, you will find that starting in 2010, there are several reports of cardiac wasting in advanced cancer animals. This basically was shown in colon cancer models, in liver cancer models, really a number of different models where this was shown. And we actually investigated this in liver cancer in much more detail. And in a liver cancer model, you basically have, and this is the Yoshida model, you have the possibility to take out all the cancer cells and investigate the tissues without infiltration of cancer cells. And the mortality in this model is about 85 to 90% without treatment within 16 days. And what you see here, you see a strong reduction in body weight starting around about day 11. Lean mass, fat mass, all is getting lost. But in the end, also the heart mass is going down. The heart mass is really progressively declining, but it is, you might argue, a little bit more protected than the overall body weight. The body weight drops a bit earlier than the heart rate. Heart rate becomes very poor. At the very end, when you really investigate the animals in the pre-terminal phase, where you actually almost never would do a human study anymore, what you can see is that the cardiac output with a severe wasting of the left ventricle that can reach 58% of the left ventricle can be wasted in these animals. You then also see reductions in cardiac output. This reduction in cardiac output at the late stage is very late, then also associated with a poor ejection fraction. You see contractility, DPTD is going down. And you also see that very late you have QRS interval prolongations. And of course, heart rate variability goes down, like you expect basically in subjects with a heart failure. You expect heart rate variability as a sign of neurohormonal activation to go down in late stage cancer. But this is a preclinical model. Now, what about humans? In humans, we did this also about 10, 12 years we started. And first of all, we had patients with and without cachexia in cancer. They have neurohormonal activation, and patients with cachexia in cancer then also had heart rate reductions. This is from pathology samples, so autopsy results. And when you look into this, you basically see everything that is red is fibrosis. You see widespread fibrosis, the more cachectic the heart becomes. Well, how can a cachectic heart, how can a wasted heart become a heart failure heart? Well, look at this. This is the normal heart on the left. And basically then you see in the bottom part, the dilated cardiomyopathy situation, where you have an increased ventricular size. The wall is getting, you might say, a little bit thicker. The left ventricular mass increases, but it doesn't increase enough to compensate for the dilation. And so you have wall stress increases. When you have a wall stress increase, you get a failing heart by the Laplace law. Now, and exactly the same happens in the end for patients with a cachectic heart. Here you have basically a thinning of the muscle, and this wasting process is accompanied by the heart staying about the same size, but a thinner wall also means in this case that the wall stress goes up. So in the end result in two very different hearts is the same thing. You have a decompensated situation. Now, does this actually happen in humans? And we just published this actually 4 months ago in JACC, and Alessia Lena and Marco Sanka from our team published on this. And you see here a total of 300 cancer patients, 60 heart failure patients, 60 healthy controls. And the cancer patients are split between cachectic and non-cachectic patients. And the first thing, of course, you see they are relatively young, all about 60 to 63 years of age. And the systolic blood pressure in the cancer patients is a bit higher than in heart failure. They have, in half the cases, they have dyspnea. Well, and these patients have also, of course, changes in their neurohormonal parameters. So they have some degree an increase in natriuretic peptides, higher than controls, but much lower than heart failure patients. They have a small increase also of troponins. They have a strong increase also of cytokines. You can see here the treatment in the bottom. Only a quarter of the cancer patients received a RASi inhibitor, and this is mostly because of hypertension. Only about 18% received a beta blocker. Hypertension is the only reason these patients are not diagnosed to have heart failure. And all the patients included really had an ejection fraction above 40%. And they had cardiac wasting. So here you see the healthy controls in green, 203 gram. The cancer patients had about 10-12% reduction in LV mass. The heart failure patients, as expected, had a 50% increase in LV mass. But particularly pronounced was the loss in LV mass in patients with cancer cachexia. Now, is this due to chemotherapy? The answer is no. Here you have anti-cancer naive patients. Here you have patients with non-toxic anti-cancer therapies, and here with cardiotoxic. The LV mass is essentially the same. So chemotherapy is not the reason why these patients develop LV mass. How often do they develop LV mass changes over time? Well, in 90 patients, we are able to show this over time. And within 4 months on average, 4 months only, 9% loss of LV mass. And if you think about this, almost half the patients we looked at had more than 10% LV mass loss, which is a substantial change in left ventricular mass. So now you need to look into your echo manuals. Your echo manuals say LV mass should be adjusted for body surface area. And I'm telling you, this is wrong. No longer ever adjust LV mass for body surface area in cancer patients. The reason is that body surface area contains body weight. And so you have a decrease in LV mass accompanied by a decrease in body weight, leading to a reduced body surface area. And the measurement of LV mass divided by surface area is actually only like 14% difference between the patients with healthy people and cachectic cancer patients. That basically is not the correct number. The correct number is that they have a 24% difference in LV mass. So with the adjustment for body surface area, you get wrong numbers. Still, you might say we need some adjustment, and the best adjustment is actually by the height of the patient squared. So if you take the LV mass index, then by the height square adjustment, you get the best number. So as a next point, let's focus on ejection fraction. Here you have the healthy control subjects, 68%, and all the cancer patients together have 64% ejection fraction. Very similar between cachectic and non-cachectic patients, but the heart failure patients have a much lower ejection fraction. But look at the stroke volumes. Well, here you have the stroke volumes relative to the ejection fractions, and you might say you're not really impressed with this change in stroke volume, but look at this. The stroke volume of heart failure patients is actually very similar to that of cancer patients with cachexia. 41 milliliter is the stroke volume in heart failure, 43 in cancer patients with wasting. And this is despite a doubling in the ejection fraction measurement. And again, one lesson to learn, ejection fraction doesn't work in advanced cancer. Stroke volume gives you a much better indication of what's going on. And if you have the left ventricular mass adjusted for the height of the patient, it is also prognostic, independent of anemia, of natriuretic peptides, of troponin, of kidney function, and CRP. So left ventricular mass wasting in advanced cancer leading to a heart failure is a problem. It's associated with poor prognosis. It's associated with poor exercise capacity. 6-minute walk test, for instance, and the muscle strength of these patients is lower. Now we move this to the extreme. We went actually to a hospice care looking at end-stage cancer patients, and these 120 patients I'm showing you data for had a median survival of 51 days, not even 2 months. And half the patients were not even able to walk 4 meters. Half the patients were not able to wash themselves on the day. So you might ask, what's the point then of us doing this research for these patients that really have fundamental problems of very poor functional capacity and of quality of life, not being able to wash themselves? Well, basically, we are now doing a heart failure trial in advanced cancer. And the aim is to make them able, when they are living a little longer maybe, to also make them able to wash themselves. So give them the dignity in the end of life scenario back. And we are giving them sacubitril, valsartan, and empagliflozin if the blood pressure is reasonable. When the heart rate is high, we give them ivermectin. We give them intravenous iron when they have iron deficiency. You might ask, well, what about beta blockers? Well, beta blockers make quality of life worse in the initial weeks, so we didn't want to do that. And MRAs, what about them? Well, they make you get hyperkalemia, and it's a complicated situation. We didn't want to have this. We have by now recruited 28 patients in this trial, and we shall see very soon whether it works. What I'm suggesting to you is that cardiac wasting, indicating basically a heart failure syndrome, and arrhythmias could soon be targets for our patients. Chemotherapy toxicity is only scratching on the surface, I believe, of what cardiology can offer in the multidisciplinary care of advanced cancer patients. The easiest entry point for cardiologists, of course, don't forget, these are your colleagues taking care of their patients, is the support structure of end-stage palliative care patients, because there's very little oncology-specific kind of care ongoing. I think we need to do this as prospective research. I think there is heart failure, and we can treat them as heart failure patients. And maybe even with the arrhythmias, we have some place for novel devices in the near future. At this stage, I thank you for your attention, and I believe we can do a lot of good things also for cancer patients with cardiology approaches of a little bit of a new kind. Thank you so much for your attention, and I hope we can discuss this. Okay.
Thank you very much. Professor Anker is here, is connected. Yes, he is connected. So thanks a lot for this excellent talk and lecture about new fields in cardio-oncology. And if you hear us, Professor Anker, then just for a question. Just, I have two questions to begin the discussion. So, hello, good afternoon, and welcome for another time, Professor Anker. Thank you very much for the excellent talk and this lecture about cardio-oncology, a new field and a new opening horizon. And I have just two simple questions. So, in practice, we have a patient with advanced cancer. He must have therapy, oncology therapy, and to ameliorate his prognosis. And then really we have a patient at high risk also of heart failure. So what about the therapeutic strategy in practice? This is the first question. The second one is, what about protective therapy? SGLT2 inhibitors, ARNI, or others in cancer patient, even low-risk patient.
Yeah, well, thank you so much. Of course, in terms of the low-risk patient, it's difficult for me to comment because there is simply no successful clinical trials of this. And if you have a clear diagnosis of heart failure with a reduced ejection fraction in such a patient, then you may use the heart failure guidelines and do it. However, of course, don't forget, such patients were always excluded from our trials. And so you would be in the art of medicine area. You would not be in the evidence-based area of medicine. And I think you can do this. But even better would be if we create evidence, and this is what we are aiming to do, particularly for patients with advanced cancer. Let's not forget some of these therapies also have adverse events, and hyperkalemia in a patient with cancer may be very disturbing and may lead to problems if it's not really regularly looked at. Let's not forget that in reality, there is so many cancer patients, but also so many cardiology patients, that a close follow-up for these patients and close care, just from the numbers standpoint, is probably unlikely to happen. And so we are focusing really on the very advanced cancer patients where there is relatively little direct oncological therapy ongoing. The trial that I've shown you in my presentation is actually in the palliative care and hospice setting, where the patients have 1 to 6 months survival expectancy. There we are living in a completely evidence-free area. It's a hypothesis that heart failure therapy can make a difference to the quality of life and exercise capacity, maybe survival of these patients. But to give recommendations at full therapy of these patients right now is a little bit difficult. But really what I want you to be aware of is that there is this possible problem. And at least from the echocardiography standpoint, if you take one message back home, in cancer, don't adjust for body surface area. Any of your measurements, either report the real numbers or report adjusted for height.
From the audience, Dr. Chabrak. Dr. Abdul Khan. Monsieur le Président, à vous la parole.
Merci, Madame la Présidente. Thank you very much for this beautiful lecture. I think that it's a quite new paradigm showing that the connection between cancer and heart failure is very strong. And do you have a program including something that more than medications, something really empathic, as you said, with cardiac rehabilitation, or whatever the ejection fraction is, because I've seen that it's muscle loss, heart muscle loss, but muscle skeletal also. And of course, we have the other disorders that we are usually to face. And do you have a program, whatever the ejection fraction, the heart situation for these cancer patients, something which look like cardiac rehabilitations, including medications, but before that, all the other aspects?
Well, thank you so much. That is a good point. In cancer, there is now an increasing awareness that when you start to diagnose cancer and the prognosis is still very good, still these patients have a long-term chronic illness. And so the oncologists call it sport for cancer or cancer sports. I'm afraid they're not calling it cardiac rehabilitation, but it is the same thing. Sport for cancer patient is something that some places are starting to offer. Some. Don't forget, this is rather expensive from a manpower standpoint. It's cheap from a drug standpoint, but from a manpower standpoint, you need to have supervised sport here. Of course, we advise also to our patients to be active, but the real rehabilitation program, you need to have also supervised sessions to tell people how to do properly the sport and also the strength training. Yes, we have this for a limited number of patients, but I'm afraid in reality, it is not of the size to be able to cater for all the many patients.
Dr. Chabrak?
Did you observe susceptibility to develop left ventricular mass loss regarding to type of cancer?
No.
The cancer type.
Yeah, I understand. It happens both in patients with hematological cancers and with solid cancers. So far, we basically can say what predicts the development is inflammation and presence of anemia. But presence of anemia, presence of inflammation can be in any cancer patient if they have metabolic problems leading to cachexia in the whole body, and then they seem also to relate to wasting of the heart. But the type of cancer, as long as it is a severe cancer, the stage 3 and 4 have much more wasting. Stage 1 and 2 don't have it. So it's more the severity of the cancer, but not the kind of the cancer.
Is there other questions? I'd like to thank Professor Anker for this very nice and wonderful presentation. And we will move to the next session. It's my pleasure to invite the chairpersons of this session, Dr. Borzela, Dr. Kraim, Dr. Malek, Dr. Marvet, and Dr. Magdi Abdel Hamid. Okay. The stage is yours, dear chairpersons.
Good afternoon, everyone. I think maybe we start our next session. So hello, everybody. My name is Mirvat Al-Asnaj, and with me moderating this session, my colleagues. Maybe you can introduce yourselves, please.
Thank you. We welcome you in Tunisia, first of all. I think it's your first time, maybe?
First time in Jeddah.
Okay. Well, my name is Asia Borzela, interventional cardiologist and former head of department in Sahlul University Hospital.
Suad Malek, cardiology intervention in SPACS.
Okay, so we're going to start this session, which is in association with EAPCI, the European Association of Percutaneous Coronary Interventions, and we're going to start with EAPCI consensus document, How to Approach Calcified Lesions, by Professor Reskuch. And it's a recorded session, and then, well, actually, I believe the session that's on is from Dr. Aliaid Kifo, which is Overcoming Professional Barriers Encountered by Women in Interventional Cardiology, and this is an EAPCI statement. So if we can have her pre-recorded presentation, thank you.
So good morning, I'm Aliaid Kifo from University Vita Salute San Raffaele in Milan, and I'm President-elect of EAPCI. I'm sorry not to have been able to be present on site, and thanks to the organizing committee to have set up a session endorsed by EAPCI. I will talk regarding specific barriers for women present on leadership in interventional cardiology. Recently, we did publish in European Heart Journal a special article on overcoming professional barriers encountered by women in interventional cardiology, and this is an EAPCI statement. You can download, because this is an open access, and read such an interesting paper. Why that? Because first, let's start from the fact, which is the representation of female APCI members in 2021 by countries. This is quite heterogeneous in different countries. There are areas where the representation is higher, like Northern Europe area where it is lower, and there are even countries where indeed we didn't have any women member in APCI. And for example, this is the case for Tunisia and lots of Maghrebian countries, despite, for example, Egypt, that had indeed 7% of EPCI members being women. And which is, in general, however, the representation of women members in EPCI quite low. And this has been low throughout the last years, going only from a 14% to a 15% in 2021. And what about the representation of women in EPCI as compared with the other European Society of Cardiology organization? It is the lowest, as you can see from the right panel. It is the lowest as compared to all the other associations. And it is quite thoughtful that is even lower than ERA, which is the Association of Electrophysiologists. And which are the barriers then to women to pursue interventional cardiology career? This is a very interesting paper that was published some years ago again from EAPCI, and specifically from EAPCI Women Committee. And this was a survey that was circulated throughout the EAPCI members, investigating which were the causes for such barriers. And this was asked to women and men members. And there was a different perspective, because men thought that the first reason was on-calls, the presence of on-calls for primary PCI or the radiation. And this is the answer by men are represented in the blue column. However, indeed, the women did feel that the largest and most important barrier for them to pursue interventional cardiology were not on-calls, radiation, or family, but indeed were the presence of lack of opportunity. So they felt that to embrace this subspecialty that we have to admit it's quite very hard working, requiring also the availability for on-calls that can happen during the night, during the weekend. However, the biggest was indeed the lack of opportunities. Radiation, however, is one of the issues. There are a lot of publications on the topic. There was also a recent paper that was again published by EAPCI, just showing that indeed it is an issue, but is not an issue for the fetus, because the dose that you are going to have is much lower than the dose that is indeed harmful for fetus. Regarding lack of opportunities, this is quite clear. There are fields in interventional cardiology where it is higher. For example, structural heart intervention. Again, this is a publication that is coming from circulation cardiovascular intervention. And as you can see, despite the fact in the latest year there has been a growth in the operators for structural intervention in TAVR, however, the number of women TAVR operator is low. And this is felt as a barrier for a woman entering into its subspecialty. The not possibility to be exposed to new procedures and to be operator in new procedures. But this is not only for professionals, so the lack of opportunities to learn new technologies and new intervention. Lack of opportunities felt also in the different scientific and academic fields. For example, lack of opportunities in editorial boards. There is a lower number of women that are in the editorial boards, and especially women in apical position. For example, the women that are editor-in-chief of journals, which is quite low and unbalanced. But also the lack of opportunity as clinical trial leaders. And this is, again, a publication that was in JAC 2021, just showing how many physicians have a leadership role in running clinical trials or in leadership committees. Economical difference is another issue. Again, this is a recent publication showing how the income and salary of a woman is much lower than the man. And this is also in interventional cardiology. And again, how many go from mid-career to clinical directors, so the lack of women in apical position as clinical directors. And this is taken from European Heart Journal. It was a publication by Borelli, and the numbers are quite discouraging. For example, in Italy, only 3-4% of the women are clinical directors. And this is quite well distributed throughout the different ESC countries. However, in the document are not only discussed which are the barriers that I described, but also to try to find solution to that. There is a clear sex gap, and there are different possibilities to reduce this sex gap. First, reduce bias in hiring, transparency of the data, so transparency of, for example, salary for women and men, transparency regarding the roles, transparency regarding the decision to appoint individuals, physicians for different procedures. There are also unconscious bias of training. That should not be the case. The importance of networking, because networking gives the possibility, for example, to encounter their mentor or sponsor that are very important for career development, to identify a mentor and a sponsor that, if it's not possible to find in our own institution, can indeed be found outside the institution. So that's the importance of networking. The issue of maternity leave. One of the solutions can be extend the maternity paid leave, also to extend, for example, the paternity leave, because we are in a society where also men would like to be more involved in their kids' growth, and to extend in countries they have paternity leave, or to indeed apply for paternity leave, could also help the women for her career despite having a kid and being in the first year of the kid. But also, for example, creation of a breastfeeding friendly premises in the working, or the creation of a kindergarten in the hospital that can help again to balance the work and family life. But also, other point is the mentorship program. As I said, it is very important, not only for women, but also for men to have a mentor. And also, in the single institution, the creation of a specific program where each mentee has a specific mentor can decrease the presence of access to education and new technology. However, the importance of creation of awareness and accountability of the issue in the own working place, as well as leadership and company commitment. So also from the institution, the commitment to have a more equal representation of gender in the leadership position. There are some institutions that, for example, did create a gender and diversity committee. In my hospital, it was created a gender and diversity committee with representation from the single department. And clearly, this helps to create awareness and is one of the solutions to overcome barriers. This is taken from Libra, and indeed, again, this was one post published in order to, again, enlighten the presence of disparity, with the women take only 2.5 times more unpaid working hours than men. Important to share the load of family, as we said, also with our partners, and also to work on educational level to younger generation, to career aspiration that should be positively correlated, and also the importance again of raise awareness. And this is taken from the paper, and again this is quite summarized, the issue of lack of opportunities, but however the importance not only to address the issue but also to think about solution. So to have an equal chance in fellowship position, for example, so for the application of fellow to center where they can be trained in interventional cardiology, to maybe consider a quota for women and to have open calls that can encourage the women to enter. Also incentives to increase the female to male ratio, promotion of policies supported by academia and industry for competence-based selection criteria, diverse editorial board for use of talented issues, a constant monitoring of reviewing process for blended and more reviewer revealing process. Because the other issue is indeed that there are a lower number of first or last corresponding authors being women. Then the lack of, as we said, mentorship, and indeed the promotion of mentorship, but not only mentorship, but also identification of sponsor to help women to go through the different stage of the careers, because barriers can be encountered in different stage of the barriers. Regarding the pregnancy and family management, as we said, incentives from health insurance coverage for a longer maternal leave, but also funds for in-hospital children facility as kindergarten, and also also to help for working parents, and also, as I said, extending the leave to paternal leave that can help the women also in their working. Then on the radiation, there are several ways to overcome this such as the use of auxiliary devices to lower this risk. On-call concerns higher feasibility for adaptability for mothers. Again, indeed, for example, creation, as we said, of in-hospital facility that can help the women during the on-call to have the children taken care on, but also a lot of work should be done in the cultural environment and helping of the society to the women that wants to be in interventional cardiologists and also to be mother. And then the last part of the document was regarding the impact of COVID, because COVID was a very good example that how it impacted especially the women in their, for example, advancing in career. So the whole point is, if we want to have more women in interventional cardiology, we have to help them to have a balance in work and life. And as we identified potential barriers, we have to put in place all the possible solutions to overcome them. Thanks for your attention.
Thank you, Professor Adelaide, for this interesting and presentation about the barriers that women have to go over to practice interventional cardiology. You have been talking about all the barriers. Okay, thank you very much. So we'll discuss the presentation at the end of the session, and we move to the next presentation, which is going to be presented by Professor Rizek from Poland, and who is going to talk about a consensus document, how to approach calcified lesions. This is more practical.
Thank you very much. Good afternoon. First of all, let me thank the organizers for kind invitation to be part of this joint EAPCI session. I am really honored to be here, as I am honored to represent Euro4C Group as its current president. And I am honored to represent the group of authors of this, in my opinion, very, very important document. Everybody knows what EAPCI is, but I am convinced that almost nobody knows what Euro4C is. Could you please raise your hand if you have heard this Euro4C? Have you heard anybody? Nobody. So I was expecting this, and that's why I want to introduce to you first this group. So more than 10 years ago, a group of rotational atherectomy enthusiasts from different countries founded a European Rotablation Club. We started to meet in Wrocław, Poland, once a year, in order to share opinions, to share knowledge. More and more interventional cardiologists came to our meeting just to learn rotational atherectomy. But in 2019, of course, we had many other different devices. We had IVL, we had orbital atherectomy. So it was obvious that Eurota Club, it has to be changed. So we changed the name and the scope of our interest from Eurota Club to Euro4C. And what does it mean, these 4 C letters? 4 C letters stand for cardiac care, of calcified lesions and complex patients. As you can see among us, Emanuele Barbato, Flavio Rebicchini, Mirek Ferenc, many distinguished interventional cardiologists, and the main goal of our group is to disseminate the knowledge among interventional cardiologist community about how to treat properly the most difficult subgroup of patients, because there is no doubt that the most difficult subgroup of patients within coronary interventions are patients with heavily calcified complex coronary lesions. So, let me give you 5 good reasons to convince you that this new document was very, very needed. Reason number 1, it is first ever holistic document on calcified lesions. There is no such an American or English or Japanese or any other document. Reason number 2, in 14 studies on drug-eluting stents, at least in 30% of patients, the core lab had established that at least 30% of patients have at least moderate calcifications in coronary lesions. Reason number 3, look at this small star here. What does it mean? It means that in the majority of these trials, moderately calcified lesions and severely calcified lesions were contraindicated to enroll patients. And despite this fact, the operators have included these patients. What does it mean? It means, and it's easy to explain, that angiography is not enough. It is a very bad tool to recognize calcifications in the coronaries. Next reason is that patients with severely calcified lesions, the green bar, have much worse outcome than patients without calcifications. And last but not least, 5th reason, if we know how to treat properly these patients, in this case it's randomized trial PREPARE-CALC by Mohammed Abdel Wahab, and rotational atherectomy and the best tool, we can see that outcome of patients can be substantially improved in comparison to patients, and not to conventional angioplasty, but to angioplasty with modified balloons. So, coming back to the document. The document has been published in May this year, so it's a brand new document simultaneously to Euro PCR in Paris. The majority of authors are connected with Euro 4C group. I am of course not able to introduce to you everything, but let me give you an idea about this document. I want to encourage you to find it and to get familiarized with it because it's very, very good document, very practical one, and which helps us to guide us during this very, very difficult procedure. So, 4 most important aspects have been discussed. First one, imaging assessment. As I said before, coronary angiography, it is a very bad tool. That's why for calcium recognition. That's why we encourage everybody to use intracoronary imaging, and we encourage everybody to use non-invasive imaging like CCTA. And let me show you 2 next slides. It's a case presented by me during Euro PCR. You can see here moderately calcified lesion in obtuse margin in the circ, but despite its only moderately calcification, the balloon does not expand. And look now at coronary angiography of the patient. You can see here clearly heavily calcifications. It's impossible not to recognize it, but most of all I would like to show to you this cross-section. I wonder if everybody of you has seen such a cross-section in CCTA. You can see here 360 calcium ring, and you see already before the patient goes to the cath lab that this patient needs atherectomy because you are unable to have this patient without atherectomy, or maybe okay without shockwave. So very, very potent, very helpful tool. We have to use it. Section number 2, tool selection. The document helps us to choose the most suitable tool for uncrossable lesions, superficial calcium, calcified nodules, undilatable lesions, or deep calcium. Section number 3, post-PCI assessment, or it should be, in fact, post-stent deployment assessment, because it's not post-PCI, because we still assess and have to assess if our angioplasty is performed optimally, because we have to use intracoronary imaging, and we strongly encourage everybody to use intracoronary imaging, and if it's from whatever reason not possible, we encourage you to use angio, but of course, during angio, you should use enhanced angio image. You should check if your stent is expanded, fully expanded, at least 2 orthogonal projections in order not to miss not fully expanded stent. And then optimization, and you should liberally use post-dilation, IVL, or other stents if needed. Very important part of this document, it is IVUS calcium score and OCT calcium score. I do not have time to go into details. We can calculate and measure these scores, and it will guide us what tool should we choose for our particular patient. Algorithms. We propose 2 algorithms. As I said before, we discourage from using angiography only, but if from whatever reason you are based, so your basis is angiography, you do not have IVUS, you do not have OCT, or you do not have experience, very important message to you, and it's first one, look at this algorithm, avoid direct stenting. Still worldwide, many colleagues, despite they see calcified lesions, they try to conquer it with direct stenting. Do not do it. I do not have time to go into details, and the algorithm based on IVUS and OCT, as I said, we encourage everybody to do it, and I will introduce to you shortly, this introduction will be based on a very, very short case. Look at this LAD, heavily calcified tight lesion. Some of you, I am convinced, would take balloons. Some would take cutting or scoring balloons. Some would go for atherectomy. But let's look at the algorithm. The algorithm tells us that we should start with imaging. So try to cross this lesion with imaging. So I have taken OCT catheter. OCT did not cross. So we come back to the algorithm. What the catheter does not cross, you should cross it with a microcatheter in order to perform rotational atherectomy or laser. Laser is not very popular in our country as well. So you can see here, after fine cross and rotawire floppy 1.5 bar, finishing runs, and the question, what next? And again, some of you would take balloons, some cutting balloons or scoring balloons, but let's look at the algorithm. The algorithm says, do not guess, just measure your calcium. So, of course, perform intracoronary imaging, and now we go this pathway to the left with intracoronary imaging. We measure exactly our calcium. In this case, OCT calcium score is 4 points, because we have 2 points for calcium arc bigger than 180 degrees. We have calcium thickness more than 0.5. We have calcium length longer than 5 millimeters, so we have 4 points. In case of 4 points, you go for rotational atherectomy or orbital atherectomy or little tripsy. No other tools, so no balloons. It will be not sufficient here. And I've taken 175 bar, and I have achieved very good result. And it's my last slide. Instead of summary, I want to encourage you to join Euro4C. It's very easy. You need just 2 easy steps to go to visit PCR online and to find this red icon, join Euro4C. And if you are a PCI operator, remember that every third your patient has at least moderately calcified lesions, so you will have problems if you do not follow some rules. When you are Euro 4C member, you will have access to excellent cases commented by Flavio Ribicchini on PCR Online. And if you are interested to build structures in your countries, I encourage you to send me an SMS, and I will tell you how to build structures in your countries. Thank you very much for your attention.
Thank you for your talk. We'll keep questions in the end of the session, if you want. That's a pleasure for me to introduce the second orator, Dr. Bennouna from Morocco. You will talk message of bifurcation PCI.
Le pointeur, vous l'avez? Alors pour avancer, c'est comme ça. Pour avancer, c'est ça, Ok. Excuse me. Alors. Hi everybody. First, let me thank the organization committee for the invitation, especially the president of the society, the Tunisian Society of Cardiology, and Professor Rania for the invitation. Today, I will talk about the new ABC consensus document, which talk about many strategies to protect the side branch while we are stenting the main vessel. My name is El-Ghali Mohamed Bennouna, and I work as an interventional cardiologist in Casablanca in the University Hospital. So every time we talk about bifurcation PCI treatment, we need to know that it's always a challenging cases. Why? Because anyone who performs PCI in bifurcation, especially complex bifurcation, is afraid about losing a side branch, especially in challenging anatomy. We must know also that any abrupt occlusion of the side branch can lead to an authentic myocardial infarction, and in some cases, a lower ejection fraction and poorer outcomes, even if in the acute setting or in the chronic setting. That's why this occlusion of the side branch after main vessel stenting could happen in 6 to 18% of cases. That's why any operator must know, learn any strategy to deal with these issues and in order to improve outcomes for our patients. The new ABC consensus document provides many strategies to protect the side branch. When we talk about protecting the side branch, we will talk about baseline wiring side branches and also restoring the flow in the side branch after main vessel stenting in case of occlusion of the side branch. Before we will talk about different strategies, before we develop these strategies, we absolutely need to define what does mean a relevant side branch vessel. In this consensus, we can clearly read that a relevant stenosis, a relevant side branch vessel means that the reference diameter of the vessel is equal or exceed 2 millimeters of diameter. It means also that it supplies more than 10% of the whole myocardial mass, which means also is that this vessel is prognosis. In other papers, we can read that if the length of the side branch exceeds 73 millimeters, we can consider it as a relevant side branch, and we need to protect it. But the real message, the relevant side branch, is the one we don't want to lose when we put a stent in the main vessel. What are the risk factors for the occlusion of the side branch after main vessel stenting? For those who perform IVUS before PCI bifurcation treatment, there is a special sign called spiky carina. The appearance of this spiky carina shows that there is a high risk of occlusion of the side branch once we put the stent. For those who use OCT before, this is more simple. When you see here, you can see the lipid content in the atheroma plaque, especially front of the side branch, is a sign that there is a high risk of losing the side branch after main vessel stenting. And finally, when in the angiogram, there is many signs that can predict an occlusion of the side branch once we put a stent in the main vessel. As we can see in the left picture, we can see the severe stenosis in the main vessel and the side branch severe stenosis. A wide angle between the main vessel and the side branch is also a high-risk feature of occlusion of the side branch. In the other picture, we can see the length of the stenosis in the side branch is also a sign that there is a high risk of occlusion of this branch. We cannot talk about protecting a side branch without talk about jailed wire technique. This consensus reminds us about the older recommendation. The jailed wire technique means that we need to leave a wire in the side branch before main vessel stenting. In the majority of cases, when we do this jailed wire technique, we protect the side branch. But in some challenging cases, anatomies, the side branch can close even we project it by wire. This jailed wire technique can play multiple roles. The first one is that is considered as a marker to recross the side branch through the struts of the main vessel stent. The second point is that jailed wire can play a role as an anchor for the guiding catheter in order to increase the support of the low-profile balloon through the struts of the main vessel in order to open the struts. And finally, this jailed wire can play a role in bailout situation. When we lose the side branch, we can push a low-profile wire, a balloon, between the stent and the arterial wall in order to open the side branch as a bailout treatment. The new evidence of the use of the jailed technique was written in this new consensus, and we can read clearly that in a series of bifurcation complex lesion of CTOs treated mainly by provisional stent technique, when the operator was unable to recross, to protect the side branch with a wire, this was linked to a higher failure procedure and a higher incidence of peri-procedural myocardial infarction. In the COBIS 3 registry, when we protect a side wire, when we put a wire inside the side branch before main vessel stenting, this is what was associated with a significant lower rate of final side branch occlusion in patients, especially in patients with complex bifurcation. And finally, in the EBC main study, the failure to rewire a side branch was associated was frequent when the jailed wire technique was not used. Finally, there is no consensus on which each anatomy we should use the side with jailed wire technique, and finally also in case what we need to know if the side branch is closed, is compromised after main vessel stenting. It is recommended to rewire this side branch and open it. So this consensus explain many strategies to protect the side branch occlusion. There is a conventional way and active protection. Two concepts are developed here. The first is the pre-shaped tip of the wire. This is the way we use every day when we treat bifurcation lesion. We can use a short bend sharp in the distal tip or a wide sharp in the tip of the wire. Sometimes we can use a double shape tip. It depends on the anatomy. If the vessel is large, we can use a wide bend. If the vessel is small, we can use a small one. If this technique doesn't work, we can use the reverse wire technique. This means that we need to perform we need to create two curves in the wire, one in the proximal side and a small one in the opposite side. And we cross the main vessel with a knuckle, which it allowed to the distal part of the wire to cross this change in anatomy when we have a wide angle between the main vessel and the side branch. When this technique doesn't work, we can use also the dual lumen catheter in this CTO complex lesion. We can cross this dual lumen catheter cross this long CTO lesion. This dual lumen catheter can deliver both wires at the same time in the main vessel and in the side branch, and it can facilitate the rest of the procedure. Another kind of angulated catheter can be used They call also sophisticated way to treat bifurcation. You can see here severe stenosis in the ostium of the side branch. It is posterolateral view. And you can see that the P-shaped wire failed to cross this side branch, which is relevant. That's why the use of the angulated microcatheter increased the support and the wire crossed the stenosis with any problem. And also there is a deflectable tip single lumen microcatheter. There is some microcatheter with the distal part we can modify the angulation of the distal part, and it can increase the support, especially in the ostial lesion and when we have some tortuosities. And the final way to prevent side branch occlusion is the balloon block and support technique. And this technique is when the microcatheters are not available or fails to attempt the side branch, we can use this technique and we can inflate balloon in the distal part of the bifurcation. And when the wire is crossing the main vessel, it will go easily to the side branch because the distal part of the vessel is closed by the balloon. Now we talk about baseline wiring vessels, side branch, before main vessel stenting. Now we will talk about rewiring the side branch after main vessel stenting. We can use the same techniques with the same wire, with the same sophisticated technique like angulated microcatheter and deflectable tape catheter, which helped in this case to open the side branch occluded side branch. And finally, there is another way to protect the side branch called the active protection with not the wire gelled balloon, but gelled balloon technique. It was described by Professor Burzota. It means that we put a balloon in the side branch, non-inflated, and we stent the main vessel. If the side branch is open, we pull back the balloon. But if the side branch is compromised, we can inflate the balloon, open the side branch, and remove it again. And we do both at the final way. Here is my last slide. In this CIT Resolve trial, they compare active side branch protection and conventional protection with the gel wire technique. And we can see that the rate of side branch occlusion and the decrease in TME flow in the side branch was significantly lower in the active protection strategy rather to the conventional strategy, but the number of periprocedural infection, MI, was the same, particularly in both techniques. And my conclusion is this central illustration, which resume all techniques to prevent the side branch, even prevention, conventional prevention or active prevention, and the use of sophisticated technique to reach the side branch. Thank you for your listening.
Thank you very much for your very illustrative presentation. And it's my pleasure to call the last speaker, Professor Rania Hamami, a bright interventional cardiologist, but also a bright professor. She's going to talk about a very pertinent topic, restenosis in the era of drug-eluting stents. Please, Rania.
Thank you, Professor Bourdel. I am so pleased to talk about this topic. And really, I am so pleased because I am your student. And I learned to do my first coronarography was Professor Borzella. So I am so pleased to be here. So I think it's a relevant topic because we get this year a new consensus of SCI, and we will get after that a joint session with SCI, and we have here the past president of the SCI, a member of the SCI. And I think that if we look at the incidence of this complication, really it has significantly decreased. In 1990, it was about 40%, but it was with BMS. Now, if we have a look at now, the incidence of this complication is about 2 to 3%. As you see, it depends on the material, the stent, the thickness of the stent, and the polymer. But let's see what happened in real life, because these results are the results of randomized trial. If you look to results of real life registry, and here we have the American registry, we find that it's more than 2 or 3%, it's about 10%. And I think the most problem is the problem of recurrent instant restenosis, which occurs in approximately 20% of all instant restenosis cases. And the predictors of this incidence is really the most predictors, the strong predictor is the number of stents, layers placed at this location. If we look at the results of our registry, the Tunisian registry, which was performed in 2020, between February and June, we collected more than 2,000 patients, and we found that the risk of instant restenosis when we put this, it's also high, about 12%. But let's say that this result, it depends because we have many diabetic people in our cohort. More than 50% of our patients are diabetics. For the causes of this complication, it's classic, we know, maybe we have stent under expansion, stent fracture, neoantimal hyperplasia, but I think the specific mechanism of instant restenosis for drug-eluting stent is neoatherosclerosis, and if we compare the instant restenosis between the two stents, you see that for BMS, it's always neoantimal proliferation. For this, it's neoatherosclerosis and especially inflammation. The restenosis will be diffuse for BMS, but it will be focal and it involves usually the stent ages. And if we look at OCT, we will note that it will be a homogeneous high signal tissue iconicity for BMS and heterogeneous for DES. I think that intracoronary imaging now, it's a must in 2023. Of course, we will treat only patients who will show positive stress test. But I think why this tool is very important because it will identify the mechanism of instant restenosis. It will allow to optimize the interventional treatment, analyze the number of stent layers at the lesion site, and assess the expansion of each layer of stents. So I have no much time, but you can see the difference between neoantimal hyperplasia with homogeneous bright uniform layer, neoatherosclerosis, and stent underexposition. You see, with OCT, we can assess the number of stent layers, and we said from the beginning that the number of layers is the stronger predictor of instant restenosis. We used to use Roxanne-Meran classification, which is a specific classification to BMS. Now we have two new classifications, a classification which was published this year by Sky. As you see, this classification is based on time interval and causative factor. Early, if it happens during the 30 first days, and the morphological substrate is undersizing, under expansion, stent fracture, late between 30 days and 1 year, and very late after 1 year. I think this is a relevant classification because it will inform us about the mechanism of instant restenosis. Another classification is the Waxman instant restenosis classification, which is also based on the mechanism of instant restenosis. And this is very important because it will allow us to choose the treatment option after that. For example, if we see the class 1, it's mechanical. It means that it's about underexpansion or stent fracture. And you see for underexpansion, we have to choose high pressure balloon, stent fracture death. We will see after that how to manage this complication. So I think we should forget uncoated balloon now in 2023 because it is also the source of complication and risk of restenosis. No clear evidence guides which type of DES should be used to treat in-stent restenosis. There is no consensus on whether the stent type should be changed when an additional DES is implanted. And I think in 2023, we must combine many treatment options. We must prepare well our lesion. Even if we will use drug-eluting balloon, we can start with cutting balloon, scoring balloon, and then we will use drug-eluting balloon. So preparation is crucial, and we must really prepare lesion with residual stenosis less than 30% without flow-limiting dissection. I think this is a full slide, but the main conclusion is that DEP is now well demonstrated that it is superior to uncoated balloon. DEP is not inferior to DES, but we have to know that not all the DEP are the same. Also, how to prepare lesion. Scoring balloon and cutting balloon are very interesting tools because it will minimize barotraumatism to the vessel and avoid slippage of conventional balloon when inflated over fibrotic scar. I think now there is new perspective. It's the bioresorbable vascular scaffold, and yesterday we get a very nice talk from our friend Mamas about a new scaffold. Also, I think if you will consider the mechanism of in-stent restenosis, if it's about well-expanded stent with exuberant neoantimal hyperplasia, we can use cutting balloon followed by drug-coated balloon. Under expansion with the soft tissue, we can use a high-pressure balloon, the APN, but if it is about calcified lesion, we should better prepare lesion using rotablator or lithotripsy and shockwave. I think the problem of repeat in-stent restenosis is really a big problem because we have to avoid a third layer stent. We should use drug-eluting balloon, and if there is no other option, maybe we can opt for cabbage. So I will finish by this case from our department. It's a 70-year-old patient who is diabetic. He got 2 deaths in 2019, but there was a gap between the 2 deaths, and he showed an acute coronary syndrome this year, and as you see, there was a restenosis, in-stent restenosis. So we tried to prepare the lesion with balloon and coated balloon, 1.5 millimeter, but we failed to cross the lesion with a 2 millimeters balloon. So we decided to go rotablation in this patient, as you see, using 7 French catheter and 1.5 bar, and then we get a very good results. But unfortunately, as you see, 3 months after, we get again a restenosis, and we tried to improve result using drug-coating balloon. I think I have just one conclusion. It's before putting a drug-eluting stent, we must prepare our lesion well, because failing to prepare is failing to fail. Thank you.
Thank you very much, Rania, for this brilliant presentation. So we can start the discussion. How much time do we have for this, please?
I think maybe 6 minutes.
Yeah, we only have 6 minutes, so I'll let you leave.
Any questions from the audience? If not, I just think I'd like to comment on something that Aliaid Kifo showed in her presentation about barriers for women who go into interventional cardiology. And I think I was very impressed when I attended the meeting here to see many women actually in Tunisia on the panels and faculty and so on. And I think the real barrier is we've been brainwashing women and the community that it's the radiation, that it's the work hours, and it's really neither, right? We see women in OB field and other fields that are very demanding in terms of the workload and the hours. It's really the culture in the interventional cardiology community that is not welcoming to women a lot of the times, and that's what the deterrent is, because women, like men, want to grow in their field and need to see an opportunity for growth where they become faculty leads, where they become professors, where they become directors of cath labs and so on. And I think we're starting to see some headway, but I think we still have some room to go.
Thank you.
Well, just one more word about this. I think that if a lady wants to be an interventional cardiologist, she can do it if she wants it. But if she doesn't want, she will never do it. I have a question, if you don't mind. Do you have any questions or any comment about this subject or another one? Otherwise, I have a question for Professor Rizek about calcification. You told us that many of the calcifications can only be carefully evaluated by CT scan. So how would you advise, to go through CT scan for all people where we see calcification in the coronarography, or do you have any advice about this? And do you think that the diffusion of calcification help us to choose between PCI and cabbage? And do you have any idea about any
so in
stratification for this?
Our cath lab, I have to say that we have quite new scan for CCTA. So the image quality, as you could assess, is really excellent. And in our cardiology department, we patients with chronic coronary syndrome are assessed according to the risk of having coronary artery disease. So patients with lower risk go to non-invasive coronary angiography, and patients with higher risk go directly to the catheterization laboratory. But I have to say that because we perform every year a workshop on calcified lesions, in many workshop candidates, and not only, when we see big and huge problem with calcifications, because I have the opportunity to send patient to coronary angio, I really like to perform coronary because I have a lot of information. Like in this case I performed, which was really astonishing, that we see that we will need not only rotational atherectomy, but we see that we will need 1.5 or 1.75 BER, so it is excellent. And the second part of your question was?
Is there any score or something that will let us go rather for cabbage more than PCI?
Yes, so we are, I would say that we have to take it into account, because calcification in an obvious reason increases the risk of PCI. But in high volume rotational atherectomy centers, orbital, in my cath lab we have orbital, we have rotational, and we have IVL. We have experts in all three entities. And our surgeons very often decide during heart teams, Christoph, you are experts in calcified lesions, we give you light, green light, go to cath lab. But in many cath labs it should be, such a patient should go to cabbage because of calcifications, for safety reasons. Thank you.
Are there any questions or comments?
I have a question. If we haven't coronary imaging in the cath lab, how to do, which tool we have to use to prepare calcification if we haven't IVUS or OCT in the cath lab?
So if you have not IVUS or OCT, for sure you should familiarize with this new document on calcified lesions, and you should follow this angiography algorithm. And we advise that, as I said, first avoid direct stenting, then try to assess the lesion first without giving contrast, because you will be able to assess the calcifications much better without contrast. Third, try to assess if you have calcium layers on both sides of the lumen, because if you have it, it means that your patient needs, for sure, atherectomy. And in my opinion, if it's a chronic coronary syndrome, you should not start with angioplasty, because you will fail, or the risk of failure is unacceptably high. Then you should be sure that your lesion is very well prepared for stenting. So you have to achieve full balloon expansion, but not in one projection, but in two orthogonal projections. And second, you have to be sure that your balloon is not too small, because undersized balloon may cover calcifications. After putting a stent, you have to use a stent booster, and again, best in two orthogonal projections to assess if it's really fully expanded, and you should liberally post-dilate the lesion. And I think that it's very, very important to follow these rules. Thank you.
Yeah, I would also consider referring to a center where they do have intracoronary imaging if it is a very complex calcified lesion. Well, thanks everybody. It was a very educational program this afternoon, and I think we move on to the next session. Okay, so Professor Rania, I think we start the next session with Sky and the Saudi Society.
Professor Morali, Professor Lahidib, Professor Walid Ben Ali, Professor Luz.
I have the honor to introduce the last session. It's a session in collaboration between the U.S. Society of Interventional Cardiology, the Saudi Arabian Society of Interventional Cardiology, and I introduce my colleague from the USA, Dr. Kavinsky, to talk about coronary artery disease and implantation of TAVI.
I want to thank everyone for inviting me here on behalf of the Society of Cardiovascular Angiography Intervention at Harvard University Medical School. I'm going to talk about a common problem, and this is a problem which actually I have more questions than I have answers. As you know, severe aortic stenosis really affects people of older age, And coronary artery disease also is an age-related disease. So it should be of no surprise to anyone, that coronary artery disease is common in patients with aortic stenosis. About half the patients undergoing TAVR have coronary artery disease. So this is a common entity. And most of the clinical practice guidelines recommend coronary angiography or some sort of ischemic evaluation prior to any kind of surgical or transcatheter aortic valve replacement. This is particularly important in patient subsets, such as patients who have a history of coronary disease, or at least one cardiovascular risk factor, suspected myocardial ischemia, LV dysfunction, older age, or postmenopausal women. So, but basically, I think most patients undergoing TAVR in today's day and age get some sort of an ischemic evaluation, and usually that's going to be coronary angiography. Coronary angiography is the gold standard and remains the standard for evaluation of coronary artery disease in patients being considered for TAVR. It has lots of advantages, and you can see them all here. It's unaffected by the calcium, although we just heard talks showing that angiography really doesn't show calcium well. Most practice guidelines are based on angiographic extent of disease. And if you are doing invasive coronary angiography, you can do immediate invasive lesion assessment, and you can have the potential to proceed directly to PCI. Usually, coronary angiography is done preceding TAVR at a different setting, so it's done ahead of time. Although it can be, in some patients, done at the same time as TAVR, particularly in low-risk patients. There are disadvantages to invasive coronary angiography. You should all know what they are by now: vascular complications, contrast nephropathy, and obviously the delay of treatment. Multi-slice CT is a newer option for evaluating patients for ischemic heart disease. The nice thing is it's non-invasive, but again, it has artifact that can be seen in patients with a lot of calcium. You can see the pooled sensitivity, specificity, positive predictive value, and negative predictive values for CT. And although it's very sensitive, its specificity and positive predictive value are not over 90%, they're less. So most students of the field feel that multi-slice CT is not really the standard for ischemic evaluations in patients being considered for TAVR, that invasive coronary angiography really is the gold standard. Now, invasive coronary physiology assessment at the time of coronary angiography is something that can be done. Although there's a lot of conflicting data out there, severe aortic stenosis does affect IFR and FFR measurements and tends to underestimate them. But however, the guidelines still recommend using the same benchmarks of an FFR less than 0.8 and a IFR less than 0.89 as the cutoffs for ischemia. So most patients undergoing angiography for being TAVR are not having coronary artery disease-related symptoms. Most are asymptomatic. So which patients should be treated then? This is a big question. It's a big question mark. There's a lack of randomized controlled clinical trial data. There's a lack of consensus. And then more than that, the timing of PCI, if you're going to do it in these patients. Should it be done ahead of time, before their TAVR, after their TAVR, or at the same time as their TAVR? These are issues that remain to be resolved. And then, of course, patient selection. Most of the patients undergoing angiography for TAVR are asymptomatic. So which of those patients should you treat? If they're symptomatic and having angina or myocardial infarction, acute coronary syndrome, or acute heart failure, those patients should be treated, but when? And then lesion location and severity is the important question. And then the choice of transcatheter heart valve. The choice of transcatheter heart valve heavily influences your ability to treat coronary artery disease percutaneously, and I'm going to show you that in a second. This is the clinical data as it exists today. There's a meta-analysis of 11 studies enrolling over 5,000 patients with documented asymptomatic coronary artery disease and comparing PCI followed by TAVR to TAVR alone. And in this meta-analysis, they found no difference in outcomes in terms of 30-day mortality, myocardial infarction, renal failure, and 1-year mortality in patients treated with PCI versus not being treated with PCI in asymptomatic patients. And there was one randomized trial, the activation trial, which randomized patients comparing PCI before TAVR versus TAVR alone in patients with documented asymptomatic coronary disease. They had to have at least one lesion, 235 patients. The primary efficacy standpoint was all-cause mortality or rehospitalization at 1 year. And there was no difference in outcomes between PCI versus no PCI prior to TAVR. So most of the data out there shows really no benefit to PCI in patients with asymptomatic coronary disease, incidentally noted during a pre-TAVR evaluation. There is a randomized trial which is ongoing, which we've been part of, called the Complete TAVR trial. In this trial, patients with coronary disease are randomized to undergo TAVR versus PCI. Now, in this particular study, TAVR is done first and the PCI will be done second. So patients undergo coronary angiography. They have at least one lesion of 70% in a major epicardial coronary artery. Then they undergo TAVR, and then they are randomized to follow-up PCI versus no PCI in medical management. This trial is ongoing, and the results should be available in the next couple years. But until then, we're just not going to know. The European guidelines for myocardial revascularization, and I've circled the important one, that PCI in patients undergoing TAVR or surgical valve replacement should be performed in patients with a primary indication to undergo TAVR and a coronary artery lesion greater than 70% in a major epicardial coronary artery. Now, I have to tell you that this is the guideline, but I don't necessarily do this, not consistently. This is a two-way recommendation with poor level of evidence C. So this is just a guideline, and I have to tell you in my practice, I sometimes don't do this in very elderly patients. If you're going to do PCI, then what is the timing of that PCI? Should it be done before the TAVR, after the TAVR, or combined? There are advantages and disadvantages to each. The advantages of doing it ahead of time is you don't have a valve in the way that can interfere with your cannulation of the coronary arteries. There's a lower risk of ischemia-induced hemodynamic instability when you do your TAVR. And then there's less contrast. Of course, when you use physiologic measurements, as I said, they can be affected by severe AS, and then you have a higher risk of hemodynamic instability due to aortic stenosis. Doing PCI after TAVR has its own problems. Although physiologic analysis is more accurate, there's a lower risk of hemodynamic instability during complex PCI because of the lack of the aortic stenosis. But there's a potential for more instability because of deferring the PCI after TAVR. Then when you're doing your TAVR procedure, you could have acute ischemic problems. So doing PCI after TAVR has its own issue. It's more challenging and potentially compromised coronary access due to the transcatheter heart valve, less stability and support of your equipment, and potential transcatheter heart valve dislodgement, although I've never really seen that. And then combining PCI and TAVR together, I don't think anyone really does this. You could do it in really low-risk patients, but the length of the procedure, the additional contrast, in my mind, makes this a non-starter. So what are the other important issues? The issues of transcatheter heart valve design. Well, the stent frame height, the higher the frame, the superannular location, the skirt height, open cell versus closed cell designs, transcatheter leaflet height, commissural alignment, all affect your ability to re-access coronary arteries after transcatheter valve implantation. This is also affected by the anatomic factors such as sinuses of Valsalva, the height and width of the sinotubular junction, coronary heights, and length of the leaflets. These are the main valves that are out there on the market right now. You can see that the balloon expandable valves on the left, the Sapien 3 has the smallest frame and the smallest height, and you can see in the bottom figure that it gives you the freest access to the epicardial coronary arteries after implantation. All the other self-expanding systems require either to go through the cells or behind the cells, and it makes it far more difficult. And then the final concept of the importance of commissural alignment. When you're putting transcatheter heart valve in, it's becoming more and more important to ensure commissural alignment so you don't have the post of the transcatheter heart valve sitting right over the coronary ostium. So in conclusion, most patients with asymptomatic incidental coronary disease do not really need to be treated. Asymptomatic patients with high-grade proximal disease of a major epicardial artery should be considered for treatment in accordance with published guidelines. The timing of PCI is unclear and should be guided by clinical presentation. Patients with acute coronary syndrome should, of course, be treated ahead of time. Performing PCI in patients with severe AS can lead to hemodynamic instability, and a consideration should be given to palliative balloon aortic valvuloplasty or mechanical circulatory support in these types of patients. The choice of transcatheter heart valve should also be taken into consideration. So if you're going to be reaccessing coronary arteries and a patient has extensive coronary disease, I really advise you to use a balloon expandable valve with a short frame that gives you very easy follow-up access to the coronary arteries. The Medtronic valve can be very difficult. And then commissural alignment for transcatheter heart valves is a newer concept which is going to gain increasing traction and ultimately will be responsible for ensuring commissural alignment on these patients. So with that, I want to thank you for your attention and for this important topic. Thank you.
Thank you. I think we have the question. If there are some questions now from the audience. Dr. Hajlawi.
Congratulations for this excellent presentation. I have one practical question. When you go for TAVI in a patient, in which situations do you recommend to go with a catheter and a wire in the coronary and to put the stent, waiting the occlusion happening?
If you have patients who have extremely low-lying coronary arteries.
How much? 10 millimeter, 9, 8?
It also depends on what the size of the, these are not simple questions. The height of the coronary is important, but so is the width of the sinuses.
How much for the sinus of Vasalva?
So if you have you have a small sinus and you're using a 20 millimeter valve and you have coronary heights that are under 9 or 8 millimeters, then you probably should be protecting your coronary.
Do you protect both or just the left main?
I'm sorry?
You protect both arteries or just the left main?
Yeah, mainly just the left main. You know, you're preventing catastrophic consequences. And actually, the best way to protect your coronary is to not get into that situation in the first place. I don't necessarily believe in coronary protection because it can get you out of the lab. But even when you have left main occlusion and you need to deploy a stent, and you deploy that stent, and you get the patient out of the lab, there's a very high incidence of late stent failure because of the mechanical interaction of the transcatheter heart valve with the left main stent. And I've had more than one case of patients coming back with catastrophic left main stent occlusions after I had bailed them out of a occlusion during a transcatheter heart valve procedure.
Thank you. In the last slide, you are advising us to put TAVI with balloon. It's better. It will go fast, and not to go for auto-expandable valve. But I have a precise question. What about the accurate valve? It seems to be one of the best in the class.
Yes.
For the reaccess. Do you recommend this
So
kind of valve?
it has large cells, and it also has a annular deployment. So yes, as we move to the future and we're seeing newer and newer valve designs, the issue of coronary access is, of course, important and is paid a lot of attention to by industry. And you're going to see new valve designs with open cells that you can get freer access to the coronary arteries. But I would advise you to, if you need to get to the coronary arteries, you know for sure, and it's a big deal, then the safest approach is still a balloon expandable system, or else a self-expanding system with an intra-annular valve design.
And what about the delayed obstruction of the coronary? You didn't speak about that, and I heard
sorry,
that we have such complication with some TAVI. The delayed obstruction that happened 2 or 3 days or even...
Dissection?
No, delay obstruction of the left main. Delayed obstruction.
Delayed obstruction. Well, I have to admit to you that I don't see this very often. Most of the problems I see with coronary obstructions are immediate, intra-procedural, or immediate post-procedural. I very seldom see complications that are occurring down the road, days, weeks later.
Another question from the audience.
Hello. Good afternoon. I enjoy your talk. Thank you very much. It's a very hot topic, and we always see this one in our patients with the severe aortic stenosis and coronary artery disease. Just a question is, in your practice, daily practice, do you do coronary angiogram for all patients, or is enough for you CT scan? And if you are doing a coronary angiogram, do you do it at the same setting of TAVI, or after, or before?
So our practice is to do ischemic evaluation ahead of time at a separate sitting. The predominance is invasive coronary angiography because we find it to be more reliable. Although CT is sensitive, it sometimes is not as specific, and the positive predictive value isn't as good. So we prefer invasive coronary angiography. Now, CT can be used, but I usually reserve CT for low-risk patients, so younger patients, patients with bicuspid valves who have a low risk of having obstructive coronary disease. I will do CT in those patients.
Right.
And then I usually do it ahead of time, not at the same sitting.
Yes, that's a very important thing because
most of these patients are older. Their kidney function may not be normal. It takes additional contrast, additional time, and I find it safer to do it ahead of time.
Another question.
Thank you for your call, for your talk. I'm just wondering how we can define symptomatic coronary artery disease in the setting of aortic stenosis. It's a little bit confusing because we can't, the imputability of the symptomatology, it's due essentially to the aortic stenosis or to the coronary artery disease.
Obviously, it can be a difficult differentiator, right? Because the main symptoms of severe aortic stenosis are chest pain, shortness of breath, and lightheadedness. And angina is the same thing. So yes, it at times can be difficult to differentiate. But oftentimes you can. Patient presents with chest pain, shortness of breath. They may have dynamic changes on their EKG. They may have elevated cardiac biomarkers to help give you a clue. Or they may have a regional wall motion abnormality and echo to help guide you in that decision making. If it's just a symptom, it can be difficult, but usually there's supporting data that would help you lean to the fact that maybe the ischemia is a problem. And then I would caution you about the timing of PCI. I've had patients with very severe aortic stenosis and left main disease, and I've tried treating their coronary disease with their critical aortic stenosis, and I've gotten into lots of hemodynamic trouble, patients crashing from their aortic stenosis. So I have actually, in my personal experience, although I hate to bring up my personal experience is to treat significant coronary disease after you do a TAVR. Do the TAVR first, then treat the coronary disease, excluding patients with acute coronary syndromes.
So symptomatology doesn't matter really, but the prognosis of the lesion in the coronary artery angiogram. And if you have proximal and life-threatening lesion, we must treat it anyway.
You're going to treat it, but I have to tell you that, and I've done a lot of TAVRs now, 1,500 or something like that, and I've never had ischemic problems during a TAVR. During rapid pacing, I've never had acute ischemia, but I've had lots of problems trying to do coronary intervention on patients with very severe aortic stenosis. I mean, once you have any kind of blood pressure compromise, patients quickly spiral out of control. and then you're struggling to try and do an emergency valvuloplasty. So if you have to do the PCI on a patient with severe AS, I advise you to do a palliative balloon aortic valvuloplasty at the beginning of the procedure.
Thank you.
It's an honor, it's a pleasure,
Yes.
and it's an opportunity for us to ask a lot of questions. So if you please, two short questions for me. The first is you speak about PCI performed in STEMI or in instability hemodynamic situation. And when you do balloon bridge in this situation, what's the delay to finish job?
If you're asking me if I'm going to do a palliative balloon aortic valvuloplasty before a PCI?
In instability, in STEMI or in instability
If it's STEMI, you just go for the coronary artery. You just got to treat the coronary artery. If there's ACS, you got to treat the coronary artery. It's just, that's the compelling indication. You got to go with the compelling indication. Okay. I'm talking about in a stable patient who's not actively ischemic, who you bring to the lab on an elective basis, what you should do.
Okay. The second question, what do you think about the industry, the future, the problem of reaccess?
Yeah. So as I mentioned a few minutes ago, newer valve platforms are being developed all the time. And those valve platforms are addressing these kinds of problems. How to treat small annulus, how to treat low-lying coronary arteries, small sinuses, and then the issue of TAVI and TAVI. So some of the newer valve platforms have open cell designs that allow for more ready access to the coronary arteries. And they also have the ability to do commissural alignment. Commissural alignment allows you to free your access to the coronary arteries by aligning the leaflets with the native leaflets and giving you more ready access to the coronary arteries.
Thank you.
So if I understand well, the deriver from anteris will be the optimal valve for you.
From the optimal valve for me? I prefer a balloon expandable valve platform. Ease of use, small frame, annular implantation. Coronary arteries are usually freely accessible. You don't have to think about it. The problem with balloon expandable systems is commissural alignment. There's no option for commissural alignment on the current platforms, and that's becoming a more and more important issue. And I think in newer generations of balloon expandable systems, you'll see commissural alignment functions in the delivery system.
You're talking about X4, but also a very good point. I understand the balloon expandable in Canada, you are 50-50 in Montreal Heart Institute, and the problem also with the Notion results, we cannot ignore the performance of the supraannular valve, because we see with Notion that even they are superior to surgical prosthesis, and we have a poor signal we will see during TCT for the 5 years for low risk for SAPIEN, but we saw already a signal that there is more SVD with S3 compared to surgery. So what's your opinion about that?
Honestly, I don't think a single valve platform is going to be applicable to everyone. You're going to have a couple systems on your shelf that let you individualize your treatment to a given patient's history, clinical presentation, and anatomic features. And you fit the valve to the patient. No valve system is going to be perfect. So I think if you're a new operator out there, you're just getting started, balloon expandable is a good way to start, and then move towards self-expanding systems. If you're just starting out and you have lots of patients with lots of coronary disease, balloon expandable platform is nice, at least right now.
Yeah, and I think there is a lot of opportunity with, we tried last week, I think, or 2 weeks ago, we put the anteris, the Duravere valve involvement. It's a balloon expandable, and we have an amazing hemodynamic performance with commensurate alignment features.
Yeah.
So I think the future is going there. Thank you very much.
Well, again, I'm sorry for taking so much time. I asked for a couple extra minutes. Look, I took 30 minutes. So
thank you very much.
Let's move on.
Thank you very much.
I would like to introduce my friend, my colleague in the same cath lab, the 20 years, for 20 years. And I would like to announce that Dr. Nadam Hajlawi from the Military Hospital of Tunis is the principal investigator of the next registry of TAVI in Tunisia. It's a very interesting registry. I would like to be a nucleus for other society of neighbors country to participate to this registry. In Tunisia now we have 10 years after the first implantation in 13, and Nadam will talk about the association of mitral valve, because in our countries we have rheumatic valvular disease. The situation is a little bit different between us and the other countries from the north. Nadam.
Thank you, Professor Lahideb. It's really a pleasure to be here in this beautiful island. I will present you some data and an interesting case of TAVI in a patient with a mitral valve. It was a prosthesis in the mitral position. This is the hospital where I work. It's the Military Hospital of Tunis. And I have a team, a very good team, aggregate professor, assistant, nurses, and technician. And we started a good program of structural. Now TAVI becomes a daily activity, and we are trying to launch a program about the mitral valve. So we are starting an activity with MitraClip. I will speak a little bit about TAVR in patient with mitral prosthetic valve. Why this situation? Because performing TAVI in patient who were implanted prosthesis in mitral position is a little bit challenging. Why? Because we have the proximity of the aortic annulus to a non-compliant prosthetic mitral valve ring. So we have this space. It seems to be when it's too tight, we can have bad interaction between the valve, which will be implanted in the aortic position, with the mitral valve. We have also other related risk factors, which include the damage of the mitral leaflet by the guide wires and by all the manipulation. We have an increased risk of endocarditis at follow-up, and we have also to manage anticoagulant in these patients because of the prosthetic valve in the mitral position. Also, in this situation, you know, all the trials of the most frequently used TAVI prosthesis have excluded patients with previous mitral valve replacement. So we have many patients with which have an indication for TAVI and a mitral prosthetic valve, and this population constitute up to 30% of all TAVI patients. But in the large national registries, surprisingly, do not specifically mention post-MVR patient, mitral valve replacement patient. Also, the current European guidelines on acquired heart valve disease do not cover this valve scenario, so this topic is a little bit absent in these guidelines. I will show you a case that we managed in the Military Hospital of Tunis. It was a male of 74 years old. He has hypertension, dyslipidemia, and diabetes requiring insulin, and the glaucoma and the medical treatment were controlled. He was diagnosed also with Wagner disease, a severe form, since 2012, but it was stabilized by medical treatment, corticosteroids, and methotrexate. This patient has had a history of mitral valve disease. It was a rheumatic stenosis, and he underwent a closed heart mitral commissurotomy in 1978, so when the patient had 30 years old. He suffered after that from stenosis, so he underwent a mitral valve replacement the 4th of March 1992 when he was 44 years old. It was a star valve size 3. So the patient was suffering from dyspnea, and the biology was normal. The EKG showed an atrial fibrillation, and the echocardiography, mitral prosthesis in place with preserved movement of the ball, the armature that overflows into the left ventricle, and then we'll show you the CT scan, which shows very well that. And we have an aortic stenosis with maximum speed of 4.8 meter per second and mean gradient of 65 millimeter of mercury, which gives an orifice area of 0.54 centimeter square. This patient was sent by our colleagues of the internal medicine department for TAVI because of frailty, comorbidities, and the previous surgery. The coronary angiogram showed atheroma without significant lesions, and we performed the CT scan. Here you have the data of CT scan, but the CT scan, in this situation, the quality is qualified as bad because of the metal of the mitral valve. Here you have the annulus, so the area, it was about 440 millimeters square. And you have here the image which shows the protrusion of the cage of the mitral valve, so it will not allow us to work easily when we will implant our valve. Here we have calculated the distance between the annulus and the cage of the star. This distance is about 17 to 20 millimeter maximum, but we know that we need at least 35 millimeters between the annulus and the tip of the nose cone of the balloon. Otherwise, the cage can push up the balloon and the valve during the deployment, which makes it very difficult. At that time, we were certified to be able to implant either SAPIEN 3 or Accurate Neo 2. But, you know, if we go for a SAPIEN 3 valve, it will not be possible because of the risk of the pop-up of the valve. Imagine that we implant a SAPIEN 3 in this situation with the cage which is protruding in the ventricle. It will not be possible. So SAPIEN 3, we are certified in implanting it, but we cannot implant it. So we got another idea. Why not to go for an Accurate Neo 2? Why Accurate Neo 2? Because at that time we were certified also to be able to implant solely this kind of valve. But you know, it's an auto-expandable valve, but it is not retrievable. So imagine if we deploy this valve and the stent opens. If there is a bad interaction between the valve, mitral valve, and the Accurate, so we cannot correct things. So what to do? Which valve? Ideally, this valve has to be auto-expandable, retrievable, and ideally it doesn't go deep in the ventricle to not touch the cage of the mitral valve. It's like a SAPIEN 3, but auto-expandable and retrievable. So we did this procedure the 4th of March 2022 with this valve. It was an auto-expandable valve. It was a Navitor valve. We have an annulus of 24, so we choose a valve size of 27, and I will show you the procedure. Here you have the mitral valve with the ball, and we are trying to go with our wires through the aortic valve, which is heavily calcified. So here we succeeded to go through the aortic valve, and after that we brought a balloon. This is the balloon, and care was taken for the balloon to be sufficiently in the outflow of the ventricle to not touch the cage and of the mitral valve. And we succeeded. We did a pre-dilation because of the importance of calcium without making bad interaction with the cage of the mitral valve, which is protruding in the ventricle. Here you have the valve. So we brought a Navitor valve, which is an auto-expandable valve with an annular position of the leaflet. Here we are trying to implant it. We have the fair to touch the cage of the mitral valve. So we tried first, and we were not happy with this position. It was a little bit high because we have the fair to touch, so we make it a little bit high. And after that, we changed the position. And finally, we were satisfied with this position. And before complete release of the valve, we called our colleague to do echocardiography to be sure that there is no bad interaction between the valve and the TAVI and the mitral valve. So after that, we succeeded to implant it correctly without bad interaction. So as you know, when we go to see the literature, we will only find some case reports and some small series. So here you have a paper published in 2014. As you see, all the series speak about 4 or 2 patients, not more. For the mechanical ball linkage, we can here see that the Sapien 3 was implanted and also some auto-expandable valve. Another article of 2018 find the same thing. We have only some patient and some small series. I want to emphasize on one thing is when the interaction happens between the TAVI prosthesis and the mitral valve, which is already implanted, complication can be serious. We can have complete heart block, we can have thrombus, and it can lead to death, and it was published. So the take-home message here, TAVI in patient after mitral valve replacement is feasible. Meticulous peri-interventional echocardiographic and computed tomography planning is essential. Echographic guidance can be helpful. Further study is warranted. There are no big studies, and transcatheter valve insertion should not be denied strictly on the basis of a previous mitral valve operation, and the strategies for success include pre-procedural study of the existing prosthesis, close examination of the aortomitral area. If it's less than 4 or 5 millimeter, it can be dangerous, and shape of balloon at valvuloplasty, as I showed you with the Sapien 3, and careful prosthesis selection and slow deployment are key of success. Thank you for your interest.
Congratulations, Professor Ajuri, for this very challenging and beautiful case. So you don't have enough time. You will move for the next speaker, and you'll keep discussion in the end of session. I have pleasure to invite the next speaker, Professor Kashkari from KSA. He will talk about an indication, a small indication for TAVR for aortic registration. Donc, Professor Kashkari is the head of International Cardiology Association in Arabia Saudite. Up to you.
Assalamu alaikum. So the screen is this, we read it for, okay. So my talk about a very interesting area that most of the TAVR people, most of the implanter people, they start to explore this topic, which is TAVI in aortic regurg. TAVI in aortic regurg, let's just have some idea about the prevalence of the disease. Our pure aortic regurg represent 13% of the lesion on the left side of the heart. AS, the most common in North America, then mitral regurg, then aortic regurg, then MS. Probably the prevalence in our region is different, being the rheumatic mitral valve stenosis is the most common. So, and aortic regurg is well known that it is the disease, in North America, is the disease of elderly people related to degeneration. But in our region, we see a lot of aortic regurg as a complication of infective endocarditis. So bottom line, aortic regurg is not a nice disease. It is a disease come with too many complications. Patient with severe, need to go back. Patient with severe aortic regurg and low ejection fraction have an annual mortality of 20%. So that's a very high number. But unfortunately, only 5% of the patient with aortic regurg and poor ejection fraction, they go for surgery, according to the data from the Euro Heart Survey on valvular heart disease. So, you remember, long time ago, we used to look and watch at the aortic valve stenosis patient until they pass away. Now, we are doing the same with the with aortic regurg patient, hoping we're going to find the technology to save these people. So, what is the difference between aortic valve stenosis and aortic regurg? Severe AS is characterized, as you know, by pressure overload. The door is closed, so the muscle have to work very hard to overcome this, and patient will develop concentric LVH and afterload mismatch. Fortunately, this mechanism, once we relieve the obstruction, patient dramatically improve. They have a reserve in their hypertrophied myocytes. So after TAVI, ejection fraction improve, and we see a marked regression in the LVH. And that's explained why patients have clear benefit of quality of life and expectancy after TAVI. This is not applicable for aortic regurgitation patient, because for the patient to have a symptom, it's a long time of regurg for the patient to have symptom. By the time he's having symptom, already the heart is weak, and already there is some changes within the myocyte itself, which is according to the Frank Starling mechanism, it's an irreversible way. And that's what I'm saying, that 30 patients with acute with aortic regurg and poor ejection fraction, they have very poor outcome. This is from anatomic point of view, degenerated aortic valve stenosis have progressive calcification of the leaflet and annulus. In aortic regurg, there is, in the majority, there is minimal, very minimum calcification if any is there. Plus, that the aortic root is dilated, and the aortic annulus also, it follows the sinus and it is dilated. The anatomical difference, it makes the true challenge for the TAVI in aortic regurg patient. Look at this. So that's the annulus of aortic regurg patient. There is no calcium, and the calcium is important to hold the device from embolization. And this is the leaflet. It looks nice, but actually there is aortic regurgitation. As you can see, the office of the leaflet is there. That's the annulus of aortic stenosis. You see the calcium to anchor the valve. Here, aortic regurg patient, and here, aortic stenosis patient. The calcium, you help to anchor the TAVI device. Here, you need to find a mechanism to anchor the valve. So, the technical challenges during TAVI for aortic regurg, it's these 3 points. The absence of annular and leaflet calcification, which is important to anchor the device. Aortic root dilatation, this means I need a device large enough to seal the valve and to make sure there is no risk of embolization or late migration. The increased also stroke volume. The stroke volume during clinical examination, if you remember from the medical school, the Corrigan sign, the femoral, pulsation, the it is the same effect exerted on the valve or the aorta while deploying. Large amount of blood coming out, it will increase the risk of embolization, and it prevents you from doing the best stabilization during deployment. Number 4 is not written here, is when you overexpand the leaflet, which is not calcified by a device, there is a very important risk of coronary obstruction. Increase the risk of embolization or malapposition of the prosthesis with subsequent moderate to severe post-procedure acute regurg, aortic regurg. So either embolization or late migration, or there is no incomplete sealing and there is aortic regurgitation. Aortic regurgitation, as we know, paravalvular leak, post-TAVI, and aortic valve stenosis, even if mild, is bad. In case of aortic regurg, imagine it is much, much bad, and most of the data we have, it showed that even mild is aortic regurg, the paravalvular leak, post-aortic regurg, carries the worst outcome comparing to any other factor. Valve migration, which can occur later on, it can be toward the aorta on the LV. As you can see, it's not an easy things to do, and we have to find a way to implant the valve safely and without migration, without embolization, without paravalvular leak. It is a tough area to explore. Okay, I need to anchor the valve, so I have to go oversize to prevent the embolization and migration. Published data saying you go 15 to 20% oversize when you select the transcatheter heart, the valve. Don't go beyond 20 because the risk of rupture. And if you look at the series, you will find that in about 15 to 20% of the patient, you have to go beyond that 20% of overexpansion. This is the data for different devices in aortic regurg from 2013 until now. This is, all devices like core valve have been used, Sapien XT have been used, and too many paper using core valve, which is a self-expandable, and also some of the valve not anymore present, like the Lotus and Lotus valve, and some like Sapien XT. So most of the data come from small number of patients, and the success rate, it ranges between 60 to 90%, comparing to the experience of the center, the device used, the old generation of the valves, the new generation of the valve. So data is inconsistent and truly is not encouraging data, and that's led to people to start to think to create a device that can be implanted safely without risk of complication with good outcome. So this is again, all the study, mentioning the different devices, and you can see here a couple of names of valve like Gina valve, and then direct flow valve, and there is the J valve. These three valves, they call it the new generation valve for aortic regurg, and all the previous one is an old generation. So they compare. Let me show you first the J valve. This is a self-expandable valve that cannot be recaptured. It's made for aortic regurg, pure aortic regurg device. You see this hooks, this C-shaped hooks, this one, and then this another one here. So this made like a clip. When you open it, you open the device, this first thing to go out. So it anchor itself in the leaflet. And then when you release the actual valve, it will push the leaflet against U-shaped clips زي المشبك. And then theoretically you said, oh, that's nice. Anchor, it will not embolize, no paravalvular leak, but the data, again, is not that encouraging. And at the beginning, when they use the J valve, they go transapical. Now they are going transfemoral. They are keep doing some changes, but this is one of the hope actually for patient cannot go for surgery. It comes with 5 different sizes, and it can go to up 900 area millimeter. So this is the largest valve can be used for the largest aortic root. This is the GINA valve is a self-expandable valve. It comes in 3 sizes, 23, 25, and 27. So you cannot use it in very large aortic root. And again, the same concept. You see this like diamond, 1, 2, and there is one at the back, 3. So when you open it, each one, it go to the sinus, the aortic sinus, non-coronary sinus, left coronary sinus, right coronary sinus. So it anchors itself. Then when you release the valve will be push the leaflet against this anchors or what we call locators, and it prevent the embolization. Here, each one is already in different sinus, and now after release, this is how it look like. So this is good, probably because of the scared. The risk of paravalvular leak is low, but again, the data show there is a risk of embolization and paravalvular leak. And this is the last slides for me. I want just to show you, this is the early generation device, the one in Verbal, including Lotus, including Edward XT, core valve. And this is the green one here, is the new devices like the GINA valve and J valve and the, can I have? Yeah, so you can see here the paravalvular leak, this is moderate to severe, not mild. It's about 17% with the old devices, now it's 7%. It's still high, but it's better than before. And 30-day mortality is 3.5. That's also high with the new devices. Major vascular complication. This one, valve in transcatheter heart valve. In transcatheter heart valve, this is the embolized. Imagine there was a risk of 20% of embolization of the valve that you need to put another valve. With the early experience. Now it came down to 5. Annular rupture, higher than what we do with aortic valve stenosis. Bottom line, the area of aortic valve regurgitation and TAVI is very challenging. No calcium, large anatomy. Still, we don't have the proper device that give us the best result. With less embolization, with better mortality outcome. I think it is the area of that need a lot of development, and at least there is 2 valves now under investigation, one from Belgium and one from Italy, talking about devices with large size and better anchoring. Thank you very much.
Thank you for this nice wrap-up for aortic regurgitation. So it's time to move to the last presentation of this session. I would like to ask gently the speaker to stick to the time allowed to enable some discussion at the end of the session. So for the last talk, I'm pleased to call Dr. Alasnag. Sorry if I spell it not well, and she will talk us about TAVR and small annuli, tip and tricks.
Well, good afternoon, and thank you for staying to the last talk of the day. I'll try to keep it brief, but hopefully cover the topic of that's actually very relevant to our part of the world, small annuli, because our patients are petite, and I think industry has been responsive by providing devices that are smaller and smaller. But is it really what we need to be doing? So let's just dissect this together. And let's just go on a journey and see what happens to small annuli from surgery to TAVR to valve-in-valve, because all of these are the same patients that go back and forth, right? So when we look at the data of small annuli, they also have higher rate of perioperative complications when we're looking at the surgical data. And they also have a higher chance of having prosthesis patient mismatch. And so you end up having some residual LV afterload in these patients when we eventually see them. But when we do look at the all-cause mortality in these patients, and we look at the Partner 1 trial that really looked at, of course, balloon expandable devices in patients who had small annuli, they had similar rates of moderate to severe mismatch, but TAVR was associated with a lower rate compared with SAVR, and this was restricted to patients with the small annuli. So when you look over here, I'm just trying to find my... So when you look at the smaller annuli compared with medium and larger, it was actually the ones with the smaller annuli where there was a significant difference between the surgical and the aortic and the transcatheter implanted valves. And so really when we look at the whole issue here, when you look at small annuli, oops, let me go back. Yeah, so when you look at over here, you look at the annuli, the issue with the small annulus with SAVR is patient prosthesis mismatch, and PVL really is a non-issue. But when you look at TAVR, the prosthesis mismatch is consistent throughout, but it's really the PVL that's an issue that comes with larger annuli compared with the small ones. And we need to take that into consideration when we're looking at our patients. And so when we're looking at the surgical data and we look at PPM, and you see that severe compared with moderate, you see there's a 1.8-fold increase in the risk of mortality compared with 1.2-fold increase in mortality in those who have moderate PPM. And when you look at what does that do? So when you do have patient prosthesis mismatch, what does that translate into in terms of the valve itself and in terms of degeneration of that valve? Well, this is a trial that was published in Circulation over a decade ago that looked at 600 surgically implanted valve with a follow-up of 6 years, and they saw that PPM was actually an independent risk factor for structural valve degeneration in these patients. And so let's move on to a different category of patients, and these are the valve-in-valve. So when you look at valve-in-valve patients, about 10.5% of them have some kind of patient prosthesis mismatch. And what you do see over here is that those with small annuli are more likely than the large and, of course, the medium to have patient mismatch with an increase in the gradient. But they also have a quality of life that is impacted compared with the other valves that are slightly larger. And when you look at the VIVID registry that looked at valve-in-valve, and they looked at outcomes in these patients, and they compared the different types of valves. So they actually looked at balloon expandable, and they looked at self-expanding valves, meaning core valve and the evolute. Once again, what you do see is that those with PPM actually had higher rates of valve degeneration and higher gradients. And see, again, over here, this pretty much says the same thing that I showed in the previous one, that patients who do have PPM, the worse it is, the worse the valve degeneration is in these patients. So what is the solution when you do have these patients? Well, the solution really lies in several parts. One, we need to consider better surgical prostheses, right? Because we don't want them to have a surgical valve, have valve degeneration, and then they come, and we need to consider TAVR in a already small surgically implanted valve. So the surgical valves and the surgical options are newer generation supraannular bioprostheses that are implanted, stentless bioprostheses, sutureless bioprostheses. These are all options. Unfortunately, a lot of them are new, and we don't have very long-term data on these. The other one is aortic root enlargement, which we should still be pressing our surgical colleagues to be doing. And finally, our last option really is transcatheter aortic valve, and I think that is the kind of algorithm that we need to be thinking of. So when we do look at mortality in patients with prosthesis mismatch and small annuli, there is a higher rate of cardiovascular mortality in surgically implanted valves with prosthesis mismatch. Now, when you do look at it in TAVR, it does not actually affect cardiovascular mortality, and this is data that has already been published, and we need to bear that in mind from Partner and Ocean trial. Again, when you look at all these trials, Partner, the core valve, et cetera, and when you do want to look at these patients who have significant ppm, and you look at the outcomes in them in terms of mortality, they certainly have a higher mortality hazard compared with those who do not have it. And here Rebecca Hahn has some Echo Core Lab data that she published that helps us kind of look through it, and we can see that valves that are actually not balloon expandable but rather self-expanding tended to have lower gradients, had lower effective orifice area, better effective orifice area, and then the dimensionless index was actually better in these patients as well compared with the balloon expandable. And again, so when you look at transthoracic echo hemodynamics and you look at structural valve deterioration, they do kind of go hand in hand. Nevertheless, we don't know if that translates into mortality events. So far, the data suggests it does not. And this, again, just re-emphasizes what I just said. But there are studies in the TAVR space that are actually looking specifically at small annuli, and this is one of them, the France TAVR. They looked at a whole bunch of patients, and after all the exclusion, they ended up enrolling about 1,100 patients into BEV versus self-expanding valves, and they look at them matched, and before matching and after matching, and certainly after matching, you can see that in terms of age, gender, etc., EF, and so on, they were very well matched cohorts. And when you compare them, you definitely see a better hemodynamics in the population that is matched and not matched, actually. But you do see that they tend to do better with self-expanding valves compared to balloon expandable valves at 1 year. So the supraannular valves at 1 year had better hemodynamics. They had balloon expandable was an independent predictor of 1 year ppm, and the ppm in itself was a predictor of all-cause mortality at 3 years. And we're still waiting for data, because that was more like registry data, but we're looking for randomized data from the SMART trial. And the SMART trial is still enrolling, and effectively they're looking at women as well in that particular trial with Roxana Mehran and colleagues. And it's a one-to-one stratification where they're looking at both a self-expanding valve and a balloon expandable valve. They're going to look at 30 days and then annually for 5 years to look at important outcomes such as hard endpoints like death, stroke, rehospitalization, but as well as valve dysfunction. I'm going to skip this for the sake of time, but essentially there's no real data that we know, and a lot of the data is very conflicting about BMI and how it affects our decision about small annulus. There's some data that effectively says yes, it does, and some data that is very confounded. So we really don't know where it is, but I would take into consideration BMI when I'm looking at patients' annulus. But what does it mean in very specific populations? And this is data that was published from the Japanese TAVR experience. They are petite patients. What they did find is that small annulus was associated with less hemodynamic improvement and smaller effective orifice area, increased ppm in patients at 30 days. But there was no obvious impact on outcomes at 30 days. And supraannular devices probably contribute to better hemodynamics. So again, the Japanese data is suggesting that there's no real impact on 30-day outcomes, hard endpoints, compared with surgical data. And in the Gulf, we did publish our data because, as I said, our patients are younger. What we did see is a composite of 12.8% of death and rehospitalizations in our patients, and this is looking at all of them, men and women, and looking at small annuli and not small annuli. We found that the predictors of poor outcomes were actually things like chronic kidney disease, low ejection fraction, but actually not the small size of the annulus. So that was interesting. Again, moderate to severe perivalvular leak was also a predictor, although it didn't reach statistical significance. But when we looked at women specifically in this registry, what we do see here is that you see the composite was actually higher in men compared than women. And yet, when you do look at cardiovascular hospitalizations, they were higher in women compared with men. Knowing that the smaller sizes, both balloon expandable and self-expanding, were more commonly implanted in women, and yet overall, their outcomes were actually better than the men. 71% of those received a size 20 transcatheter heart valve, and which is obviously the balloon expandable, and then 23, which was a balloon expandable, and the 20, which was the Medtronic. But there was really no difference between the type or size of valve that was selected and the rate of complications between men and women in our population. I'm going to end it there, but I think, if anything, we still are in the area of where we need to learn more about TAVR and small annuli, particularly in very specific populations and smaller patients. Thank you.
Thank you very much for this nice presentation. The three last talks are now open to discussion. Any question from the audience, please?
I have a question for Dr. Ashkari concerning AI and TAVR. When you're using one of the currently available technology platforms out there, do you prefer a balloon expandable system or a self-expanding system for treating pure AI?
So we haven't done too many, but from the 4 cases we have done, I like the self-expandable for one reason, because if I gonna over-expand by using a self-expandable, I don't feel afraid. If I gonna put 32, for example, 34 evolute device in anatomy, take 29 or 26, I don't really feel afraid from annular rupture. But using balloon and you want to oversize, the successful stories you see in Twitter or in presentation, actually from the data I just present, is not true. The balloon expandable is the least used between all the studies and everything before. The bottom line, I will use the self-expandable. The balloon expandable, the only device that can go more than 30 is Mayval, and is not available in, I think, in a lot of country. It's a great valve, but again, it is a balloon expandable. You have to do your calculation really very careful. Not only the annulus, what is the size of the LVOT, you don't want to, because most of the rupture is at that area. So if you want to start a program, use a balloon, a self-expandable, and call for a true expert, which is, there are few of them, to help you with the case.
Excellent presentation, Dr. Kashkari. I think the TAVI in AI, will see it more. From us as a cardiac surgeon, we implanted the commonest 2 valve that we think it is a very, very high risk to reoperate on them. The stentless valve, and the other one is the Perceval valve. Both those valves, if you keep an eye on them, in the future, the best solution for them is TAVI, valve and valve, and you still have the support to implant your valves. Keep an eye on that.
Any other question from the audience?
Yes, thank you very much indeed. Just a quick comment and a question. The comment is that there's some recent data published in JACC, which was surprising to me, that shows PPM post-surgical SAVR doesn't seem to have a significant impact on long-term survival. I was surprised to see it, but it is there. The question I have is that a few years ago, we wrote a paper to circulation recommending that we should be leaning towards implanting more tissue valve, thinking that within the next 10 to 20 years, there will be ability to insert valve in valve. But surprisingly, until today, the guidelines still recommend that mechanical valve should be considered in patients below the age of 65, I think. How do you feel about that as TAVI experts?
Well, I agree with the guidelines, because you really need to think of lifetime management when we're implanting valves, whether it's surgical or not. And I think explanting a TAVR valve, so the lifetime of a bioprosthetic valve is much shorter. The durability of them are much shorter. So when you have a younger patient, when you're thinking of lifetime management and they're younger than 65, chances are, after that implant, they're going to need to come at least 2 other times. What are you going to do the 2 other times? So if you're going to implant a bioprosthetic valve, and you need to take that into consideration. Not all centers are able to do explants. And then valve in valve, you still have your limitation of what your initial gradient is. Not all surgical valves are fracturable and so on. So I think younger than 65, I would still consider these mechanical valves, barring that they have a problem with anticoagulation or not.
Dr. Batir, your question, please.
Thank you. My question is for Merv. Thank you for this very interesting presentation. But I'm asking about supraannulus insertion of the valve, whether it was done in surgery or maybe in TAVI position. Is it a problem when we can do to TAVI in TAVI if we have a degeneration of the valve? Is it possible or not?
So I'm glad you mentioned it. It is part of the lifetime management that we're talking about. So part of the lifetime management is not just the valve itself, but you need to take risks, take into consideration coronary access. So the higher you keep implanting, you are limiting your options in terms of coronary access, the types of valves that you're using. Yeah, some of the self-expanding valves are more difficult for your average operator to engage the coronary arteries. So if you're able to implant them, you're a TAVI expert, that does not mean that everybody in the community is. And so these are questions that we need to be addressing. Coronary access, pacemaker implantation, paravalvular leaks, in addition to patient prosthesis mismatch and gradients that don't completely unload the LV. So all of these need to be taken into consideration at the first implant, really.
Thank you very much. I have a question just crossed my mind now, and I would like to hear from the audience, especially the TAVI expert. Regarding the small annulus, usually as a surgeon, sometimes we're inserting the small valve based on the body surface area of the patient, or sometimes you couldn't. Do you have any kind of heart team discussing with the surgeon before they're inserting the valve? They do aortic root enlargement for a tissue valve, so after time you can do TAVR and SAVR, or you don't have this kind of communication or heart team for this kind of patients? Thank you.
I will take the question. I'm the surgical director of the structural program in Montreal Heart Institute. And actually, we are pushing the surgical community to do more and more root enlargement, because we saw in low-risk trial when surgeons perform at 7% or 8% of root enlargement, we saw already at 1 year we have better performance for surgical valve compared to the SAPIEN 3. So that's why I think in the surgical community, and I'm pushing all my colleagues and the Canadian surgeons to go toward more aggressive approach and enlarging roots instead to try to go to minimally invasive approach, because the deal here is to treat well the patient. We can never beat the TAVR in terms of mini invasiveness, but we have to do the job very well to prepare the landscape and the field for the next TAVR and maybe a TAV in TAV for the future, so we can do the lifetime management for the patient. I have a question for the last speaker. I would like to thank you to cite our work presented last year during TCT. Actually, I have a question. I'm one of the top enroller in SMART trial that you cited. And I agree with you that our feeling is to put self-expandable valve in this anatomy. But even if we have more higher gradient, we have more halt and balloon expandable, we haven't seen a great difference in clinics. Do you think that we should do echo stress to these patients to show the impact of self-expandable valve in these patients?
Congratulations, firstly, on that trial. I think we're all eagerly waiting for to hear more about it. But I don't think stressing patients. I know there's this, Philippe is also working on one where they're looking at early intervention in patients, and so trying to prompt symptoms by putting them on a treadmill and something like that. But I think we should probably be looking at other data. So looking at, for example, MRIs of the LVs and looking for fibrosis, early evidence of fibrosis and early evidence of dysfunction. So when we're waiting for LV dysfunction, that's probably the last part of it. And I agree with you, the hemodynamics of the valve is not the end of the story. It's maybe the beginning of the story. There's so many factors to take into consideration, but you know, we don't know a whole lot about, for example, leaflet mobility and thrombosis. Is it higher in patients with small annuli? Is it higher in patients with prosthesis mismatch? And so on. And I think that's the data that we're hoping will eventually come, and then we'll be able to dissect a little bit more to gain an understanding. Right now, hemodynamics does not necessarily translate into higher mortalities or higher clinical events. So yes, thank you for bringing that up.
Thank you. The last
Yes,
question.
Last question. I have a question
short,
for...
short
yes.
response, please.
Yes, short. For Professor Hajlevi, thank you for this challenging cases. For this patient with mechanic mitral valve, in CT scan, which criteria to assess for accurate the implantation? Which criteria from CT scan?
In this situation, I think that we have an annulus of 24, so we can go for an accurate, but in this specific case, we want to implant a valve which is retrievable. With the Navitor that we implanted, we can do echocardiography and we can check the valve and the interaction with the mitral valve before complete release. Thing that we cannot do with the accurate. You know, the accurate, the last, in the end, you have to release the stent, to open the stent. So if there is a bad interaction at that time, it will not be a good thing. So that's why we decided to not go for an accurate.
Thank you very much. It was an exciting, very interesting session. Thank you for all the speakers and audience. And we have to keep place for Professor Mohammed Ghanem and his presentation.
On vous invite à rester dans la salle. Il faut appuyer dessus. Bon. On vous invite à rester dans la
Bon,
salle.
Sami, tu vas m'accompagner.
Voilà. Bon, on garde le meilleur pour la fin.
Bon, ça va être un cours particulier en fait. Vous êtes que 3, c'est très bien, vous êtes les meilleurs, vous êtes les plus courageux, moi aussi. Et c'est moi qui ai choisi cet horaire parce que j'étais à Marseille, à Pau et à Bordeaux. Et donc,
En tout cas, c'est toujours un plaisir et un honneur d'avoir parmi nous si Mohamed Ranem, qui nous a accompagnés pendant, on va dire, pour te rajeunir, 30 ans.
40.
30, je veux dire. Donc, dans la réadaptation cardiaque, mais bien avant dans d'autres sujets. En tout cas, on a l'immense plaisir et l'honneur de vous laisser la place pour, bien sûr, nous mettre à la page concernant la réadaptation dans l'insuffisance cardiaque. À vous aussi, Mohamed.
Merci, Sami. Donc, je pense que l'adaptation cardiaque et l'adaptation générale, la prévention, c'est l'enfant pauvre de la médecine. Et d'ailleurs, la salle le prouve très bien. Vous savez tous que l'insuffisance cardiaque commence par un dysfonctionnement ventriculaire gauche. Et tout de suite, il y a une panoplie de remise en question avec un arsenal neuro-hormonal pour corriger cette insuffisance cardiaque. Et malheureusement, très vite, ils deviennent donc nocifs. Et vous voyez, vous avez des anomalies hormonales, mais vous avez des troubles ventilatoires, vous avez une myopathie, fente musculaire, vous avez des anomalies vasculaires. Et quand le patient va vous voir, voilà ce que vous traitez. Ben, vous traitez que les anomalies neuro-hormonales. Qu'est-ce que vous faites sur le trouble ventilatoire? Rien. Qu'est-ce que vous faites sur la myopathie? Rien. Qu'est-ce que vous faites sur les anomalies vasculaires? Rien. Et vous pouvez me croire, quand vous faites de la réadaptation cardiaque, vous corrigez tout ça. Et si vous ne me croyez pas, je vous donne de la lecture dans des revues hautement connues scientifiquement parlant qui parlent de ce que vient de vous dire. Ça veut dire que la réadaptation cardiaque corrige toutes les anomalies de l'insuffisance cardiaque. Vous avez entendu parler de cette étude des glofosines qui corrige, etc., l'insuffisance cardiaque avec un très bon pronostic. Et en fait, cette glifosine n'agit absolument pas. Elle fait qu'une glucosérie avec une amélioration de l'insuffisance cardiaque, mais sur tout ce que je viens de vous dire, elle ne fait rien. Mais le patient, quand il vient vous voir, il vous dira jamais que j'ai des anomalies neuro-hormonales. Il va vous dire, voilà, moi, je suis fatigué. Et à chaque fois que je marche, je suis essoufflé. Et quand je suis essoufflé, je m'arrête, etc. Et c'est un cercle vicieux. Plus il est essoufflé, moins il fait d'efforts. Moins il fait d'efforts, il est donc fatigué. Alors, si je vous pose la question, c'est quoi la VO2? Vous allez me répondre tous, c'est la capacité physique du patient. Et si je vous dis pourquoi, vous me direz que tous les substrats qui donnent de l'énergie ont besoin d'oxygène. Et donc la consommation d'oxygène est reflux direct des substrats qu'on utilise pour fabriquer de l'énergie, et donc ça reflète la capacité du patient, et c'est pour ça qu'on fait la VO2. Alors quand on regarde la VO2, qui est la capacité du patient à faire un effort, et vous avez un pont hémodynamique, début cardiaque, etc., vous avez un pont métabolique, la différence artério-veineuse. Et nous tous, on s'occupe énormément de tout ce qui est hémodynamique avec fraction d'éjection, mais on ne s'occupe pas du tout de la différence artério-veineuse qui est donnée par la VO2. Nous savons tous que la fraction d'éjection a un facteur pronostic très important, c'est connu. La VO2 aussi. C'est un facteur pronostic très important. Vous voyez, quand la VO2 est inférieure à 10 ml kg/minute, eh bien, en un an, il y a 50% des insuffisances cardiaques qu'on va perdre, ils vont donc mourir. Et quand on fait la courbe VO2 en fonction de la fraction d'éjection, il n'a aucun rapport. Et on a vu parce qu'on explore deux choses différentes. D'un côté, vous êtes hémodynamique, de l'autre côté, vous êtes métabolique. Alors maintenant, quand vous faites un effort, eh bien, vous allez vous adapter à l'effort. Alors vous avez une adaptation hémodynamique que vous voyez d'un côté. Alors cette adaptation hémodynamique, c'est le volume d'éjection systolique qui va augmenter et la fraction d'éjection la fraction cardiaque qui va augmenter. Mais votre insuffisant cardiaque, il ne va pas les utiliser, puisque d'abord, le volume d'éjection au bout de 40% de l'effort maximum, il va stagner. Et en plus, l'insuffisance cardiaque ne peut pas augmenter son volume d'éjection systolique. Donc ce qu'il fait, c'est qu'il va se rabattre sur le problème métabolique. Ça veut dire qu'il va augmenter sa différence artério-veineuse. Et plus il est adapté, plus il est réadapté, plus il peut faire un effort, plus cette différence artério-veineuse augmente. Alors, comment prescrire au mieux cette réadaptation cardiaque? Le mieux, c'est faire une VO2. Pourquoi faire une VO2? Pour obtenir ce fameux AT, c'est en fait le seuil anaérobie, le premier seuil, parce que le deuxième seuil, vous le voyez que chez le sportif. Il y a le premier seuil, et c'est le premier seuil qui va nous servir pour adapter le patient, soit en continu, soit en fractionné. Je ne vais pas revenir sur ça parce que c'est un peu trop long et vous êtes très fatigué, il faut que je finisse rapidement. À côté de cet entraînement en endurance, en fractionné ou en continu, vous avez la musculation puisque l'insuffisance cardiaque crée une myopathie et une fente musculaire. Alors, des fois, vous avez des patients qui ne peuvent même pas faire un effort, ils ne peuvent même pas faire de la musculation et dans ces conditions, on utilise l'enfoncement musculaire passif. Ça veut dire qu'en fait, on va utiliser des appareils qui vont entraîner des signaux électriques et ces signaux électriques vont tout d'abord faire fonctionner les muscles petit à petit et après on arrive à le faire une musculation active et après on va le mettre sur un vélo. Alors, cette électromyostimulation, je crois que les sportifs l'utilisent. Il y a des femmes qui l'utilisent aussi pour maigrir, donc c'est des influx électriques. Il est parfaitement démontré que cette électromyostimulation va augmenter la capacité d'effort du patient et elle va augmenter aussi sa qualité de vie. Sauf que si le patient peut bouger, l'électrostimulation ne sert à rien. Elle sert que si le patient ne peut pas bouger de façon active. Alors, pour l'insuffisance cardiaque, des fois, vous avez des insuffisants cardiaques qui sont extrêmement fatigués. Et le mieux, c'est de commencer par une puissance très faible. Vous augmentez la durée. Par exemple, vous faites 10 minutes, 15 minutes, 20 minutes, avec une petite puissance. Et vous augmentez peu à peu la puissance, mais vous ne commencez pas par une grande puissance parce qu'il va être vite fatigué. Vous commencez par une petite puissance, ça veut dire qu'il y a une fréquence cardiaque qui est aux alentours de 50% de ce seuil anaérobie. Vous augmentez la durée, 20 minutes, 30 minutes, etc., etc., puis augmentez la puissance après. Alors, est-ce que la réadaptation cardiaque sert à quelque chose chez l'insuffisance cardiaque? La réponse est oui. Et cette étude, qui est une étude randomisée, des patients qui étaient réadaptés et des patients qui ne sont pas réadaptés, ils sont aux alentours de 2000 en tout. Ils sont tous avec un traitement optimal d'insuffisance cardiaque. Et alors, cette étude est positive. Si on ajuste tout, vous allez voir sur cette courbe qu'on baisse la mortalité et on baisse le nombre d'hospitalisations également. Et elle serait encore plus positive si jamais il n'y a pas un biais, parce qu'en fait, les patients qui ne sont pas réadaptés, on leur dit quand même de faire un effort et on leur téléphone pour leur dire qu'il faut faire des efforts. Donc il y a des patients qui sont témoins mais qui font des efforts. Et inversement, il y a des gens qui doivent faire de l'adaptation, qui doivent faire des efforts, et bien ils ne le font pas. Il n'y a que 30% qui font les efforts de 120 minutes par semaine. Il n'y a que 30% des gens qui le font alors qu'ils devraient être à 100%. Alors, voici une méta-analyse qui vous montre que l'adaptation cardiaque baisse la mortalité, baisse les hospitalisations globalement et baisse la hospitalisation pour insuffisance cardiaque. Je reviendrai sur la mortalité tout à l'heure. Voici une cohorte de 40 000 patients, quand même, une cohorte américaine en fait, c'est une étude internationale. 20 000 patients ont fait adaptation et 20 000 patients n'en ont pas fait. Et vous voyez, la mortalité de toute cause baisse, les hospitalisations baissent, les incidences d'AVC baissent et l'incidence d'arythmie complexe fibrillation baisse. Et dans la vraie vie, voici un registre qui est quand même de 140 000 patients, dont 29% ont fait de l'adaptation. Et vous voyez que la mortalité baisse de 43% chez ces patients. Alors, quand on regarde maintenant, pourquoi la mortalité? Pourquoi la mortalité, quand elle baisse, tout baisse de façon significative, sauf la mortalité? Et pourtant, quand on regarde bien, les facteurs pronostiques de l'insuffisance cardiaque sont quoi? La pro-BNP, la fraction d'éjection, NIA, VO2, VO sur VCO2, voici, en gros, ceux qui motivent le pronostic de l'insuffisance cardiaque. Alors, quand on regarde les hospitalisations, par exemple, regardez, on a vu tout à l'heure que la réadaptation baisse la hospitalisation. Et vous voyez cette étude qui vous montre, plus les patients sont hospitalisés, plus le pronostic est très mauvais. Donc, en théorie, si on baisse la hospitalisation, on baisse donc la mortalité. Et cette étude-là qui vous montre que la NT pro UMP, en fait c'est une métalyse, qui baisse de façon significative par l'adaptation, et l'étude qui est au-dessous vous montre que les sous-groupes qui sont en endurance baissent beaucoup plus la NT pro UMP que les patients qui sont en résistance. Alors, pour la VO2, vous voyez que la réadaptation cardiaque augmente la VO2 chez tous les patients de façon non exclusive, et elle baisse aussi, elle augmente la VO2 et elle baisse la VE sur VCO2. Et vous savez que la VE sur VCO2 est un facteur pronostique indépendant de tous les autres paramètres. Normalement, si la réadaptation augmente la VO2 et baisse la VE sur VCO2, normalement, elle devrait baisser la mortalité puisque c'est un facteur pronostique. Voici une autre étude qu'on a faite récemment et vous voyez que la réadaptation cardiaque augmente le volume d'éjection systolique et le débit cardiaque, surtout à l'effort. Alors, on est allé plus loin. Voici une biopsie du muscle cardiaque avant réadaptation et après réadaptation. Vous avez l'architecture a totalement changé après réadaptation, ce qui est à droite. Et en plus, vous avez plus de fabrication d'ATP. Là, en bas, c'est une étude que nous, on a faite avec l'Université de Compiègne. Et on a montré que quand on fait un effort, on utilise moins d'énergie après réadaptation qu'avant réadaptation. Et en plus, la dégradation de l'ATP est beaucoup plus lente. Ça veut dire qu'en fait, on utilise mieux après réadaptation notre énergie qu'avant la réadaptation. Alors, évidemment, il y a quand même quelques facteurs limitatifs. La réadaptation cardiaque n'est efficace que quand elle augmente la VO2 de plus de 6%. Quand elle n'augmente pas la VO2 de plus de 6%, c'est un facteur pronostique majeur et malheureusement, le pronostic est mauvais quand le patient ne bénéficie pas de la réadaptation cardiaque. Vous voyez sur cette étude, quand les patients ont une VO2 basse, ils restent après réadaptation basse, ils ont un très mauvais pronostic. Et bien, quand ils augmentent leur VO2 après, les mêmes, quand ils augmentent leur VO2, et bien, le pronostic est beaucoup mieux. Voici une autre étude qui vous montre exactement la même chose, avec ce cut-off qui est le 6%. Quand les patients augmentent leur VO2 de 6%, ils ont un bon pronostic. Quand ils augmentent de moins de 6%, ils ont un mauvais pronostic. Et là, c'est une étude qui a été faite par la Société de cardio française qui vous montre que si les patients n'augmentent pas leur VO2 de plus de 6% après réadaptation, ils ont un très mauvais pronostic. Alors maintenant, cette étude qui a fait beaucoup de bruit pour l'insuffisance cardiaque à fraction d'éjection préservée, comme si vraiment on a découvert quelque chose d'extraordinaire. Alors que si on en revient en arrière, vous voyez que l'adaptation cardiaque dans l'insuffisance cardiaque à fraction préservée, elle améliore la capacité d'effort, elle augmente la fraction diastolique du ventricule gauche, elle améliore la qualité de vie. Donc depuis très longtemps, on sait que l'adaptation cardiaque est efficace pour l'insuffisance cardiaque à fraction d'éjection conservée. Mais on ignore parce que ça ne rapporte rien, évidemment. Tu ne vas pas vendre le vélo, tu le vends une fois, mais pas deux fois. Alors qu'avec le traitement, tu vas faire beaucoup de bénéfices. Voici une autre étude qui vient de sortir d'ailleurs en 2021 et on savait que la réadaptation cardiaque est efficace dans l'insuffisance cardiaque à fraction d'éjection basse. Et on se pose la question sur l'insuffisance cardiaque à fraction d'éjection préservée. Alors, on a une étude qui te montre ça donne exactement la même chose, même mieux que dans l'insuffisance cardiaque à fraction basse. Donc, ça fait très longtemps qu'on sait que la réadaptation cardiaque est efficace dans l'insuffisance cardiaque à fraction préservée. Alors, on s'est posé la question toujours, que ce soit pour l'insuffisance cardiaque à fraction conservée ou préservée, par quelle méthode il faut les réadapter. Alors, est-ce qu'il faut les réadapter en fractionné? Est-ce qu'il faut les réadapter en continu? Eh bien, la réponse est là. En fait, faites ce que vous voulez. L'essentiel, c'est que le patient bouge. que ce soit fractionné, que ce soit en endurance, c'est exactement la même chose. Il faut absolument que le patient, ça donne exactement le même résultat. L'essentiel, c'est de faire des efforts. Alors, on a quand même remarqué que malgré les efforts qu'on fait, quels que soient les efforts qu'on fait, eh bien, le pronostic de l'insuffisance cardiaque s'améliore. Et vous voyez là, avec le trait que je vous montre, à VO2 égale, le patient mourrait, disons, moins, plus que maintenant. À VE sur VCO2, qui est la même, eh bien, le patient mourrait, disons, avant, plus que maintenant. Et pourquoi? En fait, parce qu'il y a deux choses qui ont joué. La première chose, c'est l'optimisation des médicaments. Et vous n'avez pas mieux que les services d'adaptation pour optimiser les médicaments. Et la deuxième chose, c'est le traitement non médicamenteux. Je vais y revenir. Alors, l'optimisation des médicaments, vous voyez là, pour l'Entresto, alors quand vous réadaptez un patient, plus le patient a une dose élevée d'Entresto, plus sa VO2 augmente, plus sa VE sur VCO2 baisse. Ça veut dire qu'en fait, plus vous adaptez, optimisez votre traitement, plus votre réadaptation est efficace. Donc, il y a une synergie entre l'optimisation du médicament et la réadaptation. Pour les bêta-bloquants, c'est exactement pareil. Pour les bêta-bloquants, les patients qui sont sous bêta-bloquants bénéficient beaucoup plus de la réadaptation que les patients qui n'en ont pas. Et c'est une erreur monumentale d'arrêter les bêta-bloquants chez un patient, même quand il a fait une poussée d'insuffisance cardiaque. Et vous voyez en bas que pour une même VO2, les patients qui sont sous bêta-bloquants vivront beaucoup plus que les patients qui ne sont pas sous bêta-bloquants, alors qu'ils ont exactement la même VO2. Alors le traitement non médicamenteux, on se pose la question toujours, si la réadaptation apporte quelque chose ces patients qui sont resynchronisés. Ben, la réponse est oui, et regardez très bien, les patients qui sont en insuffisance cardiaque contrôle, qui n'ont pas fait adaptation cardiaque, ils baissent leur VO2. Quand ils sont réadaptés, ils augmentent de 2,1 ml/kg. Quand ils sont sous CRT, ils augmentent de 1,9. Et quand ils ont les deux, ils augmentent de 5,5 ml/kg. Et vous voyez très bien que si je compte bien, 2,1 plus 1,9, ça veut dire réadaptation et CRT. Vous voyez, c'est à 4, alors que si je les mets les deux, j'ai 5. Ça veut dire que c'est plus que synergie, les deux. Alors, pour les assistants circulatoires, moi j'ai l'expérience de Thoratec. Vous savez, le Thoratec, c'est une valve qu'on met à la pointe du cœur. Elle aspire le sang et elle le réinjecte dans l'aorte ascendante. Alors le gros problème pour nous, c'est que ces patients n'ont pas de tension, puisque le flux est continu. Donc il faut se baser quand même uniquement sur l'aspect du patient, puisqu'il n'a pas une circulation pulsatile et donc on n'a pas de pouls, on n'a pas de tension en fait. Et ce patient-là qui est grabataire, vous voyez, il est venu chez nous, il ne marchait pas. Il est allongé tout le temps. Et regardez, à la fin de son séjour, il fait du vélo. Et vous voyez, à côté c'est les batteries qui, initialement, je crois qu'on avait une autonomie de 8 heures et maintenant, on a une autonomie de quelques jours, donc les patients peuvent... Alors, initialement, c'était pour attendre. Ça, c'est circulatoire, pour attendre la greffe cardiaque, on attend. Et finalement, on a des gens ça fait 10 ans qu'ils sont en attente. Donc, on s'est dit, c'est quand même un traitement, puisque ça fait 10 ans qu'ils sont en attente, ils n'ont pas été greffés. Alors, pour maintenant la greffe cardiaque, c'est la meilleure façon de montrer que la réadaptation est efficace. Quand vous avez un greffé cardiaque, s'il n'est pas réadapté, il ne s'améliore pas. Et pourtant, vous avez changé le cœur. Pourquoi? Parce que son système circulatoire, il est le même. Il n'a pas changé. Le cœur ne fonctionne pas tout seul. C'est une centrale, mais il faut après des tuyaux. Si les tuyaux ne sont pas adaptés, eh bien, le patient ne s'améliore pas. Alors, quand vous réadaptez un patient qui a une greffe cardiaque, sachez une chose, c'est que le cœur est dénervé. Comme il est dénervé, eh bien, il n'augmente pas tout de suite sa fréquence cardiaque, il attend que les catécholamines augmentent pour augmenter sa fréquence cardiaque, donc la fréquence cardiaque augmente bien après, et comme quand il s'arrête, il n'a pas de frein vagal, eh bien, la fréquence cardiaque ne baisse pas tout de suite, elle baisse quelques minutes, voire plus après. Voici une étude qui vous montre que la réadaptation cardiaque est efficace dans la greffe cardiaque. Vous voyez qu'elle augmente tous les paramètres. Alors voici, si vous ne me croyez pas, voici un article qui vient de sortir. Il est sorti en 2021. Et vous voyez que la réadaptation cardiaque agit sur le cœur, sur le système neurovégétatif, sur le rein, sur l'inflammation, sur le pancréas avec l'insuline, sur les muscles, sur les vaisseaux et sur les poumons. Et vous pouvez voir cet article. Alors, si vous connaissez un seul médicament qui fait tout ça, j'achète tout de suite. Et on n'a pas. Ils ont essayé de trouver en Inde la gélule, ils ne l'ont jamais trouvé, mais nous, on la connaît depuis très longtemps, c'est l'exercice fixe et l'adaptation. Alors là, c'est une étude qu'on vient de faire. Et vous savez que quand vous faites un effort, eh bien, vous avez le shear stress, vous avez le débit sanguin qui augmente dans les vaisseaux, et cette pression au niveau du vaisseau fait qu'il y a du NO qui est vasodilatateur. Et normalement, la anosynthétase, elle se trouve que dans l'endothélium. Il se trouve que chez les sportifs, cette anosynthétase va migrer au niveau de la mitochondrie et va fabriquer d'INO au niveau de la mitochondrie. Et du coup, elle protège la mitochondrie contre l'ischémie cardiaque. Et c'est extrêmement important pour l'insuffisance cardiaque ischémique puisque ça va protéger le muscle contre l'ischémie. Évidemment, l'adaptation cardiaque n'est pas que l'exercice physique, n'est pas que les médicaments. Vous avez l'éducation thérapeutique, vous avez le conseil diététique, vous avez l'arrêt du tabac, le sévrage, etc. Alors, voici 2 cas vrais de chez nous. La patiente qui est à droite, elle arrive, elle n'est absolument pas autonome. Pourtant, elle a 80 ans. Le papy à côté, 80 ans. Même fraction d'éjection. Lui, il joue du basket et elle est à peine autonome. Alors, même âge, même fraction d'éjection. Parce qu'il y a un qu'on vient de finir sa réadaptation, il joue au basket. Il y a une qui vient d'arriver, elle marche même pas de façon autonome. Alors, est-ce que tout ça nous coûte plus cher? Non. Compte tenu de ce qu'elle coûte la réadaptation cardiaque à la société, à la sécurité sociale, eh bien, vous voyez qu'en fait, ça ne nous coûte pas beaucoup plus cher par rapport aux gains qu'on a. Alors, avec tout ce que je viens de vous dire, évidemment, regardez les recommandations. Les recommandations françaises, c'est un A. Les recommandations européennes, c'est pareil. Les recommandations qui viennent de sortir, ils disent même plus, ils ne parlent plus d'insuffisance cardiaque, ils parlent de toutes les cardiomyopathies. Il faut donc les réadapter et c'est toujours au grade. Les réadaptations américaines, c'est pareil. Alors, pourquoi ça ne marche pas? Alors qu'on a démontré 1000 fois que ça marche, alors que toutes les recommandations sont 1A. Pourquoi? Parce que c'est toujours plus simple de prendre un comprimé que faire un effort, surtout après le travail. Ça, c'est mon bouquin qui va sortir bientôt. Le deuxième, c'est l'adaptation cardiaque. Et ça, c'est notre congrès du Gers. Il nous a fait l'honneur d'être à Pau. Quelqu'un d'autre nous fera l'honneur d'être à Montpellier. Merci beaucoup pour votre attention. Normalement, en lecture, il n'y a pas de questions, normalement. Non, je ne prends pas.
Merci beaucoup, si Mohamed, c'était vraiment épatant. Et dommage que c'est vrai que c'est une partie du traitement de l'insuffisance cardiaque et même d'autres pathologies cardiovasculaires qui est toujours, c'est pas occulté, mais je crois délaissé. Et malgré tout ce qui a été du moins dit depuis des années, ça fait au moins une vingtaine d'années que j'assiste à nos congrès et bon, c'est vrai qu'il y a de l'inertie, il y a beaucoup d'inertie, peu d'investissement dans un domaine qui peut apporter, même en survie, vous avez démontré ça sur plusieurs points. Donc, pour vous faire plaisir, ça, c'est la photo de 2 greffés cardiaques qui ont commencé leur réadaptation. Donc, mais une autre question, par contre, par rapport, quelles sont les spécificités de la réadaptation du greffé cardiaque par rapport au long cardiaque?
Oui, le greffé cardiaque, il faut absolument qu'il ait une VO2. Parce que vous ne pouvez pas baser sur la fréquence cardiaque, je vous l'ai montré. La fréquence cardiaque, comme le cœur est dénervé, vous ne pouvez pas vous baser dessus. Donc, tu te bases sur le seuil anaérobie. Le seuil anaérobie, c'est quoi le seuil anaérobie? En fait, c'est le seuil quand vous marchez ou vous courez. Ben, vous allez utiliser votre oxygène. Et toute molécule d'oxygène va donner une molécule CO2.
Donc il y a un équilibre. À partir du moment où vous allez accélérer et que l'énergie par le système aérobie oxygène est dépassée, vous allez faire appel à votre système anaérobie. Et quand vous utilisez votre système anaérobie, le CO2 va dépasser le O2. Ce n'est plus un équilibre O2-CO2, il n'y a plus de CO2, et donc vous accélérez votre respiration. Et à partir du moment où vous accélérez votre respiration, c'est le seuil anaérobie. Vous passez d'une consommation aérobie à une consommation anaérobie. Et c'est ce seuil, vous prenez la fréquence cardiaque à ce seuil-là et vous allez réadapter votre patient à ce seuil-là, à la fréquence, au seuil. Ça, c'est pour le continu. Si vous voulez faire des fractionnés, il faut absolument que la fréquence cardiaque que vous utilisez soit supérieure à celle du seuil. Et plus votre seuil va s'approcher de votre pic de VO2, plus le patient va fabriquer du CO2, il va être fatigué. Et au moment où il arrive au pic de VO2, il doit s'arrêter parce qu'il a une acidose musculaire. Alors la VO2 max, il ne faut pas en parler, parce que la VO2 max n'existe que chez le sportif. Ça veut dire qu'en fait, quand il fait une VO2, il va y avoir un plateau au moins de quelques minutes. Or, tu remarqueras que tous les patients que tu fais, moi, toi, les malades, ils font un pic et ils descendent. Il n'y a pas de plateau. Et donc, on parle de pic de VO2. Et quand vous réadaptez votre patient, eh bien, vous allez déplacer votre seuil anaérobie. Ça veut dire que le patient va faire appel à son système anaérobie et donc plus de CO2 à éjecter plus tard. Et donc, il sera fatigué plus tard.
Merci, Mohamed, pour cette belle lecture. On ne peut pas s'empêcher de poser des questions. Moi, mon ressenti par rapport aux patients à qui on fait de la réadaptation, c'est l'amélioration spectaculaire de leur vie et tout. Bon, après, moi, je dirais qu'il y a deux évolutions possibles. Il y a des patients qui continuent à changer de leur mode de vie. Il y en a d'autres qui ne continuent pas. Et peut-être que c'est dommage aussi parce qu'ils reviennent un petit peu au même modèle. Donc, y a-t-il un accompagnement, par exemple, chez vous pour ces patients-là? Parce que nous, on les perd de vue après.
Alors, ta question est juste. Mais moi, je te pose une question. Si ton patient à qui tu donnes son bêta-bloquant, il l'arrête, le bêta-bloquant, ton traitement serait inefficace. C'est exactement pareil. Alors, ceux qui accrochent et qui commencent à faire une demi-heure tous les jours, tous les demi-jours, je peux te dire que ça devient drogue. Il ne peut plus s'arrêter tout seul. Ça, c'est la première chose. La deuxième chose, c'est qu'il est vrai que compte tenu de nombre d'insuffisances cardiaques chez nous ou chez vous ou ailleurs, il n'y a pas assez de centres pour les prendre. Ça, c'est une chose. Et la deuxième chose, c'est qu'on remarque chez nous, enfin en France, 10% des insuffisants cardiaques qui doivent bénéficier d'une adaptation iront. Alors, ce qu'on a fait actuellement, donc il y a la Sécurité sociale qui a développé 4 projets. Nous, on a pris 4 projets. Et ces 4 projets, donc, on les a faits. Et donc, aux Européennes, on va en parler parce que toutes les études sont positives. C'est la téléréadaptation. La téléréadaptation, c'est que quand on prend un patient, on l'explore, on lui donne une application, il rentre chez lui, il fait son adaptation chez lui. Et quand il l'a fait chez lui, ça veut dire quoi? Ça veut dire qu'il peut faire les efforts quand il veut. Donc, il n'est pas limité par le temps de telle heure à telle heure. Non, il peut le faire à minuit, il peut le faire à temps. Donc, il y a vraiment... il y a, comment dire, il y a une compliance. Donc, il peut faire ça quand il veut. Donc, il y a 4 projets. Le premier, c'est qu'il fait une semaine d'adaptation, il a son programme, il rentre chez lui avec une application. Le deuxième, il fait une semaine en centre et une semaine chez lui. Le troisième, c'est en Corse, parce que les distances sont extrêmement importantes. Donc, ce qu'on fait, c'est qu'on fait une exploration dans un centre. Il continue à faire dans le centre le plus proche de chez lui. Le quatrième, c'est la question qu'il vient me poser. Comment accompagner les patients pour qu'ils puissent continuer? Et donc, on a les APA, ce qu'on appelle les APA, c'est en fait des professeurs sportifs de sport à la pathologie. Donc, eux, accompagnés d'un psychologue, d'une diététicienne, continuent à accompagner le patient à long terme jusqu'à ce qu'il accroche. Mais c'est vrai que si tu veux, c'est toujours compliqué, mais si tu veux, un médicament, quand tu l'arrêtes, il n'est plus efficace. Pareil pour le sport.
Merci. Question, Dr. Abdeslam.
Moi, j'ai deux questions rapides. C'était vraiment un topo magnifique, comme d'habitude, Siranem. La première question, on entend de plus en plus parler de contre-pulsion externe. La contre-pulsion externe, c'est des compressions au moment de la diastole, et comme un ballon de contre-pulsion, mais ça se met par des brassards au niveau des jambes. Beaucoup de gens parlent d'un effet bénéfique, réadaptation-like. Est-ce que vous êtes d'accord ou pas? Est-ce que vous avez l'expérience de ça? Ma deuxième question, c'est la stimulation externe. Est-ce que c'est l'équivalent d'un travail isométrique pour vous ou pas?
La première question, je n'ai aucune expérience, donc ça va être très simple. La deuxième question, la stimulation, tu veux dire par un flux électrique. J'ai parlé, c'est ce qu'on appelle l'électromyostimulation, nous. Donc l'électromyostimulation, effectivement, elle est efficace, mais elle est efficace quand le patient ne peut pas faire d'efforts actifs. Ça veut dire qu'il ne peut pas faire ça, il ne peut pas bouger. Donc, ces influx, il y a en complexe un petit appareil qu'on branche. Il faut absolument faire attention quand le patient il a un défibrillateur ou un pacemaker parce que vous risquez de perturber le PM. Et donc, il faut le faire pas dans l'axe du PM, il faut le faire un peu loin au niveau des jambes, par exemple. Et donc, tu as des influx que l'appareil va donner. Alors, il va faire, par exemple, pendant 5 minutes, des influx qui sont à haute fréquence et des influx à basse fréquence pendant 5 minutes, comme s'il faisait de l'intervalle training, mais en fait, c'est par des influx. Alors, c'est efficace uniquement chez les patients qui ne peuvent pas faire un effort actif. Maintenant, si le patient court et tu lui fais ça, aucun bénéfice. Et ce qui est démontré, c'est que ça augmente la VO2, ça améliore la qualité de vie et ça augmente le test de 6 minutes. Ça veut dire la capacité d'effort et la qualité de vie augmentent. Pour la mortalité, on n'a pas encore de données.
Alors, en fait, merci beaucoup, Dr. Hanem, pour cette belle lecture, en fait, qui montre bien la place de la réduction cardiaque en pathologie cardiaque, soit insuffisance cardiaque ou coronaire. En fait, j'ai un commentaire, une question. Pour le commentaire, professeur Moral, il a parlé d'inertie thérapeutique des médecins, des cardiologues ici en Tunisie. Moi, je dis oui, il y a de l'inertie, mais l'inertie est secondaire à l'absence, on va dire, des autorités de santé. Et ça fait 20 ans, même plus que 20 ans qu'on parle de l'attention cardiaque et de ses bienfaits. Vous avez bien montré l'étude économique qui montre bien que sur le plan économique de santé, donc il y a un gain. C'est moins cher que les médicaments, il y a une baisse de la mortalité, il y a une baisse des insuffisance cardiaque. Donc pourquoi pas démocratiser cette indication? Pourquoi pas, avec la sécurité sociale, assurer un remboursement clair? Et là, à Sfax, il y a un centre de réanimation cardiaque en privé, mais malheureusement, ils travaillent. Mais ils ne travaillent pas à plein régime parce qu'il y a pas mal de patients qui n'ont pas trop les moyens. S'il y a un montant, et là je pense qu'il y a Dr Abdeslam, président de la société tunisienne, peut-être avec le ministère, on peut jouer sur ce sujet. La question, en fait, c'est pas technique, c'est une question technique. Alors, quel est le plus fiable, en fait, si on va adresser quelqu'un pour une prescription de l'attention cardiaque? Est-ce que plutôt la formule de Carnoven, donc en tenant la fréquence cardiaque avec une preuve d'effort classique, ou plutôt l'épreuve d'effort cardio-respiratoire avec le pic, le SVA1 ou l'intersection de VO2 et VCO2. Donc, quelle technique vous plutôt recommandez?
Oui, alors d'abord, la formule de Carnoven, c'est pour l'endurance. Donc, ça ne touche pas du tout le fractionné. Hein. Et quand on lit, moi, je me suis amusé à sortir cet article de Carnoven. En fait, sa formule, elle était faite chez des étudiants en médecine. Aucun n'était malade. Ce n'était pas fait chez des malades. Et du coup, nous, on l'a refaite pour comparer si le patient est réadapté sous la formule de Carnoven ou en lui faisant une VO2 en tenant compte du seuil anaérobie. Eh bien, le 0,6, il est trop bas. Il faut surtout quand le patient est sous bêta-bloquant. Parce que si le patient est bêta-bloquant, amuse-toi à faire la formule de Carnoven avec un bêta-bloquant. Tu vas voir qu'en fait, il n'augmente pas beaucoup sa fréquence cardiaque. Du coup, quand il dit fréquence cardiaque maximalement fréquence de repos, ça ne représente pas grand-chose. Et donc, maintenant, surtout quand le patient est sous bêta-bloquant, ne pas utiliser 0,6, il faut utiliser 0,8 pour que tu augmentes un peu la fréquence cardiaque. Parce que nous, on n'utilise pas beaucoup. Hein. On n'utilise pas beaucoup. À la limite, fais une épreuve d'effort, tu prends la fréquence maximale du patient et tu vas leur adapter à 60% de sa fréquence maximale. C'est beaucoup mieux que la formule de Carbonène parce qu'elle est plus proche de la vérité. Et si tu veux le faire en fractionné, eh ben, tu prends 90% de la fréquence maximale à l'épreuve d'effort pendant 2 minutes, puis 2 minutes moins, puis 2 minutes, etc. etc. Bien sûr, parce qu'elle ne dépend de rien. Le restant, ça dépend de beaucoup de paramètres. Parce que même la fréquence cardiaque, elle dépend si le patient il est ému, s'il est fatigué, s'il est...
Alors juste, ma question elle est d'ordre pratique. Je voulais poser la question à Siranem. À quel délai, à partir de quelle date, un malade greffé, surtout un malade greffé ou un malade porteur d'un DEF, peut-il joindre à un centre de réadaptation cardiaque? Quand est-ce qu'il doit démarrer sa réadaptation? Un greffé ou surtout les DEF?
Oui, le DEF, ça pose pas de problème. Le BEF, tu peux l'utiliser assez rapidement, mais il faut tout simplement, d'abord, il faut quand même que tu mettes la fréquence inférieure à celle qui va déclencher.
Moins 10.
Parce que sinon, il va décharger tout le temps. Donc, tu fais moins de 10 à peu près de la fréquence de déclenchement du DEF. Donc, ça ne pose pas de problème. Sauf la cicatrice, évidemment, il faut faire attention.
La cicatrice, on peut démarrer la...
Ouais. Certains mouvements, il faut les éviter parce qu'il y a des sondes, etc. Ça, c'est... Pour le greffé, c'est très long. Pour le greffé, sa VO2, on l'a fait 3 mois après. Au début, il faut vraiment faire du light. Ça veut dire qu'en fait, il faut faire de la musculation, tout ce qui est en résistance. Et après, quand tu le mets sur vélo, c'est très peu. Au bout de quelques mois, tu le fais une VO2 et tu commences à l'adapter. Et le résultat chez le greffé, le bon résultat, tu l'auras 6 mois après. Pas avant. Regarde, quand je t'ai montré là les résultats, c'était à 6 mois.
C'est-à-dire le contrôle par la VO2, on le fait 6 mois après, même si on commence à prendre...
on fait la VO2 3 mois après. Mais 6 mois après, on peut avoir le résultat bénéfique.
Et la durée de sa réadaptation pour le greffé?
Très long.
À raison de 5 séances ou 3 séances par semaine?
Ça dépend. Si tu fais 3, il faut plus de temps, c'est tout. Mais l'insuffisance cardiaque aussi. Hein.
Oui.
L'insuffisance cardiaque, normalement, c'est pas moins de 8 semaines pour qu'il s'améliore.
Exactement.
C'est pas 4 semaines comme le coronarien. Par contre, le coronarien, tu n'as pas besoin de VO2, le coronarien.
L'insuffisance cardiaque, c'est 30 séances et plus pour avoir déjà l'amélioration.
Il faut beaucoup plus pour l'insuffisance cardiaque et encore plus pour le greffé. Le greffé, il faut longtemps après.
Vous voyez, on va passer la soirée. La dernière question.
Alors, merci, Dr Ghanem, pour cette excellente lecture, comme d'habitude. Bienvenue parmi nous aussi. Et là, réellement, en tant que membre de la Société tunisienne de cardiologie, ici présents, tous les experts, mais aussi les gens influents, je pense, ma question est très pratique. On est réellement tous convaincus de la réadaptation cardiaque. Mais après, qu'en est-il réellement du réemboursement, de la prise en charge? On en a travaillé sur un parcours de soins qui va être publié, je pense, dans quelques jours. Et là, avec les instances d'INEAS, que faire de plus pour avancer tout en étant pratique?
Alors, nous, on se base pour imposer... Pardon.
C'est le combat de votre vie, là.
Oui, c'est le combat. En fait, on se base sur montrer les bienfaits. Nous, médecins, on s'occupe du patient. Ceux qui nous gouvernent s'occupent de l'argent. Il faut leur montrer qu'ils gagnent de l'argent.
On a bien démontré dans les études qu'il y a réellement un gain. On a
alors,
un gain sur la survie, un gain sur la qualité de vie. Qui dit qualité de vie, c'est un gain d'argent.
Alors c'est le gouvernant qu'il faut changer. Ils sont sourds.
Ça sort du pouvoir de la société.
Oui, ça sort du pouvoir de la société, mais écoute, moi, j'ai eu des patients, honnêtement, j'ai soigné des ministres, des présidents, même secrétaire général de l'ONU une fois. C'est quand ils sont malades. Quand ils sont malades. Moi, je me souviens, j'étais interne. Et j'ai reçu le mari de notre directrice. Il avait un problème, un infarctus. J'ai couru voir le professeur Lenné. Je dis, écoutez, j'ai le mari de notre directrice et j'ai pas de place. J'ai que de place j'ai une chambre où il y a 3 lits. J'ai pas une chambre, un lit tout seul. Et il me dit, justement, c'est là où il faut le mettre. Comme ça, sa femme, directrice, verra ce que c'est qu'un malade dans 3 lits. Et effectivement, elle a compris que 3 lits, c'est quand même inconfortable pour les patients, et elle a fait des chambres à 1 lit. Donc, nos gouvernants, quand ils sont malades, ils sentent bien les choses, ils changent.
Voilà,
Juste
voilà
une
la réponse.
dernière...
Il faut qu'il soit malade et qu'il reste malade.
D'accord.
Comme ça, c'est
Juste une dernière aussi question par rapport aux patients oncologiques et qui développent autant de pathologies cardiaques. Est-ce qu'il y a là des précautions particulières? Non.
Moi, je suis allé à Genève une fois, il y a 10 ans. Et il y a quelqu'un, je crois Raymond, il s'appelle Raymond Casse, il a présenté une communication sur le cancer du sein chez la femme après et avant la réadaptation. Eh bien, toutes les patientes améliorent leur survie par la réadaptation cardiaque. Donc l'oncologie ou l'insuffisance cardiaque, c'est encore 2 choses qui doivent nous pousser à en faire, puisque dans les 2 cas, la réadaptation est efficace. Moi, je te parle de réadaptation, je t'assure que je fais 3 jours par semaine que du caté. Je fais très peu de réadaptation, je suis un théoricien de la réadaptation. J'en fais pas beaucoup. Et j'étais convaincu dès le départ, que nos patients ne sont pas bien pris en charge quand on s'en occupe, quand on les dilate et on les lâche dans la nature avec tous les facteurs de risque imaginables qu'on connaît. Ils reviennent assez vite d'ailleurs. Et donc, si tu veux, nos cardiologues d'intervention qui sont là, à mon avis, ils sont convaincus, ils sont là, ils sont tous cardiologues. C'est marrant, il n'y a que des cardiologues interventionnels dans la salle. Et ils sont tous convaincus, mais ceux qui nous gouvernent ne sont pas très convaincus. Tu sais pourquoi ceux qui nous gouvernent ne sont pas convaincus? Moi, j'ai fait une controverse avec Broustet, à la Société de cardio. Et lui, il fait de l'adaptation, moi, je défends l'angioplastie. Tu sais ce qu'il m'a dit? Un mot que je l'ai vu là, il y a 87 ans. Il me dit, Mohamed, toi, avec l'angioplastie, tu plantes des orangers et tu manges des oranges dans ta vie. Moi, je plante des chênes pour les générations futures. Et si tu veux, en fait, ceux qui nous gouvernent partout dans le monde, ce qui les intéresse, c'est maintenant. Après, il n'est plus là. Le ministre n'est plus ministre, le président n'est plus président, c'est fini. Ce qui l'intéresse, c'est maintenant. Or, toute la prévention, toute la adaptation, c'est dans le futur que tu vas. Et lui, ça ne lui sert à rien. Si c'est dans 10 ans, ce qu'il veut, c'est maintenant. Là, tu prends la cigarette. On peut arrêter le tabac tout de suite, on peut l'augmenter à 40 €. Et le problème, c'est que le tabac rapporte tout de suite l'argent maintenant, mais si tu arrêtes le tabac, eh ben, les gens qui vont mourir, ils vont mourir bien après. Donc le ministre ou le président, il est déjà parti. Donc ce qu'ils veulent, c'est maintenant. Et c'est pour cela notre problème je parle de la France, je ne parle pas de la Tunisie, je ne connais pas la Tunisie. Mais en France, c'est comme ça que ça se passe. Ce qu'ils veulent, c'est le résultat tout de suite. Il faut l'argent tout de suite. L'argent, après, s'en occupe pas, il n'est plus là, lui.
Madame Bourziel.
Oui, juste une phrase. Mohamed, tu prêches des convaincus qui ont le triste et frustrant sentiment d'être des convaincus.
Voilà.
Sur ces mots sages et vrais, d'accord, nous devons donc clôturer donc, cette belle session. Merci beaucoup aussi, Mohamed. C'était très instructif et très interactif. Et en fin de compte, on ne regrette pas d'être resté au départ. Voilà, jusqu'à maintenant. Merci beaucoup.
En tout cas, merci pour votre invitation. Je suis désolé d'arriver un peu en retard, j'étais un peu partout. J'ai évité quand même le pape. J'ai évité le roi, parce qu'il y a un qui était à Marseille et l'autre qui était... Et je n'ai pas évité votre congrès.